Check one, one, two. Hey, test. Check one, two, two. Hey, hey, check, check. Check one, two, 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 two. Yeah. Hey, yeah, yeah. Check, check.
Hello, check, test, hello, check, check, testing level बढ़ा दो. Hello, check, testing, hello, check, check, hello, check. लाइन इनका मेरा खोलो, मेरा बढ़ाओ ना बस केवल. हेलो, चेक, चेक, हेलो. माइक का देखो यहाँ से बोल. हेलो, हेलो, चेक, चेक, चेक. स्पीकर खोलना है इसी माइक का, इसी माइक का स्पीकर खोलो. हेलो, चेक, टेस्ट, टेस्टिंग, हेलो, चेक, टेस्टिंग. ये सर पे बज रहा है इसलिए तुझे जा रहा है. हेलो, चेक, 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 हेलो, हेलो, चेक, चेक, हेलो, चेक, चेक, टेस्टिंग, हेलो, हेलो, चेक, check, hello, hello, check, check, hello, hello, check, hello, check, check, hello, check, check, hello, check, check, hello, check, test, hello.
Fortunately, over the years, it has been getting better and better, and one of the most sought after conferences in this part of the country as far as science is concerned. So, last 11 years, we started early days with Cardiff University as our partners. We were their sole partner in this country. We had Professor Colin, Professor Mohammed, Dr. Neera as partner of this program. Dr. Mohammed, he still remains our organizing committee, core committee member. And last 4 years, we have tied up with ASD, that is Arabian Association for Study of Diabetes and Metabolism, with Professor Inash Sheltout as chair, and she's also part of this organizing committee. This year, for the first time, as I briefed last evening also, ACE we have been pursuing, and they have made a APEC board, that is Asia Pacific Board of American College of Clinical Endocrinology, with Professor Shashank as chair, me, Dr. Bansi, Dr. Amit, Dr. Rakesh Sai, and Dr. Shalini as board members. So it is for the first time, because time was very less, we had a virtual participation from ACE in the evening yesterday. This program we started at 8:30 and went on till 11 p.m. and it was a very appreciated program. We have been having a virtual program with ASD because it is difficult to have everyone part of a physical conference these days. So Friday we conducted a 3 hours international symposium with ASD, followed by four speakers from US, Professor uh, Dandona, Professor Adi Mehta. He finished at 8:45 p.m. in the night. Dr. Antonio and Dr. Colin. And just to share with you, when we closed, we had close to 940, 950 delegates still logged in at 8:45 p.m. Yesterday, we had again a very thought-provoking symposium with DIPSI, because Professor Sheshai, our mentor, it is difficult for him to travel so frequently. So we again organized this symposium virtually 3 to 6 p.m. Again, it went very well, and it was appreciated by one and all. So today we are here, and we now are about to start this physical meeting, that is 11 Cmre International Symposium, and this is a day-long program, and trust me, it is an excellent scientific agenda which we have drafted, and you will really enjoy as the day progresses. So with that initial remarks, we will have a formal inauguration at 1 o'clock, and with dignitaries Professor Das, Dr. Professor Anup Mishra delivering their orations, and key addresses by Professor Mohammed and Professor Inash Sheltout. So I'll request now Dr. Vipul to please come and start the proceedings for this scientific program. Dr. Vipul.
So good morning one and all, and welcome to the third day of CMRE, and this time it is truly international with multiple international collaboration. We are in MMS Ahuja Hall on Sunday, day 3, which is physical, and to start first symposium in which we have speakers like Dr. Neeta Deshpande, Dr. Ranjit Unnikrishnan, and Dr. Sanjay Agrawal sir, I would like to invite Professor Vinod Kumar sir from New Delhi and Dr. Rohit Kapoor sir from Amritsar to chair this important session. Can we have a big round of applause? Over to you, sir.
Stick to the time. So I invite Dr. Neeta Deshpande. The title of talk is Obesity Management, the Key to Treating Type 2 Diabetes Effectively. Dr. Pandit, Dr. Deshpande, please.
Thank you, Chairpersons. A very good morning to all of you. And at the outset, I would like to thank Dr. Rajiv Chawla and my other friend, Dr. Shalini Jaggi, for having invited me here to this prestigious conference to speak on a topic that has become quite a debate in the last few years, 1 or 2 years, after we realized that obesity could actually, weight loss could actually reverse or at least remit diabetes for some time. So, is it really the key in all cases or in some cases? That is what we are going to explore and see whether obesity management alone is to be considered the primary target in treating type 2 diabetes rather than just glycemia. That means if one loses weight, does the glycemia take care of itself? That is what we want to look at. So, I need to advance my slides. 1 minute. Okay. Yeah. Thank you. So we all know that obesity by itself is a multifactorial relapsing chronic disease. We have been struggling very hard to make it basically we are calling it a disease, but we have not really succeeded, at least in our country yet, for people to believe that it is a disease. And we also know that obesity is the mother of all diseases. So you have uh, metabolic diseases, cardiovascular diseases, mechanical problems such as obstructive sleep apnea, etc., and mental health problems because of obesity. The other thing we also know is that over the last few decades, the global prevalence of obesity has really gone very far ahead, almost become like a pandemic. And importantly, it mirrors the escalating rates of type 2 diabetes. What does this mean? If two pandemics are running in parallel and pathophysiologically they are connected, you really need to find out which is the chicken and which is the egg, which came first. So that's what we are going to be dealing with. So this parallel trajectory itself suggests a cause and effect relationship between obesity and type 2 diabetes. So if you remove the cause, then you are treating the disease, and that is the paradigm that we're going to explore today. So weight loss, we now know you have had several studies. You've had the direct study. We have had our own studies in our own center, which we have published, where weight loss is known to reverse many underlying metabolic abnormalities, not just diabetes. We've seen hypertension reversing. We have seen fatty liver reversing. So several of these are reversing with just weight loss. And of course, there's improved glucose control as well. All of us know the direct trial where loss of 15% or more of body weight can have a disease modifying effect in people with type 2 diabetes. I need say no anymore. An outcome that is not attainable by any other glucose lowering intervention. Please mark my words. No glucose lowering intervention, whatever you use, will cause 15% weight loss and will also have glycemia that is restored or reversed. So weight loss in this population exerts benefits that extend beyond glycemic control to improve the risk factor for cardiometabolic disease. So with this introduction, I'm now going to explore some data and some more concepts of why we think that obesity management is the key to attaining good glycemic control. So if you look at the cause and effect, you can see here that obesity is the root cause of type 2 diabetes in most diseases. So here you can see, let me explore the connection between weight gain and type 2 diabetes risk. That means even before you get diabetes, how obesity serves as a risk. Second, in the management itself. So obesity management and prevention, and then obesity management, and then what happens to remission. So we know now that extensive research indicates that even modest weight gain elevates the risk of type 2 diabetes. So here in itself, you realize that you gain weight, you are at a high risk of getting type 2 diabetes, and that is why obesity is the root cause, and hence the treatment part also follows. Secondly, the obesity management and prevention part. This perspective finds robust support in numerous studies. where preventive effects of obesity management on the onset of type 2 diabetes. This is what we are seeing. And once you know that weight management can prevent diabetes, then we go to the beyond prevention part. So obesity has best shown, obesity management has shown that individuals with type 2 diabetes, if they lose weight, they can remit diabetes, they can prevent microvascular complications, attenuate their cardiovascular risk factors, renal and heart failure. So I have established here that obesity is a root cause for type 2 diabetes. So, what are these mechanisms that link obesity to type 2 diabetes? I don't have to tell this august audience what this means. This is nothing but the twin cycle hypothesis, secretion of pro inflammatory adipokines. As you put on weight, the fat is not sitting as an innocent bystander, it is toxic. It is very, very dynamic, and tumor necrosis factor alpha, interleukin 6, etc., are elaborated from this adipose tissue, and these interfere with insulin signaling pathways, leading to insulin resistance. And primarily, when this happens at the liver cycle starts, and what you have is insulin resistance. Then, what happens is there is compensatory hyperinsulinemia, and this promotes the deposition of ectopic fat in the liver that further accentuates resistance. And when this happens, finally spills over into the blood, what you're going to get is accumulation of fat in the pancreas as well, and this leads to increased fat distribution to all other tissues as well, and then you have insulin deficiency. So this is how the twin cycle hypothesis explains how caloric excess and obesity ultimately leads to inflammation, the liver cycle, the pancreas cycle, ectopic fat accumulation, and the onset of type 2 diabetes. So what does this mean? This means that if you were to reverse this cycle and put a person into negative balance, then you would be able to, if not completely reverse diabetes, but at least have better control. Negative calorie balance can only happen with lifestyle modification and other means also, and what you get with that is weight loss. So weight loss here I'm showing you is the key to actually better glycemic control. And you can see the complex ways in which obesity contributes to type 2 diabetes, how obesity untreated can worsen diabetes. I need not go into all of these details, but you can see when there is fat accumulation, what happens. I already told you what happens to the inflammation. I already told you what happens to the adipokines. So this is a graphic representation of how inflammation in the fat cells, how ectopic fat deposition in the liver, all of these can ultimately lead to insulin resistance, especially at the level of the liver and muscle, and insulin deficiency that happens because of pancreatic fat accumulation. So obesity has a huge role to play in the pathogenesis of type 2 diabetes. So it is intuitive to think that treating weight or creating weight loss can reverse all these problems. And then obesity in turn can cause all these different problems. So it's not just diabetes that occurs because of weight, but you will also have dyslipidemia, stroke, sleep apnea, NAFLD, hypertension, coronary artery disease. All of these things will ensue with obesity. So when you treat obesity in a person with type 2 diabetes, not only are you treating type 2 diabetes and glycemia, but you are getting an entire metabolic control because of that weight loss. So it is holistic to treat obesity, create weight loss, and treat glycemia as well at the same time. So now I put forth before you this very elegant paper from the Lancet, where it talks about a weight-centric approach on the left side versus a glucocentric approach on the right side. So, if you treat obesity, what you're actually doing is you are doing an intervention that is upstream, which means you're going to the root cause of the disease. Whereas if you go to the downstream approach where you're only treating glucose, you are not getting a complete metabolic control. You will get a complete metabolic control if you intervene at the root. That's called upstream intervention. That means you are treating obesity and adiposopathy. So you are getting all those other benefits, like you are treating NAFLD, you're treating osteoarthritis, you're treating obstructive sleep apnea, etc., etc. Whereas if you do a downstream approach, you're only taking care of some of the microvascular and macrovascular complications, because without losing weight also you can get good glycemia. We have those drugs today, but you may not get all the benefits that you're seeing with an upstream approach. So that is the most important part for you to understand here. Now, this is the disease continuum for weight related diabetes. There are a few cases of type 2 diabetes which may not be weight related. I'm not talking about those, but majority of them are weight related. And if you look at the continuum over here, you can see that on the one hand you have beta cell function, you have adiposopathy that is continuously increasing. So you can see obesity right in the center there. And if you take care of that obesity, look at what you are getting. You are treating pre-diabetes, you're treating diabetes. So getting pre-diabetes and diabetes is a continuum in the saga of obesity. So obesity is so huge, it's an entire umbrella under which pre-diabetes and diabetes may be there somewhere in between. So if you're not treating obesity and only treating glycemia, then you are treating the entire metabolism piecemeal, just piecemeal. So if you're looking to prevent comorbidities, if you're looking for complications, pre-diabetes, everything, you have to view it as a disease continuum, and you need to remember that. So now we talk about lifestyle intervention for type 2 diabetes prevention. I'm talking about prevention, and they were randomly assigned to intervention or control group. And the results showed that even a modest weight loss reduced the risk of type 2 diabetes by 58% in high risk individuals, which is phenomenal. So here again, weight loss can prevent type 2 diabetes. Then we know about the DPP. It involved about 3,000 high risk subjects with diverse backgrounds, and they had either intensive lifestyle intervention or metformin or placebo. We all know that. And we know that an average weight loss of 5.6 kgs at 2.8 years again had a 58% relative risk reduction. And then the DPPOS. So everywhere, and this there was a follow-up as well. So everywhere you know that you intervene, lifestyle, weight loss, and you can prevent diabetes. Then you can also gain this by bariatric surgery. So the means of reducing weight are many. So lifestyle intervention is there. Swedish obesity study was there where more than 4,000 of them were there. And the group that underwent bariatric surgery exhibited 16% weight loss over 10 years, in contrast to the control group. And more strikingly, very importantly for my talk here, the incidence of type 2 diabetes in the surgery group was only 7%, while the control group, it was a significantly higher incidence of 24%. There is a long-term impact also. There was a study that analyzed the same study in which 1,600 patients with obesity treated with metabolic surgery were matched with controls with obesity. At 15 years, I'm talking here about the durability, the incidence rates of type 2 diabetes in the control group was approximately 4 times higher. So those who had lost weight definitely could prevent diabetes, and therefore weight loss is a target for prevention. Now, these are randomized controlled trials with a follow-up duration of at least 2 years, where bariatric surgery versus current treatment. Now, why have I compared this? Not to tell you which is better, but to tell you that higher the weight loss, better are going to be your outcomes. And we all know that bariatric surgery does give higher weight loss until and unless we start getting the dual agonists and triple agonists very easily. Once that happens, then yes, maybe we will reach this one as well. And you can see I just direct you to the last point where total body weight loss is important. And you can see here that, of course, the current, when this study was done, as against the current medical treatment, you can see that the weight losses are very high and the proportion reaching glycemic target also is proportionately higher in those who lost more weight, in this case with bariatric surgery. So then obesity treatment and glycemic control. So you have all these four studies that are there, and herein I'm going to tell you, and look at what happens. The chairperson sir and me were talking about technology, and look at what happened when I generated my slides in AI. This woman has a beard. So I just it was a very quirky thing, and I didn't remove it because just to tell you what AI can do to us. So obesity treatment and glycemic control. So you have the look ahead study where you had more than 5,000 subjects who had overweight, obesity, type 2 diabetes. They were randomly assigned to intensive lifestyle intervention and usual care to investigate the effects of intentional weight loss on cardiovascular disease. And we found here, of course, we know that patients in the intensive lifestyle group had a higher likelihood of achieving diabetes remission. I don't have to tell you anything about the direct trial where you had at the end of 1 year, you had 46% remission in those who had lost more than 15%. And at the end of 2 years, it was 36%. At the end of 5 years, it was only 13%, no doubt, but it was there. So if you have weight loss and if you can maintain it, then yes, you have a chance that your glycemic control is going to be better. And those who enjoyed remission at least for 5 years, they may have relapsed, but I'm sure they came back stronger and not as bad as when they started out with the program, the diadem one. So these are all the studies which tell you the same thing. You treat obesity, you get glycemic control. We have anti-obesity medications. We all know that for management. So you have GLP-1 receptors, you have tirzepatide, you have SGLT2 inhibitors. We all know the outcomes of all these studies, but these are anti-obesity medications that you use for better glycemic control. Why better glycemic control? Again, because of weight loss. So these are the common, this is a very interesting slide which tells you, especially for counseling to your patient, there are people who lose a lot of weight with lifestyle modification, either with drugs or anything. But remember that any substantial body weight loss by any means, even cancer, you will have all these problems. You will have constipation, you will have hair loss, because everyone talks about hair loss. Yes, when there is a lot of, it's going to happen, and loose skin, etc., etc. And this is my last slide, and it's a very interesting slide. This is proposed primary and secondary treatment goals by phenotype. Now, we all know Dr. Ranjit is here, and from their center, there are different phenotypes of type 2 diabetes itself. So, if you can categorize them into adiposity-related diabetes, diabetes with cardiovascular disease, and isolated hyperglycemia, this was published in 2021, then maybe you could have a tailor-made treatment for these people. So adiposity related diabetes, where the primary driver is insulin resistance, the approximate prevalence is 40 to 70%. So at least every second patient is going to be in this category. So which means that obesity treatment is very important. Maybe for the last one, it may not be very important, but at least 40 to 70%, and it is weight centric treatment for this first category, as you can see here very well. So anti-obesity agents or anything that you do for this particular group. So that is the important part. So these are my conclusions. Obesity is multifactorial. It is the root cause of type 2 diabetes. Obesity centric treatment approach with sustained weight loss is important. It's the key driver, and it may also serve as a useful intervention in established diabetes. Finally, obesity should be prevented or treated to prevent or treat type 2 diabetes and its complications. So thank you very much.
Thank you, Mrs. Pandey. And we will have the question and answer at the end of all the three presentations. And I would now invite the next speaker, Dr. Ranjit Unikrishnan. May I have?
Let me introduce. I have
Okay.
got introduced.
Okay, you got this.
Yeah, yeah. Now or at the end? Dr. Jeep, what do you say?
Dr. Chawla, discussion will be in the end.
I'll take the questions now because I may have to leave.
You have to go.
You have to go. Okay.
So this is open. I think it's a very important link between the obesity and type 2 diabetes has been illustrated. Particularly, I was interested in the treatment goals according to the phenotype, and I think something very important to emphasize. So this is open to discussion. Any question, please come over to the mic and have your question.
Thank you.
Please have the mic. This is on your left side.
If you take away the hedonic signals, with every anti-obesity drug, we've seen some amount of depression, suicidal. So in your center, when you treat obesity, have you seen the mental health, and do you have a questionnaire?
Yes.
Or can you tell us data about mental health age-wise, adolescents and...
Absolutely. That's a very relevant question. Thank you, Meena, for that. Mental health, especially in people who have had obesity for a very long time, can be very fragile. So we do have a depression questionnaire that we use, and if we find that they are depressed even slightly or clinically, then we do ask them to undergo therapy before they even embark on the diet. I don't even start lifestyle modification for them till these issues are sorted out, because the adherence is an issue when they are in that kind of a depression. Good counseling, even without depression, is the key. So I always feel that obesity treatment in today's day or weight loss journeys are spiritual journeys more than anything else. The reason for that, and I say this with confidence, because unless their mind is made up, unless positive reinforcement is given to them, and they realize that they are not failing, and this can be a genetic problem, this can be a homeostatic disruption problem, then when they realize that, they are much better.
Just request you to introduce the next speaker. Thank you very much, and we come to the next talk, and I will request co-chair.
Just wait, there's another question.
When it comes to weight loss, are we looking constantly at the insulin levels, and what are the insulin levels that we are aiming for in Indian patients?
Yeah, so if it's a known case of type 2 diabetes, there's absolutely no role for doing any insulin levels or anything, because we don't know in what part of the continuum they are. Are they at hyperinsulinemia compensated, or are they at insulin deficiency? So known case of type 2 diabetes, no. Whereas if you're trying to prevent diabetes and you are looking at weight loss, we do insulin levels. At least at my center, we're doing insulin levels and checking out the glucose and looking at the HOMA-IR. Not that HOMA-IR is extremely accurate, but it gives you something to go by. And at the end of 3 months after the weight loss, we do find the HOMA-IR has come down. So to that extent, yes. But in a known case of type 2 diabetes, which you're trying to either remit or control better because with weight loss, we don't do insulin levels. Of course, we do the inflammatory markers as well.
But do you think in the 3 months' time the HOMA-IR will come down?
Yes.
I mean, because it depends upon what's the percentage of the weight loss.
Yes.
It exponential is HOMA-IR reduction with the percentage of weight loss. Because somebody is not reducing weight in the 3 months' time,
Yes.
then we don't recommend HOMA-IR so quickly in 3 months'
I
time.
always find a better marker to be a fatty liver.
Yeah, and secondly, single value of
Rather than
HOMA-IR
actually
sometimes.
doing insulin levels, what I do
Okay.
at first month and third month is I do a simple ultrasound at least and look at the fatty liver. If the grade 3 fatty liver has gone down to grade 1, I know the insulin resistance has improved, and that is what we have been doing.
Rather ultrasound, rather fibroscan will be a really better
Fibroscan
way.
is ideal, it's
Definitely will
expensive,
guide better
and it's
way.
not available at every center, so
Definitely,
that's the
because
problem. Yeah.
thank you very much, Dr. Neeta, because from glucose-centric to weight-centric approach, and that's really fantastic, brilliant. So I would like to invite Dr. Ranji for the next lecture. It's a microbiome in diabetes, therapeutic implications. Dr. Ranjit is Vice Chairman and Consultant Diabetologist, Dr. Mohan's Diabetes Specialist Center, Chennai. He has been conferred various fellowships like FR, CPFS, CPFS, CPFS. He is the recipient of Best Doctor Award by the Tamil Nadu Dr. MGR Medical University, Then Dr. Selo Memorial Lectureship in Experimental Medicine by API. He's contributed 235 publications in peer-reviewed national and international journals and delivered lectures at national and international conferences. So he's already very famous. Yeah.
Thank you,
Thank
sir.
you, Dr. Ranjit.
Thank you for your kind introduction, sir. Thank you, sir, and thanks to Shalini for inviting. It's always a pleasure to give a talk at CMR, either virtually or even better in person. So it's a very interesting topic and it's a very vast topic. I don't know how I'm going to do justice to it in 20 minutes. I've been asked to. Yeah. Can't hear me? Yeah. So,
Keep near yourself. Keep near to the
yeah. Can you hear me now? I think there are two and they probably are interfering with each other. Yeah. So I've been asked to speak on an important aspect of the gut microbiota, that is how it interacts and how it influences the therapy for diabetes. And by diabetes we mean type 2 diabetes, because really the role of microbiota in treatment of type 1 diabetes is not that significant. I don't have any conflicts of interest relevant to this particular subject. And to introduce the gut microbiota, there are 100 trillions of microorganisms in our gut, and the size of the genome is comparable to the human genome. That means there are almost as many, if not more of them than there is of us. So anything which affects the human genome, anything is totally dependent on what happens to the gut microbial genome. There are thousands of species belonging to various groups or phyla or genera. But what we find is that 95% of the total microbiota are constituted by these two particular groups, that is the Firmicutes and Bacteroidetes. The weight of the human microbiome is around 1.5 kilos, and it doesn't remain static from throughout your life. It changes from infancy to adulthood, but unless there is some major metabolic perturbation happening, the microbiome of an average adult remains more or less constant throughout his or her life. So what happens to the gut microbiota in diabetes? In type 1 diabetes, the main role of the gut microbiota probably is in the pathogenesis of the disease. We all heard of the hygiene hypothesis, which states that somebody who is raised in an atmosphere where they are not exposed to the normal microbes which a normal child is exposed to, they develop some degree of dysfunction of the immune system, a dysmodulation of the immune system, which makes them react rather abnormally to other insults which may develop like viral infection, thereby predisposing them to development of beta cell defect and type 1 diabetes. But in type 2 diabetes, most studies have shown, and this is a result from a meta-analysis which was published 4 or 5 years ago, most people with type 2 diabetes have what is known as a moderate degree of gut microbial dysbiosis. And there is also a decrease in the abundance of some of the organisms which produce butyrate. And we know butyrate is a short chain fatty acids, which is very important for maintaining the integrity of the intestinal epithelial tight junctions. And the butyrate and propionate and other such SCFAs are formed from the fiber that we consume by the action of the gut microbiota. So some of these microbes which actually produce the SCFAs are reduced in type 2 diabetes. Conversely, there is an increase in various opportunistic pathogens. So how does this lead to type 2 diabetes? Now, we are consuming an unhealthy diet, rich in saturated fat, poor in fiber, rich in refined cereals, and we develop gut microbial dysbiosis. So what happens here is that these microbes, these pathogenic microbes, they're predominantly gram-negative microbes. And we know that the cell wall of the gram-negative microbes contains what is known as a lipopolysaccharides. So there is increased production, elaboration of lipopolysaccharides in the intestine on one side. On the other side, there is also a decrease in production of protective factors such as butyrate, because butyrate producing bacteria decreased. So this leads to disruption of the intestinal tight junctions. And this means that the lipopolysaccharide, which is produced by these pathogenic bacteria, can now translocate into the systemic or portal circulations. And we know that once the lipopolysaccharide enters into the system, it can have lots of adverse effects with respect to production of pro-inflammatory cytokines, development of insulin resistance, metabolic syndrome, diabetes, obesity, and type 2 diabetes. So this is what is known as the inflammatory hypothesis of type 2 diabetes pathogenesis. So how do the microbiota influence your anti-diabetic therapy? You can think of it in two ways. We have heard from the previous speaker how losing weight by various means can help in amelioration of type 2 diabetes or even prevention of type 2 diabetes. So when we go for a healthy diet, when we lose weight, of course, all these good things happen. Your glycemic control improves, insulin sensitivity also improves, but you can also improve your gut microbiota by reducing the quantity of saturated fat, by reducing the quantity of refined cereals, and by increasing the amount of dietary fiber. To an extent, you can modulate your gut microbiota such that the opportunistic pathogens come down and you get more of healthy microbes in your gut. The second thing, and I think what I'll spend slightly more time on, is what happens to the response to various anti-diabetic therapies that we might decide to give our patients. So the bioavailability, as well as the drug delivery, as well as the drug toxicity of various agents that we give for type 2 diabetes depends to a great extent on the composition of your gut microbiome. And this probably works through the action on the intestinal epithelial tight junctions. It may act through production of short chain fatty acids and through other mechanisms like bile acid production and so on, which we are not very sure about at the present time. So these are the mechanisms by which a medication can favorably alter the gut microbiome. It can favorably alter the composition of gut microbiome, helping in metabolic control of diabetes. The metabolism and efficacy of the drug may be in part dictated by the composition of the gut microbiota, because these are bacteria which can produce various enzymes which can act on the drug in various ways. It can inactivate the drug or even activate the drug, leading to changes in the drug activity. And the third thing is that the gastrointestinal tolerability of certain drugs may also be decided by the composition of the gut microbiome. So, metformin, this is the most commonly used anti-diabetic drug, and there is some evidence that, contrary to what we previously thought, the metformin may act at least partly through the gut. It's effective orally but not parenterally. It alters the enterohepatic circulation of bile acids. Now, bile acids are very anti-inflammatory substances. They act on the FXR receptor and lead to various protective anti-inflammatory effects. And this is a very interesting study which was published a few years ago in Diabetes Care, in which they looked at the effect of delayed release metformin. Now, this is not extended release metformin, this is delayed release metformin. Basically, delayed release metformin is something which does not get absorbed at all. It goes as it is to the distal intestine. And distal intestine, the large intestine, the colon is where the majority of gut microbiota reside. And it was shown in this particular study that delayed release metformin controls blood glucose better than extended release or immediate release. So the hypothesis being that probably it works through altering the gut microbiota. Of course, this is what happens to the composition of the gut microbiome. It alters the relative abundances of bacteroidetes and firmicutes, increases number of butyrate producers, strengthens the intestinal tight junctions, thereby decreasing endogenous endotoxemia. It increases the abundance of Akkermansia, lactobacillus, and the butyrate SCFA producers. And all in all, the microbiota of somebody with type 2 diabetes who is treated with metformin is similar to that of a non-diabetic individual rather than that of an untreated individual with type 2 diabetes. However, the flip side is that the gastrointestinal side effects of metformin may also be dictated by the composition of the gut microbiome. That is why some people tend not to tolerate metformin. This is one of the reasons. There are so many other reasons. One of the reasons may be some differences in the gut microbiome. What about alpha glucosidase inhibitors? This is another group of agents which works on the gastrointestinal tract, and we have evidence both from rodents and in human beings that they do tend to modify the gut microbiome favorably. For example, in mice, when we gave miglitol, this erysipelothriaceae and choreobacteriaceae were reduced. When you have high fat diet, these two particular genera increase, and this increase is reduced by administration of miglitol. Similarly, the use of acarbose increases the SCFA producing bacteria such as lactobacillus, bifidobacterium, faecalibacterium, and prevotella, and reduces the utilization of starch, that is, which is present in our cereals, by propionate producing bacteria. And voglibose has been shown to restore the ratio between bacteroides to firmicutes, which universally has shown to be deranged in type 2 diabetes. What about GLP-1 receptor agonist? Again, another group of drugs which has an action on the gastrointestinal tract. And liraglutide is said to reduce the bacterial diversity in high-fat diet-fed mice by enriching the firmicutes and depleting the bacteroidetes, proteobacteria, and actinobacteria. It enhances the abundance of several genera of bacteria associated with weight loss. So probably one of the mechanisms of weight loss produced by GLP-1 receptor agonist is by modulating the gut bacteria. And it depletes the obesity related bacteria, such as, I'm not even trying to pronounce this, you can all read. These were not there when we were studying microbiology. We were so easy for a streptococcus, staphylococcus. These sorts of things were not in there in those times. Anyway, it's good for the weight loss is all I'm trying to say. So what about DPP-4 inhibitors? As would be anticipated, the effects on microbiota are milder than those of GLP-1 receptor agonist. But they do have some effect. But the effect on the obesity-related microbiome is much less significant than that of GLP-1 receptor agonist. And that probably relates to the weight neutral property of DPP-4 inhibitors compared to the weight loss effects of GLP-1 receptor agonist. What about SGLT2 inhibitors? Again, we don't have too much of data about these agents as with respect to the gut microbiome. Dapagliflozin has been shown to decrease gut microbial diversity and the Firmicutes bacteroides ratio in mice. It has also been shown to increase the abundance of Akkermansia muciniphila, which is associated with favorable metabolic outcomes. But these are all studies in mice. We really don't have any large human data as to how SGLT2 inhibitors work on the gut microbiome. Theoretically, they can be expected to have some favorable effects. So this is a summary of what happens to the gut microbiota when you give various agents, include and probiotics. We'll talk about probiotics very soon. But the one thing to realize is that the effect of all these agents plus the effect of lifestyle modification on your microbiome also depends to a great extent on your baseline microbiome. And now people have started talking about enterotypes. Three enterotypes have been described: enterotype 1, 2, and 3, both all related with certain forms of diet and various implications. Enterotype 1 is supposed to be the unhealthy enterotype associated with so-called Western diet, and that is associated with obesity, metabolic syndrome, and type 2 diabetes. Enterotype 2 is a healthy enterotype, which is associated with the Mediterranean diet and is protective against type 2 diabetes and obesity. And enterotype 3 is a sort of mix which has not been linked to any particular diet pattern or to any therapeutic outcome. So the effect of these drugs on the microbiome may depend to a great deal on your baseline microbial composition. So the next part is what happens to the drug when you give it, when they give the drug, what does the microbiome do to it? Thus far we've been talking about the effect of drug on the microbiome, but what does the microbiome do to the drug? Now, there are so many enzymes which can be produced by these bacteria: beta glucuronidase, azoreductase, nitroductase, so on and so forth. And many of these drugs are susceptible to metabolism by these enzymes. So, the drug action may be modulated by the microbiome. They can happen in different ways. The microbiome can either make the drug more active by activating it or deconjugating it, or it can make the drug less active by deactivating it by inhibiting the absorption of the drug. So in either way, this probably underlies to a great extent the inter-individual variability in the drug response which we see in type 2 diabetes. We have been talking about all these phenotypes and so on and so forth. But more than all that, probably it is the what happens to the drug when it is given orally, what happens to it in the intestine, that is what depends on what decides the effect of the drug in a particular individual. So finally, I will talk a bit about probiotics. Now, what are probiotics? These are live microorganisms which, when administered in adequate amounts, confer a health benefit on the host. And it's found in foods such as yogurt, to a lesser extent in dahi or curd. And also it is available as dietary supplements. Any supermarket you go to, even in India nowadays, you get all these probiotics kept on a row, some of them in the fridge and some outside. So it's a big business, it's a big market. But there is some evidence as to the usefulness of these agents, as I will show you later on. So what are prebiotics? Now, prebiotics are non-digestible substances which selectively stimulate the growth of these favorable microorganisms. So to put it simply, the probiotics are the good guys and the prebiotics are the food for the good guys. which make the good guys grow at the expense of the bad guys. And prebiotics, again, they are available as dietary supplement, various polysaccharides, fructo-oligosaccharides, and so on are available. But it's also found in whole grains, bananas, onions, garlic, honey, and so on and so forth. There have been many clinical trials on probiotics in type 2 diabetes. I'm just giving you a selection of those. Interesting thing I found is the disproportionately large number of trials which have come from Iran. I don't know why that is so. Maybe it's changed now. This is a slightly old meta-analysis. It's all showing the same thing. And not very long-term studies. All of them are 8 weeks, 6 weeks, and so on and so forth. But when you look at the safety of these agents, I don't think we need to worry too much about the duration of treatment of these drugs. And what we find is that they do tend to have an effect on fasting plasma glucose, although the confidence intervals are wide. Not that much of an effect on HbA1c. Probably you need to be treating them for a longer period of time to get sort of benefit. A definite but small effect on insulin concentration. Insulin concentration comes down, and a similar small beneficial effect on the HOMA-IR. And this meta-analysis actually looked at 8 studies. And what they found was that the dietary interventions by giving the probiotics or prebiotics were associated with modulation of gut microbiota, which led to this particular meta-analysis, there was no improvement in FPG, fasting insulin, HOMA-IR, but HbA1c improved. So it all depends on the sort of intervention you do, whether it's just a dietary intervention or by giving a prebiotic or a probiotic, and the duration of interventions. The earlier meta-analysis did not show a benefit on HbA1c, probably it was too short. This one shows an effect on HbA1c. But this particular meta-analysis did not show an effect on inflammation, SCFA, and anthropometrics, probably indicating that the benefits act through some other mechanism. And what they have said is that there is a small but significant benefit to the use of prebiotics and probiotics in type 2 diabetes. They cannot replace medications, they cannot replace lifestyle modification. At the best, they can only act as an adjunct. What about safety? A huge meta-analysis, 622 trials. Of course, most of them were small in number. Even though trials are 622, the number of subjects were not great. And they have tried administering different genera of probiotics alone or in combination, but there was no difference in the relative risk of any adverse event. So basically telling you that these agents are considered to be safe. And most of the adverse events reported, as could be expected, were referable to the GIT and they were very short-lived. But there is one group of individuals in whom you have to be careful while giving these agents, especially the probiotics, because they are live microorganisms. And these are individuals who are immunocompromised. Although not in this particular meta-analysis, there have been case studies of fungemia and invasive bacteremia and sepsis in immunocompromised individuals who have been given the probiotics. So in this particular group, you have to be a bit careful. So I like to stop by saying that there is definite link between gut microbial dysbiosis and all the components of metabolic syndrome, including type 2 diabetes. There is a bidirectional relationship between the gut microbiome and anti-diabetic agents. The anti-diabetic agents affect the gut microbiome, preferably favorably, and the gut microbiome acts on the anti-diabetic agents, modulating their therapeutic efficacy and side effects. But longer term and largest trials are required to see whether this link can be elucidated and whether these agents can form another pillar in our armamentarium in the fight against type 2 diabetes. Thank you for your attention.
Thank you very much indeed, Dr. Unikrishnan. Beautiful talk. We'll have discussion at the end of the session. And I would now like to request the next speaker, a very well-known, Dr. Sanjay Agarwal. I don't know how to introduce him. I know him as the Secretary of RSSGI for last 6 years almost, and he is Director of the Aegis Clinic Diabetes Care, Head of the Department of Medicine and Diabetes at the world-famous Ruby Hall in Pune. And without much ado, I would request Dr. Agarwal to please deliver his talk.
Thank you very much for this kind introduction, sir. It's an honor to be introduced by you. And I would like to thank Rajiv as well as the entire team of CMRE and Shalini for giving me this opportunity to speak over here. I've been assigned to give this important topic on MASL, what is the hot, right out of the hot oven. That's how my topic actually reads. But there's been a whole bit of changes that have happened in the area of how we understand mast cell today. Now, if you just go back in prevalence and you look at the global prevalence of how mast cell is, and if you look at just the top line, the global prevalence of NAFLD in patients with diabetes is about 55 to 70%. The global prevalence of non-alcoholic steatohepatitis in patients with diabetes is 30 to 40%. And the global prevalence of fibrosis, that's F2 to F4, in patients with diabetes is about 12 to 20%. And I want you to focus on the right lower corner for Southeast Asia. You have a prevalence close to about 9 to 20%, depending on the region. And you see NAFLD in patients with diabetes in Southeast Asia close to about 58%. So it's fairly common that we see that patients with diabetes will tend to have some form of fatty liver disease. This is just sort of a cross-sectional statistics that we see. It's about 25% worldwide. In India, it's about 38%. In patients with metabolic disease, it's about 58%. But I draw your attention to the fact that almost 35% in the pediatric age group tends to have the presence of NAFL, which is kind of mirrors the epidemic of childhood obesity that we see now. So they're kind of going parallel hand to hand. We see more of childhood obesity and as well as you see presence of NAFL in these young children. So sometime back, the nomenclature for NAFL was changed to MSLD. And why was the need considered to make this change happen? Because a lot of people thought that NAFL is rather sort of stigmatizing when you say non-alcoholic, and this was in the Delphi consensus thought by about 61% of the participants. And fatty again was stigmatizing by about 66% people thought so. Now, when you use alcohol-related terms, so non-alcoholic related is less stigmatizing than non-alcohol related is less stigmatizing than non-alcoholic. And this was a terminology that was sort of favored by about 62%. And again, in the pediatric population, as we see, when you call somebody a fatty, then it's considered as stigmatizing. So given this fact, the whole bit of societies that came together in June 23 in the ESL conference, and they said we need to change this terminology. For one, it becomes, we need to see that how can be more acceptable. And two, when you say NAFLD, it does not reflect the metabolic abnormalities that come along with a fatty liver disease. So now the new classification, as recommended by Delphi consensus, is that you have steatotic liver disease, and then you have mast cell on one end, which can sort of convert to MASH, that's metabolic dysfunction associated steatotic liver disease, and then they can go on to steatohepatitis. The second one is, of course, mast cell with increased alcohol intake, which is MET-ALD. Now, depending on the proportion of what occurs, whether it's mast cell predominant or ALD predominant, you have the classification. The third category is, of course, alcohol-associated liver disease. The fourth is specific etiology, whether it's drug-induced or monogenic. And the last one is cryptogenic. So there's a whole bit of change that has happened in our understanding of how we now consider steatotic liver disease. Now, it is important that when you talk about mast cell, it's not just presence of steatotic liver disease. By definition, you call it steatotic liver disease when more than 5% of the hepatocytes are sort of laden with fat. But you need to have also one of the cardiometabolic risk factors. So whether it may be elevated triglycerides, low HDL, presence of diabetes or prediabetes, obesity, or a high blood pressure. So you need presence of more than 5% of liver fat along with one of the metabolic risk factors. So if you look at the association, you find that in obesity about 90% will tend to have presence of NAFLD. So for purpose of class, I mean for the lecture, it's going to be interchangeably. I'm so sorry. For purpose of lecture, I'm just going to use these terms interchangeably, whether it's NAFLD, MASLD, or MASH.
but the entire thing is obviously going to be massived that we're going to talk about. So obesity, you get 90% of the people who will tend to have NAFL. In diabetes, you'll have about 70%. High triglycerides or hypertriglyceridemia, you find that almost 83% will tend to have fatty liver disease. And in hypertension, 68%. I'm not counting the fact that when you have polycystic ovarian syndrome and there is a insulin resistance syndrome that you've got, even in these patients, you'll tend to get presence of NAFLD. Now, in our clinical practice, it is extremely important to evaluate our patients for presence of fatty liver disease because it is one area which has been pointed out by the earlier two speakers, Neeta, as well as by Ranjit, that we do have preventive measures that we can adopt to reverse the amount of liver fat that is there. So the simplistic thing that we can do is do a calculation of FIB4, which is so easy to do by just a calculation. And if you have a presence of FIB4 of less than 1.3, then these patients are at low risk. If the FIB4 is more than 2.67, then these are high risk. And obviously, they are at a high risk for development of fibrosis, which along with other metabolic factors would be sort of considered at a risk for development of liver cirrhosis. These are the patients who would probably require a hepatologist consultation and follow-up in a liver unit. But your first two, that's the low risk and the intermediate risk, is where probably we have a role to play. Now, the intermediate risk is again somewhere when you have somebody in between, whether it's between 1.3 to 2.67, where you need to see what is the next step that you see in terms of risk stratification. And most of us would do an elastography to look at the liver stiffness measurement. If you have a liver stiffness measurement of less than 8 kilopascals, then these are the low risk. If it is more than 12 kilopascals, then these are the high risk and probably go more towards the high risk of FIB4. The indeterminate are the ones, who are in between. So the low risk and the intermediate risk are the ones that we should be very aggressive about to see that our focus should be on obesity management and cardiovascular disease prevention. Once the patient goes into the high risk group and starts developing increasing staging of fibrosis, this patient is already on the road to develop liver cirrhosis. And I'm going to come shortly as to why we need to keep these patients away from cirrhosis because of the mortality statistics that you see. So theoretically, what really comes first? Does diabetes come first or is there mast cell? And you've got a host of different pathophysiological pathways to a healthy liver which predisposes to development of fatty liver. So you've got high insulin resistance, hyperinsulinemia, which may lead to hyperglycemia. And add to that the environmental factors and the genetic predisposition which predisposes a patient to develop fatty liver. And if you're not careful, some percentage of these are going to develop lipotoxicity through inflammatory pathways, develop NASH, and end up either with an end-stage liver disease or move on to development of type 2 diabetes and metabolic syndrome. This is a very interesting paper that came in the Lancet in 2022, that if you have a NAFLD with a strong hepatic genetic component, then these are the patients who present primarily with NASH and fibrosis. They have lesser incidences of diabetes or cardiovascular disease. But if you have a NAFLD with strong lifestyle and adipose tissue depot component, these may be through either increased consumption of glucose, fructose, or patients on insulin, or through visits, of course, visceral adiposity, then these are the patients who are going to develop a high incidences of diabetes, cardiovascular disease, and increased incidences of insulin resistance. They have a lower incidence of NASH and fibrosis. If you look at the progression of fibrosis in patients with diabetes versus non-diabetes, clearly you can see the separation that is there in this through a multicentric study that was done in about 400 all NAFL patients, which were included and confirmed by biopsy. And over a period of about 12 years, 73% of these patients progress in patients with diabetes. So you can see the statistics at 4 years, 8 years, and 12 years. The separation is clear that patients with diabetes had a higher progression to fibrosis than patients with non-diabetes. This also comes from another paper that was published where they looked at the clinically significant liver fibrosis in NAFLD, and this was published in 2024, where they observed that high BMI, increased liver transaminases, and low platelet counts were associated with clinically significant liver fibrosis. But if you had only elevated liver transaminases, they were present in only about 20 to 30% of the patients who developed clinically significant liver fibrosis. So high BMI contributes to a large extent for patients with development of clinically significant liver fibrosis. So it is important that patients with type 2 diabetes should have a screening for presence of liver fibrosis, because that it's irrespective of the liver transaminase levels. Now here's a slide that is extremely important, which says that why are we required to screen for fibrosis? So if you look at patients with diabetes and no diabetes, and you look at the mortality at every stage, so once a patient moves from NAFL to NASH cirrhosis, and percent of people who develop hepatocellular carcinomas, look at the mortality statistics: 10 to 20%, 10 to 15%, 3%, 14%. Compare that with patients with diabetes, the mortality almost doubles up at every stage. So 40%, 20 to 25%, and 5% of patients with cirrhosis will tend to develop hepatocellular carcinomas, and 85% of them will tend to have a higher mortality, and 14% of them will move on to development of liver transplant. So this is the importance that we clearly see, that patients with diabetes who progress with cirrhosis to increasing stage of fibrosis will tend to have a higher mortality as compared to patients without diabetes. And mark that the duration of diabetes remains important at every age group that you see. So the higher the duration of diabetes at every age group, the higher incidence of liver-related events or all-cause mortality. Now, there's been a very interesting article that appeared in JAMA this month itself of MASLD and its relationship to aggressive atherosclerosis and the incidence of cardiovascular disease. And I urge you to read that article. But clearly, that presence of MASLD is associated with increased incidences of cardiovascular events, as well as all-cause mortality and cardiac-related mortality. And this was also seen with patients who've got AF or heart failure or extrahepatic cancers. You've got a host of studies which show that presence of increased cardiovascular disease or cardiovascular event rates or mortality in patients with MASL. So I've just outlined the importance of screening. I've outlined the association and why is it important that we should pick up our patients early enough to intervene. So what is the solution that we've got? I think we need to have a multidisciplinary approach to management of MASL, where you've got, of course, you need to risk stratify by calculating the FIB4 and calculating where the risk this patient stands at. And then, as Neeta pointed out, that it's important to initiate weight management. It may be medical, it may be through surgical intervention. Along with that, you need to have a nutrition and lifestyle intervention, and you need to have a team-based approach with various specialities so that you can treat this patient not just pharmacologically, but also through lifestyle changes. At some point of time, you need to have a psychologist on board, and if the patient is shows a progression to fibrosis, then you need to get an early intervention with a gastroenterologist or a hepatologist. Remember that, as we pointed out, that these patients are at a high risk for cardiovascular disease, and you need to have the intervention of a cardiologist as well as aggressive management of all dyslipidemias. Does weight loss really help? And this slide says it all. So if you lose more than 3% of your basal weight, then you can get a steatosis improvement. But how many people sustain it at the end of 1 year? That's not been reported. If you lose about more than or equal to 5% of the base weight, then the ballooning and inflammation improvement happens in about 41 to 100% of the patients, but only about 30% sustain it after 1 year. If you lose about more than or equal to 7%, then you may get NASH resolution in about 64 to 90% of the patient, but only about 18% are able to sustain it after 1 year duration. And if you're able to lose more than or equal to 10% of your base weight, then you may get fibrosis regression in about 45% of the patients, but only about less than 10% of the weight loss is sustained at the end of 1 year. So what it really tells us is that you may do a lot of weight loss interventions, but weight regain remains a problem, and you need to have a sustained effort for weight loss. Whatever you may do, whether it is lifestyle, whether it's pharmacological intervention, or surgical followed by a pharmacological intervention, any intervention is always a permanent in terms of weight management. It is not a short-term treatment because all the ill effects will all come back if you don't sustain the weight loss. Important is, of course, that if you do weight loss, does it translate in benefit of improvement in the liver transaminases? And this paper in JAMA, which was published in 2019, which looked at 22 studies, participants about 2,600, the mean age was 45, and they looked at all the different options. And you can see the list of all the studies that are on the right side. I'm sorry you can't read them. But what is important is they had a good weight loss in all these studies. And you can see in this forest plot that all the interventions clearly had benefits in terms of weight loss. What is the effect on the ALT values? And you can see here that weight loss definitely had benefits in lowering the ALT values, as you can see in this forest plot. And if you look at the liver steatosis, again, there was a clear benefit in reducing the liver steatosis by weight loss. So there was a benefit by weight loss, whichever way you do it, in reduction of the liver transaminases as well as the steatosis. So this has to be the path that we need to follow very aggressively if we want to reduce the incidence of fatty liver disease. And then if you look at the NASH, that's the non-alcoholic fatty liver disease activity scores, you clearly find that there is a benefit that happens with patients who have this. This was the Brazilian guidelines, which looked at, according to the BMI, what should be our intervention points, and they've suggested this. Weight management is now, of course, I'm not going to get into the slide because Neeta covered it all, but we've got various therapies that are available, and she's covered in elaboration all those therapies, and I'm sure they all have good goals, and they get you to the goal, but you need to keep them there. That's most important. Today, if you look at the entire pathway that I outlined earlier, right from just, presence of high triglycerides all the way to development of fibrosis, you got tools to intervene at all points of time, and you've got drugs to do that. So if you look at all the liver targeting drugs, and you see on the right side the effect on steatosis, fibrosis markers, hepatic enzymes, A1C reduction, and insulin reduction, clearly you can see all the glitazones, fibrates, saroglitazar, and lanifibranor and elafibranor. They're all good in terms of reductions of steatosis, fibrosis. Some of them are hepatic markers, and of course the glycemic controls. If you look at obitocolic, that's the FXR agonist, you find that there is a great improvement in terms of steatosis, fibrosis markers, hepatic enzymes, but they don't have much effect on the glycemic markers. The only drawback is with obitocolic, people complain a lot about itching. And then, of course, you've got the GLP-1 analogs that's now become the gold standard, where you find that all these markers significantly improve. And now the newer GLP-1 analogs and the dual and the triple one agonists that we've got get you to a great weight loss, almost to the tune of about 20%, 18 to 20%, which obviously translates also in benefit in reduction of the liver markers. And then, of course, you got the SGLT2 inhibitors, which has now shown a great benefit in reduction of the adipose tissue and liver fat. So these are all great things. And part of the insulin resistance that happens is because of reduction of the weight that you get. Insulin really does not have too much of an effect. So today, we've got a number of good drugs: efruximine, obitocolic acid, semaglutide, alifibranor, resmetirom, pioglitazone, and tirzepatide, which have been studied for all these effects. And you've got good data which talks about MASH resolution without fibrosis worsening and fibrosis improvement without MASH worsening. And these have been better observed with lanifibranor, resmetirom, and efruximine. I'm going to end up my talk by just saying that lipid management is equally important and triglyceride lowering should be very aggressive, because these are the ones that really, through the VLDL in the ideal pathway, tend to get lodged into the liver and increase the liver pathway. So my last slide is, of course, that these are the key messages that we need to have, that NAFL is highly prevalent with variable rates of progression to NASH and advanced hepatic fibrosis. It's crucial to identify those with NASH advanced hepatic fibrosis, because it can quickly progress to cirrhosis and hepatocellular carcinoma, requiring liver transplant. And these are the patients who tend to have a higher mortality. And patients with type 2 diabetes warrant evaluation, but consider other risk factors. And if NAFL or NASH is present, then stratify according to the hepatic fibrosis. And probably you need to have a mix of approaches and sequential tests that may rule out or even rule out insignificant or advanced hepatic fibrosis. Thank you very much for your patient listening.
Thank you very much, Dr. Sanjit, for this brilliant, and please take a seat over here. Dr. Ranjit, Dr. Nita, if you can come over there, the stage. And we have 2 minutes for any questions from the house. Dr. Ranjit, what about probiotics used in type 1 diabetics? Take this mic. Somebody can give the mic? Yeah.
So basically, when you give a probiotic or a prebiotic, or for that matter, anything to alter the gut microbiota in type 1 diabetes, you may not be doing anything for the pathogenesis of the disease, because it already happened. But please bear in mind that nowadays there are many people with type 1 diabetes who have what is known as double diabetes. So that way you may be able to modulate the gut microbiota and provide some additional benefits to those people. But what has already happened, the immune-mediated destruction, there is no way you can change by giving a prebiotic.
Because we presented one study of 25 type 1 diabetes patients. We had one study in which patients were given probiotics and they fared well as compared to another 25 who were not administered probiotics.
Many of them do have a component of insulin resistance also. I usually tell my patients these are the people who would have developed type 2 diabetes at the age of 40 if type 1 had not got them at the age of 10.
Well, what's the prevalence of insulin resistance in type 1 diabetes?
It's not uncommon, sir. Earlier we used to have this teaching that type 1 means lean. If you get somebody who is overweight or obese, rule out type 1 diabetes. Yeah. Now that is no longer the case. There are people who are obese, there are people who have abdominal obesity, even fatty liver, which used to be unknown in type 1 diabetes, we are seeing now. Because overall prevalence of obesity in the population is increasing, and type 1 does not make you immune from obesity. It's a very difficult situation to treat.
Thank you.
Apart from, I think Dr. Ranjit, for you again, apart from probiotics, prebiotics, and the various anti-diabetic drugs with relative benefits of each of them, do you know of any specific non-anti-diabetic drug which could positively impact my microbiota?
Sir, I didn't get you.
A specific non-anti-diabetic agent.
I don't know. Again, yesterday I had a patient. I would like to get the opinion of somebody has been trying sertraline for these people, antidepressant. And I asked him, patient didn't have any depression, anything of that sort. And somebody has started sertraline for altering the gut microbiota. It's an educated patient, so he knows why the sertraline has been given. So lots of studies are going on, but the point is even for drugs which purportedly act on the gut microbiota, the evidence is iffy even as of now. So we need much larger studies with much larger numbers of people to see whether these agents actually work.
Any role of environment, geographical location, yes, genetics?
That's again a very interesting point. In fact, we had actually done a study with a Danish collaborative group in which we tried to look at the difference in gut microbiota between pre-diabetes, NGT, and type 2 diabetes and compare it between Indian and Danish population. Well, what we found was that definitely there was a difference between non-diabetic, diabetic, and pre-diabetic, but that difference was much smaller than the difference between the Indian and Danish. So ethnicity, environment plays a major role, and that is why we should take all this data which has come from Western countries regarding the absolute concentration of various organisms with a pinch of salt. We need Indian data. What is the composition of our microbiome? And how is it changing when we develop metabolic disease? So, and it's not easy. We need big data. For example, for this particular study, we had to take the help of TCS, Tata Consultancy Services. So much of data. It is much beyond what our statistician or what our investigators can see.
Thank you very much, Dr. Ranjit. And I think so. Yes, somebody is there? Any question? Yeah. Till the mementos they are given, Dr. Sanjay, because MASL, yes, you start with that.
Okay.
MASL is very strong CVD risk factor. What about statins to be given? Dr. Sanjay, what about statins? Because it's a very strong risk factor, CV risk factor, MASL.
Yes.
And
So
do you think that every patient needs statin to be administered?
you're true. I mean, that's absolutely true, because we said that this is a metabolic disorder and it has a high cardiovascular risk. So clearly, all these patients come under a high risk group, and you need to have aggressive statin therapy for lipid lowering. So your lipid goals has to be lowered to an LDL of less than 70. And if the patient has already had a cardiovascular disease, then less than 50. And you need to have more aggressive triglyceride lowering, because clearly these are the triglycerides that are going to get affected and lodge into the liver. So you need to have very low triglycerides that you need to.
Thank you very much, everyone. Thank you for all these three speakers for their brilliant deliberation. Thank you.
So, thank you very much for wonderful session, and I request everyone to stay on stage and present a memento to three of our speakers. I request Dr. Vinod Kumar sir and Rohit Kapoor sir. And now we have something exciting. We have a quiz session before we start the next session. आपका फ्लाइट सर 2 मिनट सिर्फ छोटे 3 क्वेश्चन. So I request everyone to scan this QR code. We have 3 small questions. भाई इधर से एक्सेस नहीं दिया हो. We have 12 players ready. यहाँ से नहीं हो रहा है. नहीं जाएगा. 2 मिनट. अरे यहाँ से आगे नहीं हो रहा है. For next session, I request our chairpersons, Dr. Aparna Agarwal and Dr. Lily Rodriguez, to come on stage, please.
So, good morning, all. I am sure everybody has woken up on a Sunday morning. We have the second symposium, and Professor Shashank Joshi needs no introduction. He is here right in front of us. I don't want to waste much of time. Sir, over to you, Professor Shashank Joshi.
Thank you, Rajiv. Thank you, Madam Lily and Madam Aparna. Rajiv has asked me to do this topic on cure, reversal, remission of type 2 diabetes, new approaches and medications. So, thank you, Rajiv, for allowing me to speak on this topic with Shalini and the entire team of this thing. And digital diabetes care is here to stay. And clearly, COVID was the biggest game changer in digital health. So we have now definitions in place for reversal, remission, cure. We have a twin cycle hypothesis which Neeta alluded to, which can reverse diabetes. We have a lot of AI diabetes, where we can reverse chronic disease. And now we have new ticket drugs like GLP-1 agents, GIP agents, triple agents, which can actually cause remission. So there's a lot of RCT and new data. And clearly, Raju, thanks for always thinking ahead of time on these type of areas and domains, and maybe a simple take-home message. So clearly, we are in the era of continuous monitoring. That is the biggest game changer. And because of CGM, we are able to look at virtual connectivity. We can actually treat people at home. And that's the reality. So in the newer approaches, we have newer insulins, newer technologies. But I feel that the single most important game changer in the type 2 diabetes space, through which we are able to achieve a lot, is the continuous glucose monitoring. The CGM has been the biggest game changer. And then machine learning algorithms for predicting values have been the other big game changers. So when you did this was done in 2020, almost 4 years back, by Gurthre and his group, how to define remission, cure, and reversal. The term reversal was abandoned mainly because it gave you a false sense of security. And the term remission was borrowed from oncology people. Because you are in remission as long as you are doing a particular lifestyle or taking a particular drug. So presence of remission is basically absence of glucose lowering therapy, normal glucose, and more than 1 year of duration. That is the sense of remission. That could also be called as cure. That could also be called as reversal. So when they did a scoping review, they used some of these statistical techniques like the Sankey diagrams. And through those filters, they actually coined these terms of partial remission, total remission. And the partial remission means absence of glucose lowering therapy is required. Normoglycemic thresholds were defined of 6.5 and below A1C, or fasting below 126, 2 hours below 200. And absence both of glucose lowering therapy and glycemic thresholds met for the duration of time. When it came to complete remission, it was not only absence of glucose lowering therapies, but the A1C threshold came down to 5.7. The fasting threshold and the PP threshold came to 110 and 140. And the duration was up to 12 months. So that is how the partial and total got defined. And then all societies came together. And they had a simple definition. A1C less than 6.5. Whenever A1C cannot be done, you can use an EA1C or a calculated E1C from the CGM, and then you do testing, and then you look at long-term maintenance. So simple 1, 2, 3, 4 was the consensus report. And they said, don't use the word cure, it's as good as cure. Keep your A1C below 6.5 for 3 months without drugs. Keep your fasting glucose below 7 millimoles. You can use eCGM also. A1C must be measured at the beginning and after intervention after 3 months of ending. And at least you must screen and test for A1C and complications once a year after remission. So ADI 2021, after this consensus, said there is a remission definition, there is a partial remission definition, there is a complete remission definition, and there is a prolonged remission definition. And that prolonged is now equated by cure by our bariatric surgeons. So what is prolonged remission? A1C below 5.6, fasting below 100, and off diabetic medications for at least 5 years or more. And they say cure is probably about 10 years. But I'm not put cure as a definition because most people don't like to use the word cure, because then there would be restoration of unhealthy lifestyle, and that's the fear. So there is prolonged remission, 5 years or more, complete remission 1 year, and then 5.6 and fasting glucose 100 are the cutoffs for A1C. And in the partial space, A1C is 6.5 and fasting glucose is 126 or below, and duration is 1 year for partial and less than 3 months for the remission definition. It's all linked to food. You know, food is medicine, and we as Indians have an ability to remedy because we are thin fat Indians, we have more fat, less muscle, we have mitochondrial defects, and we eat carbs and fats, and we have less protein. So clearly Professor Taylor said, when we eat too much, we activate the liver cycle, we cause so-called MASH, which Sanjay very nicely alluded to, and we also get a fatty pancreas. So fatty pancreas, fatty liver due to too much of eating is the core hypothesis on which all remission programs and diets are related. And all they say is restrict calories, do physical activity, or do pharmaceutical intervention. So if you really want to achieve remission, improve insulin sensitivity, get normal metabolism, all you need to do is either eat less than 800 calories, or do physical activity measures with that, and or have drugs. So that gave the birth to this old concept of VLCD and LCD. Very low calorie diets and low calorie diets. In 1979, it was shown, 1929 sorry, that VLCD used to treat obesity. In 1962, the canned-based drinks were introduced as diets. But suddenly they saw, in the 76 to 78, sudden deaths happening. Whenever people did very low-calorie diets, because when you do very low-calorie diets, you take low-quality protein and micronutrients which are insufficient, you can get deaths. And therefore, the Global Body Codex, which is a certifying body for food standards, they said that we need low-calorie diets which are micronutrient enriched and protein enriched. And that is why a lot of formulas which you see in the commercial market today are enriched with micronutrients and commercial formulas. Codex also defined in 1995 what is LED or LCD and what is VLCD or VLED. They said you need micronutrient replete, which means sufficient. You need 50 grams per day protein. We need 7 grams per day fat, and if it is very low calorie, it is 850 to 800 to 450 calories. If it is low calorie diet or LCD, it is 800 to 1200. So the caloric content, the protein content, the micronutrient content, and the fat content was defined. So diabetes is reversible first came from Professor Taylor's group equal to bariatric surgery. Surgeons were able to do that. And Corey's et al. By a bilirubin-pancreatic diversion showed that you can get 90% remission of diabetes for 10 years. And even the Swedish cohort showed by bariatric surgery. But by severe caloric restriction, Professor Roy Taylor, who gave the Claude Bernard lecture at EHD in Madrid, clearly showed that you can actually restore everything. And he published the direct trial, and now 5-year results are available in a primary care setup, that if you have a low calorie meal with type 2 diabetes less than 6 years, with obesity without insulin, you can actually achieve remission in half the population in a real world setting. What was their formula? Meal replacement with low calorie diet, negative calorie balance established, depletion of liver and pancreas fat, and reversal of diabetes. Who responded better? Shorter the duration of diabetes, better the response. Younger the patient, better the response. And at the EHD, we had an oral. This was oral me and Dr. Samanna presented. Duration of diabetes, baseline A1C, number of anti-diabetic drugs, baseline time below range, and baseline HOMA beta. They are the factors which are strong predictors of remission. So yes, type 2 diabetes can be reversed. We can use technology. We use this technology of twin, where we use health signals, happy signals, causal signals, precision nutrition, medicine and insights. And they have an app. We do a CGM. We monitor food logs. From that, we put them through an AI system for food, sleep, activity, medications. And then we categorize foods which are red, yellow, and green. Green you can consume, yellow you can be moderate, and red you can avoid. And for every human it is different. If you all of us apply a CGM, you can actually study it. If the food you eat today afternoon, what is your glycemic response? Then we give digital nudges and human touches and give personalized nutrition recommendations which are individualized for glucose control, medication remission, and diabetes remission. And you don't have to be stuck to apps all the time. Once the AI algorithm learns it, it's like when you search on your mobile phone a particular thing. Right now I want to see which is the earliest flight from Mumbai to Delhi to Mumbai. Then it will keep on reminding you. Or if you do something on shopping, it will keep on popping up. Similarly, the AI learns and the technology interface comes down. Many other people have tried this. There's a Vata program, which is a keto diet reversal. There's a Livanga program. And most of them are able to achieve remission. We have published it in RCT format. And we have now data up to 3 years where we are able to achieve remission and reversal. And we are able to get A1C improvement with or without weight loss. We published this in the ACE meeting long time back. Therefore, remission is a reality today by using lifestyle, by cutting calories, and using AI-based apps. But still there's a long way to go in remission, because we still don't know the non-glycemic measures during remission. We still need to look at long-term outcomes of remission. We still need to develop it. And UK is now trying to apply in NHS remission programs based on the direct program. But the drugs have been the big game changers. 5% of weight loss, glucose and blood pressure comes down. 5 to 10% which semaglutide does or GLP-1 single agents, receptor agents do. They can prevent MAFLD, diabetes, PCOS, dyslipidemia. 5 to 10%, 15% which a tirzepatide will do, dual agent will do. You will get much more impact. But if you get 15% weight loss, which direct trial got, with 800 calories, you can get type 2 diabetes remission, cardiovascular mortality will come down, and heart failure due to preserved ejection fraction will come down. But only lifestyle, only AI, is that a solution? No. We only knew insulin, but after 100 years of insulin, we have repositioned glucagon. This is Dr. Tishop, who got the Banting lecture last year. And you can see that he repositioned and created super hormones by glucagon, GLP, and GIP. And tapping the glucagon receptor, tapping GLP, tapping GIP, there are now triple agents. And these triple agents and dual agents cause compelling weight loss, equal to bariatric surgery, and cause complete remission of diabetes. Complete remission of diabetes. Like this is a triagonist, retatrutide. In North America and Europe, it will be available soon. The FDA's form, Europe and US have cleared it. It's a triple G agent. It's a GIP, GLP, and a glucagon receptor agents. 74%, to 83% achieve more than 15% of weight loss, and almost 100% have diabetes remission. So very, very compelling data. So we clearly recognize that whether it is tapping technology, glucose and
glucose and
behavioral
behavioral
change,
change,
we can
we can
achieve
achieve
weight
weight
loss
loss
and
and
diabetes
diabetes
remission.
remission.
So
So
diabetes
diabetes
remission,
remission,
prolonged
prolonged
remission and
remission and
cure
cure
is
is
possible through
possible
three
through three
routes:
routes:
surgical
surgical
route,
route,
medical
medical
route,
route,
AI-based
AI-based
app
app
route,
route,
and
and
compelling
compelling
medications
medications
from
from
single
single
G,
G,
dual
dual
G, or
G, or
triple G
triple G
route.
route.
And that's
And
all
that's all
incorporated in the
incorporated in the
algorithm now.
algorithm now.
That's all
That's all
incorporated in the
incorporated in the
algorithm.
algorithm.
And
And
these
these
compelling weight
compelling
loss
weight loss
drugs
drugs
are
are
making
making
us
us
keep
keep
people
people
living with
living with
diabetes in
diabetes in
remission.
remission.
Even an
Even an
agent like
agent like
SGLT2
SGLT2
metformin
metformin
and
and
gliptin,
gliptin,
which is a
with the
triple
triple
agent,
agent,
can
can
keep
keep
your
your
A1C at
A1C at
5.6 today.
5.6 today.
An
An
agent
agent
combination of a
combination of a
glitazone,
glitazone,
an
an
SGLT2
SGLT2
inhibitor or
inhibitor or
metformin
metformin
also can
also can
keep
keep
diabetes into
diabetes into
remission.
remission.
That is
That
based
is
on
based on
clusters.
clusters.
So I
So I
think
think
today
today
in
in
2024,
2024,
in
in
September,
September,
type 2
type 2
diabetes
diabetes
remission
remission
is
is
possible.
possible,
Partial,
partial,
complete,
complete,
total,
total,
prolonged.
prolonged.
Word
Word
cure should
cure
be
should be
avoided.
avoided.
Word
Word
reversal should
reversal
be
should be
avoided.
avoided.
This is
This is
very, very
very, very
possible.
possible.
It is
It is
possible with
possible with
direct
direct
based
based
data,
data,
which is
which is
600 to
600 to
800
800
calories.
calories.
But
But
don't
don't
forget
forget
protein
protein
and
and
micronutrients
micronutrients
as per the
as per the
codex.
codex.
Ensure that
Ensure
that
that
is
that is
taken care
taken
of.
care of.
It is
It is
possible through
possible through
apps
apps
with
with
AI and
AI and
personalized
personalized
supervision.
supervision.
And it is
And it is
possible
possible
through
through
new
new
agents
agents
which cause
which cause
compelling weight
compelling weight
loss
loss
from
from
8% to
8% to
25%,
25%,
like a
like a
GLP-1
GLP-1
single
single
agent,
agent,
GLP-1 dual
GLP-1 dual
agent
agent
with
with
GIP, or
GIP,
a
or a
GLP-1
GLP-1
triple
triple
agent with
agent with
GLP-1
GLP-1,
GIP,
GIP, as well
as
as
with
with
glucagon
glucagon
receptors.
receptors.
So
So
it is
it is
really
really
doable.
doable.
And
And
surgery is
surgery
still
is
there,
still
it's
there,
not
it's
out.
not out.
So
So
all this
all
is
this is
possible.
possible.
So thank
So
you,
thank you,
Rajiv, once
Rajiv, once
again
again
for
for
allowing me to
allowing me to
speak on
speak
this
on this
topic,
topic, which is very
germane to my
germane to
heart.
my heart.
Thank you.
Thank you.
Thank you, Dr. Shashank, for that masterly talk on the hopeful reversal of type 2 diabetes. And, and it was really wonderful. And I think the questions are taken later. So we'll thank you very much.
So thank you, Dr. Shashank. So now from weight-centric remission of diabetes, we go on to sarcopenia in women with diabetes. It will be delivered by, it's a keynote address to be delivered by Professor Ina Shaltau. Unfortunately, due to visa issues, she could not make it physically here, but her lecture will be here with us. She has been very active academically, professor of internal medicine, diabetes, and faculty in Cairo University from 2004 till today. And she has been the founder member, president, and active in the Arabic Association for the Study of Diabetes and Metabolism since 2006 to date. So she has guided many PG theses, has written many chapters, has many publications. So I would like you to start the keynote address on this.
The cardiometabolic disease in the young diabetic. And let me start with these important figures about the global prevalence of overweight and obesity in children and adolescents. During 2016, we had more than 340 million children and adolescents having obesity. And these are the causes of childhood obesity. They are complex and multifactorial. We have some genetic factors, endocrine factors, psychological, neurological, drug-induced, and environmental factors. Pediatric overweight obesity has many complications and comorbidities, and let me start with some complications which is common, like pre-hypertension and hypertension, the presence of NAFL, prediabetes or type 2 diabetes, hyperandrogenemia or polycystic ovary syndrome,
proteinuria, focal segmental glomerulonephritis, sleep capital femoral epiphysis, pseudotumor cerebri, sleep apnea, and early subclinical atherosclerosis, increased incidence of cardiovascular disease, morbidity, and premature mortality in adulthood, and also dyslipidemia. Obesity during adolescence increased the mortality rates during adulthood stroke. Several types of cancers also may be present as a complication, and also the presence of osteoarthritis, especially the weight-bearing joints. Some psychological disorders. The first problem to occur in obese children are usually emotional or psychological. They experience bullying by their peers, sometimes even by their own family. Some are harassed or discriminated against by their friends or their own family. Low self-esteem, depression, and according to CGC, Center for Disease Control in 2003, 1 in 3 children born in US in 2000 will become diabetic in the future, and those children will become later on type 2 diabetes. The relation between type 2 diabetes in the youth age. Before 1990, only 5% of children or adolescents diagnosed with diabetes were classified as type 2 diabetes. Now they account for 30 to 50% of new cases of diabetes in youth, and the incidence of diabetes parallels the national data, estimating tripling the rate of overweight in adolescents in the past 20 years. Type 2 diabetes in the youth is considered #1 consequence of the epidemic of obesity. Children are becoming sedentary with less physical activity in schools, more screen time, and only 50% of them get regular physical activity, and 14% of teenage report no physical activity at all. And these are important cardiometabolic risk factors, which are hypertension, dyslipidemia, and non-alcoholic fatty liver disease. According to Diabetes Canada, these are the clinical features at diagnosis of type 2 diabetes, and we find 95% of type 2 diabetes in the young. They are obese. 12% of them are having polycystic ovary syndrome, 44% having dyslipidemia, 28% having hypertension, 22% having elevated liver enzymes or NAFL, and 14% have micro or macroalbuminuria. An important question: when and how to screen? And according to AGA, we screen youth who are overweight with more than 85th percentile or obese more than 95th percentile, and have one or more additional risk factors like maternal history of diabetes or gestational diabetes during the child gestation, family history of type 2 diabetes in second or first degree, relative race or ethnicity like Native American, African American, Latino American, Asian American, Pacific Islander, signs of insulin resistance like cancer negligence, hypertension, dyslipidemia, polycystic ovary syndrome, or small for gestational birth weight. According to Diabetes Canada, who to screen non-pubertal and three or more risk factors beginning at the age of 8, or pubertal and two or more risk factors. And these risk factors include obesity, member of high risk ethnic group like African, Arab, Asian, Hispanic, or South Asian descent. First degree relative with type 2 diabetes, or exposure to hyperglycemia in utero, signs and symptoms of insulin resistance like cancer, negligence, hypertension, dyslipidemia, or NAFLD or elevated liver enzymes. Again, who to screen? Polycystic ovary syndrome, the presence of impaired fasting glucose or impaired glucose tolerance, and the use of atypical antipsychotic medications. To screen, the recommended screening tests are the same like for adults. We do hemoglobin A1C together with either fasting or random plasma glucose. And if there is discrepancy between A1C and fasting or random plasma glucose, we go for oral glucose tolerance test. Another question, what are the associated complications and comorbidities in youth with type 2 diabetes? We have short-term complications or acute complications like diabetic ketoacidosis or hyperglycemic hyperosmolar state, and long-term or chronic complications, severe and early onset microvascular complications including retinopathy, neuropathy, and nephropathy. So it is important to screen for these medications at diagnosis and then yearly after. Comorbid conditions like dyslipidemia, screen for dyslipidemia at diagnosis of diabetes, then every 1 to 3 years, and when to give statin therapy or lipid-lowering therapy. We try first 3 to 6 months later intervention, and if LDL is still elevated, we start statins. Hypertension, screen for high blood pressure at the beginning, at diagnosis, and then in subsequent clinic visits. If present, we should search for other comorbid conditions associated with insulin resistance, like polycystic ovary syndrome or non-alcoholic fatty liver disease, and we start treatment. This is a screening schedule according to Diabetes Canada. For neuropathy, we screen at diagnosis, then every year. For retinopathy, we screen at diagnosis, then every year. Nephropathy, again, at diagnosis, then every year. Dyslipidemia, at diagnosis, then every year. For hypertension, at diagnosis, then every visit. NAFLD, at diagnosis, then yearly. Polycystic ovary syndrome, we screen at diagnosis in pubertal females, then every year. Obstructive sleep apnea, at baseline, and then every year. There is some signs and symptoms for obstructive sleep apnea like snoring, the presence of apnea, morning headache, fatigue, daytime sleepiness, and nocturia and enuresis. Depression, we screen at diagnosis and then every year, and there is clinical assessment by history of symptoms of depression, including fatigue, depressive mood, irritable mood, loss of interest or pleasure, feeling worthlessness or guilt. Binge eating, we screen at diagnosis, then every year, and binge eating is clinically assessed by history, frequency of having lost control while eating usually large amounts than anybody can eat in a meal. Young adults with diabetes have high rate of cardiometabolic risk factors. This can lead to increased disease prevalence and mortality rate among these individuals as they age. The presence of diabetes in youth and young adults increase exposure to chronic hyperglycemia, leading to cardiometabolic risk factors early in their life, increased incidence of cardiovascular disease, kidney failure, and lifetime diabetes complications in middle age, and this can contribute to reduced life expectancy of young adults with diabetes. These are the estimated morbidity and mortality in adolescents and young adults diagnosed with diabetes later in life. These are the causes of death. Highest percentage with end-stage renal disease, followed by coronary artery disease and stroke, and diabetes complications. The most prevalent is microalbuminuria, followed by nephropathy, followed by coronary heart disease, peripheral neuropathy, strokes, the presence of end-stage renal disease, blindness, treatment with photocoagulation, lower extremity amputation, severe complications when diabetes start in early age. Answer question, how can we stop the cardiometabolic epidemic? And these are the IGF recommendation for a healthy diet for the general population, what to eat and what to avoid. And then these are the WHO recommendation on physical activity for different age groups. And for children and youth aged 5 to 17 years, they should do at least 60 minutes of moderate to vigorous intensity physical activity daily. How to prevent? By active play, by less TV and video games, more exercise and physical activity, healthy eating habits, weight loss, and medications when necessary. Type 2 diabetes prevention in the young adults or youth. It is a team approach between endocrinologists, physicians, general practitioners, diabetes education, diabetes educators, dietitian, the student himself, the family, the school, and the media. How do we initiate change at schools? Schools can provide quality daily physical activity classes, nutrition awareness campaign, parent education and awareness campaign, psychological education, psychological intervention when necessary, and school nutrition policy. The main message, parents are an important influence on their children's eating and activity habits. Another main message, change will take time, begin by taking a few small steps. Thank you very much.
It was an excellent talk. I don't think she's online, so we'll not be able to ask any questions. Two important messages from her talk. One is very early screening for childhood diabetes. She has recommended screening at puberty for Asians because that's one high risk factor. And if you have any person in the family with diabetes, then we need to screen at puberty. And at the age of 8 years, if you have an additional risk factor. And second important thing was education involving the schools also in the training and management of these children. So thank you very much, Dr. Professor Inas Shaltout. And I think we pass on to the next talk.
Yes, we invite Professor Muhammad Hasnain. He has come all the way from Dubai. I have the pleasure of introducing him. He is a professor at Mohammed bin Rashid University, Dubai, and a senior consultant endocrinology and diabetes at Dubai Hospital, Dubai, and HOD Gulf Medical University, UAE. He is, I am very happy to say that he was a co-founder. He is a co-founder of Diabetes Diploma, MSc for Cardiff University. Many of us from India have also attained that certificate since 2007. And he's a consultant in the Department of Endocrinology Diabetes at the UK in 2002, graduated from Alexandria, Egypt. And he has many other credentials to his credit. He has published over 100 papers and is an associate editor of Dubai Diabetes and Endocrinology Journal. Over to you, sir.
Good morning. It's very great pleasure for me to be here, and thank you very much for the kind introduction. Thanks to my dear friends, Dr. Rajiv Chawla and Dr. Chalini for the kind invitation. Always good time to be in India. So I'm delighted to see that the audience of the session are split between men and women, so we'll have no fights on this. But the big question, obviously, are there gender differences when it comes to diabetes and cardiovascular disease? And if there are any differences, what are they? I will be sharing with you some of the data that we've recently had. They're in the manuscript stage as well, so some of these data are very new. I'm sure many of you have read this excellent book, Men Are From Mars, Women Are From Venus. I'm not really sure why they are both on two different planets. But when it comes to diabetes and cardiovascular risk factors, the question really, are we that different from two different planets or not? Now, this is an important publication that was published earlier this year, in May of this year, looking into the lifespan between men and women. And I got here the data from two regions. I work in Dubai, so it's a high-income country, but it's also a North Africa and Middle East country. And obviously, the vast majority of the population in Dubai are not indeed locals. They are indeed 40%, as I presented yesterday, are from India. So it's Indians in Dubai. But as you can see, for cardiovascular or atherosclerotic problems, it's the lifespan for men is shorter than for women. So we can say in so many ways that women break our hearts, literally. But that obviously is just a joke. But when you look into the population of Dubai, it's a very interesting distribution of gender. In young, the gender is equal. But as we get into adult age, the vast majority are men. So we definitely need more young women in Dubai. It's almost 3 in 1, men to women, because obviously related to the workforce and so on. But when it comes to the, and this is the exact figure, 70 or 69% of the population are men, and only 31% are women. So certainly there is a need for a change in this, and it's very much related to the workforce, and that obviously can change. But what about when it comes to cardiovascular risks? Who has more weight or overweight or obesity? And this is data from a household survey that is done as per the WHO criteria, which includes everyone in the city, not just a specific nationality. And as you can see, 21% of women are obese, while only 16% are in men. But overweight are a lot more in men than in women. In general, as you can see, it's only about 43 to 41% of the population have normal weight. And it's not just about being obese or overweight, is where is the fat distributed? You only know about the pear and the apple, and obviously this is quite important. So as Shashank Joshi mentioned in his previous lecture, weight circumference is possibly more important than BMI. And obviously, as you can see, as much as the waist circumference increase, the problems on cardiovascular death and myocardial infarction, all-cause mortality increase both in women and in men. This data is from women, so it's exactly the same in men as well. So the higher, the worse outcome. Now, if we look into the prevalence of associated risk factors in obesity, and here is the waist-race ratio. So it does look like men don't care, as I mentioned, too much about their waist. While there is more obesity in women, but it might be distributed in other parts of the body. So the waist circumference of men is much higher than the waist circumference of women. And I guess we have the advantage of cheating and putting our belt lower and thinking we did not increase our weight. Obviously, that's not the case for many women. Now, this is the beautiful data that was collected from Abu Dhabi, the capital of UAE. This is data from 55,000 persons who joined a specific insurance program called Wuqaya. Wuqaya in Arabic means protection. And as you can see here, central obesity in men is much higher across all the age groups until we get to the older age group, where perhaps the concern about keeping a good waist for women is not as high. But for younger age, as you can see, there's a very big difference. Look into, for example, those in the 40s, 62% versus 76%. Into the 30s, 48% versus 62%. So clearly, there is big difference in waist circumference. Men are higher until we get into the older age, and then it starts to equalize. An important cardiovascular risk factor is prediabetes. And is prediabetes higher in men or women? And it's much higher in men in comparison to women, at least as we saw from the data in Dubai. Why is that the case? I'm not really sure why, but it is a very significant difference between the two. Now, I was happy to be engaging with colleagues from my own city, Alexandria in Egypt, and we did this large population study which we published about 6 years ago, and it included 10,600 persons from the city. Now, the beauty of the city of Alexandria, it includes urban parts, rural parts, and even the desert parts, the Bedouin side, so it's very representative of the country. And as you can see, the prevalence of prediabetes in Egypt or in Alexandria, is lower in men. So why is prediabetes higher in Dubai in men? I don't really know. When it actually comes to diabetes prevalence globally, it does seem that there is a very minor difference between genders. As you can see here, the diabetes line in blue is slightly higher than in men. And when you can look into the data from across the MENA region, there is hardly any difference in gender between men and women in prevalence of diabetes. But again, there is a difference in Egypt, in Alexandria, where far much more women have diabetes in comparison to men. In Pakistan, the same issue was there as well. Females had, this is data from that was published by Professor Abdul Basit and colleagues 2-3 years ago, that far much higher prevalence of diabetes in women versus men. In our data in Dubai, it's the opposite. It's men who have more diabetes than women. So more diabetes in men, more prediabetes in women, which is different to many of the neighboring countries. And I'm not sure what's the cause of this. So of course, to try to protect the person from complications, we need to reach the KPIs, the key performance indices that everyone is trying to look for. And I looked into this data that I've recently had. This is unpublished data yet. It's in a manuscript stage. It's over 12,000 persons, 12,500, including about 1,100 from India. And the data is almost nicely split between men and women, a touch more female in the survey than. Sorry, I got the figure right. From India, it's 1,000, but from the Indian subcontinent, it's 3,000. But the duration of it's almost identical for many parameters. Duration of diabetes is identical. Control of HbA1c, hardly any difference, 8.3 to 8.4, but again, the same feature. women are more obese, men are more overweight. More importantly than who has got more obesity and more has got more weight, the more important point here is the vast majority of our patients are not in target glycemic control and indeed are overweight or obese. So maybe that's a more serious message. We talk about cardio and renal protective drugs, and we've heard beautiful presentations over the last day and today as well about the importance of them. But unfortunately, these drugs, specifically GLP-1s, are hardly used by the mass population. So out of 12,500 persons from Morocco up to Indonesia, including 3,000 persons from the Indian subcontinent, only 2.9 or 2.2% are on GLP-1. And again, more men than, or equal men and women in GLP-1s, but in SGL2 inhibitors, a lot more men than women for so unknown reason to me. Blood pressure is not well controlled for over 50%, 55% of the population. LDL is pretty poor in the vast majority across the globe, and our smoking, obviously, far much more men are smokers than women, although there is under-reporting of smoking. And the prevalence of shisha smoking, which now is becoming like a trend. It's cool to go to a cafe and have a shisha, which is obviously a very high cardiovascular risk. So I'd like to go to the reality of what doctors in this survey reported of the presence of cardiovascular risks. We hear in many presentations about 30% of the patients have renal problems or something like this. And I guess in Asian society or in Eastern society, we get diabetes at much younger age, which is different from when I was practicing in UK. So the actual prevalence of nephropathy is about 10%, and cardiovascular disease is 15% in men and 10% in women. So 50% increase between men and women in the prevalence of cardiovascular disease. And I started to dissect some of the data to try to understand why do men have more cardiovascular disease. And I think there's a number of points. One, smoking is much higher in men than in women. And second is the central obesity, which I've shown you before, is much higher in men than in women, and we all know about the intra-abdominal fat. Now I will share with you the data of those who have cardiovascular disease from the survey, which is about 1,359. And again, about 40%, 60% men, 40% women. It's the unfortunate scenario that the vast majority of them have poor control, so good glycemic control. In fact, it's not so good. I've just made it 7.5 to make it an easier figure, considering that many of these are maybe on the older age group with a longer duration, so perhaps tight control would be not the case for some. But as you can see here, less than 30% on average are achieving good glycemic control. The BMI within target is in a quarter of them. Systolic blood pressure being below 130/80 is only in under 40% and a bit higher in men than in women. LDL, and this is again a very common feature. LDL for a person with diabetes and established cardiovascular disease should be less than 55, as all the guidelines says. And this is here 10 to 13%. If you relax it a bit and you say, I'm happy for it to be under 70, it's again 15% in women and about 23% in men. So the vast majority of people with diabetes and established cardiovascular disease are not achieving the LDL target. And obviously it's unfortunate to see 13% or 13.5% of men with cardiovascular disease and diabetes continue to be smokers. Now, you might say that SGL2 inhibitors and GLP-1, we are saving them for the high-risk persons. And there is no higher-risk person than a person with cardiovascular disease. And as you can see here, it is less than 25% in overall, and GLP-1 got up slightly from 3% to 4.4% in women and 6.6% in men. Death because of early death in diabetes is equal between both genders until we get into the 70s. And then suddenly women overtake men into that cause. And perhaps it is the loss of protection by estrogen and the effect of this. What exactly is the cause? Obviously, it needs to be understood. So my take-home messages is, we do indeed, of course, have some differences in gender between men and women. Obesity is more than female than men, but central obesity is much more in men, pre-diabetes more in men, diabetes itself, hypertension, and definitely smoking. In people with type 2 diabetes and cardiovascular disease, 60% are men and 40% are women. The majority of all of them in general, whether they are men and women, they are not really achieving the treatment targets. And that's something very important. But they are largely equal, but females are less likely to be prescribed SGL2 or GLP-1 receptor agonists. And of course, in those with type 2 diabetes and cardiovascular disease, women tend to have, unfortunately, from the data, higher HbA1c, higher BMI, and LDL, but lower prevalence of smoking. Now, it is really important. I had the pleasure to go to the Swedish Register office, which is a massive building where they have a register for everything. And the beauty of the data that came from Sweden of 1.4 million, 1.38 million persons, matched with over 250,000 persons with diabetes. If we address these cardiovascular risk factors, the lifespan and the mortality and morbidity of a person with diabetes will be no different than a person without diabetes. So it's not all doom and gloom if we address the risk factors and the 5 main risk factors. And this is regardless of gender. And again, finally, thank you with pictures of my own city, Alexandria. Thank you.
Thank you, Professor Mohammed. I would like you to take the seat. I think the other, of course, one speaker did not come, but I saw Dr. Shashank Joshi strolling out. So I think he's gone. So we would like you to now enlighten us more on the doubts that we have. I would like to ask, I just wanted to comment on your beautiful, wonderful talk, which came from your heart. I feel that you know, from your experience you have spoken, and wonderful study results. But you also said that CVD in men had 15% percentage of CVD, and women it was only 10% in your study. So on the contrary to what we experience here, the CVD is much more common in women with diabetes, at least 2 to 3% more than the men. And as you rightly said, post-menopausal women suffer much more than the premenopausal because of the estrogen protection. So would you like to comment on that? Why is it more or less or different as we see in India?
The data I've shown you are data from as west as Morocco and as east as Indonesia, including 3,300 persons from the Indian subcontinent, India, Pakistan, and Bangladesh. There was about 1,100 from India. So the total of those with cardiovascular disease were roughly about 1,500. So obviously, it's difficult to dissect it to difference it from our data. Why is in India, in this case in India, that women have much higher or a bit higher prevalence of cardiovascular disease than men? I'm not sure. Obviously, you can enlighten us better. Is it access to healthcare, access to service? Could be.
That's a very good conclusion, I think, and it inspires all of us to do a study in our own areas on finding out the difference in gender. I think we all need to do a research in our own areas because it is lacking.
Dr. Chawla, but I see most of the speakers thanking only Dr. Chawla. No, Dr. Chawla, this is not for you. This is for the gender bias. So I want a big round of applause from my friend Dr. Shalini, who's equally a part of CMRE. But from the morning, she's been working so hard, and I've seen most speakers, I'm saying, in the morning, thank only Dr. Chawla. So a big thank you for my dear friend for working together with Dr. Chawla and also burning the midnight lamp.
This is because of the fact that she was handling that hall. There everyone is obviously conveying thanks to Dr. Shalini.
One more question, that probably SGLT2 inhibitor is not less written in India for the women, but I have to withdraw it more often in Indian women because they do develop genital tract infection. Now, whether that is related to the temperature in our country, it's moist, whether that is related to a lot of cultural practices, sari wearing women not using undergarments, or is it related to genetics? We have not been able to find out. But more women, we have to stop the SGLT2 because of genital infections and recurrent genital infections. So that is one reason why maybe less women are, at that point, less women. We do see balanitis and balanoposthitis in the uncircumcised male. But in your part of the Dubai, most people would be circumcised. And also there may be a difference because the population that you're talking about, Indian, they're immigrant population. They're working hard there in poor conditions. So does that mean they have more diabetes, more, or you're talking about every immigrant?
Sure. Obviously, I agree with you about how hard Shalini is working. But I'm not saying that. I'm not saying that. Yes, obviously we have a parallel rooms here. Um, the serious point is the SGL2 inhibitors and GLP-1s are terribly underused. Specifically, the SGL2 inhibitors, as we have the cost is much better, and there is many generics as well. So why, despite of all of these activities and conferences about the value of these classes of drugs, they are still underused? I'm still concerned. The data I've shown you about the prevalence of diabetes and prediabetes or so forth from Dubai, it includes equal proportion from all sectors of the community, regardless of their income, because we wanted it's a WHO standards of stepwise, and obviously it would be important to have the blue collar and as well as the others as well. So there is no economic bias in the sample, and then the data are factored for the size of the population.
Thank you. I have a question for you, sir. It's about the recent comment by the Alliance, Global Alliance, that the gender studies in diabetes are very few, and they've given a call, which I'll show in my slides in next talk, that the more gender difference studies have to be done, and we have called the diabetes in women distressful, different, and I mean, it is often dismissed by the male members that they get. I think what Meena said is quite correct. I'll allude to it. Thank you very much. My question to Sasank, who had to go out suddenly and will come back after some time, is that what he said is absolutely true. We should popularize remission and not by the reverse Wallace reversal and cure. I think that's my take on that, because that is what we have said, sir, that we should more emphasize on the remission than on the reversal and cure. If it happens, happens, because they are different kettle of fish. When you say diabetes can be totally reversed. The third and final point I wanted to make, of course, madam is not here, is that we have a diabetes in young study in India. We call it DIY, and I chair that group. Now we have, as he showed, a group of type 2 diabetes in the young adolescents. And as he rightly showed, we call it malignant diabetes because they develop all types of complications. They develop all types of obesity, onwards comorbidities, and they die very young. So I think a special focus needed as type 1 focus. We also need a focus on type 2 diabetes in the adolescents. Thank you.
If you have any questions.
I have a question.
Dr. Inas has also joined live, so
Oh,
she's with
excellent.
us.
Excellent.
So, okay.
Please go ahead, sir.
Please ask.
Is the smoking and the alcohol consumption in India very much different between men and women?
Sure.
There she is.
Interestingly, we miss heart failure in women more often that because probably they're obese, and even when they go to the consultant, heart failure, breathlessness might be dismissed as being psychosomatic or because they are obese. So I think another message to the audience is not to miss heart failure in obese men and women both, but more heart failure is missed in women. And yes, smoking is the statistics are that men and women, huge difference. Culturally, we don't see many women smoke. The younger ones maybe, but still the percentage is not more. It's much more in men statistically.
We have Professor Inas joining us live from Cairo. So if we have any questions or any comments for her, you're most welcome. Mike.
Title what you spoke about type 2 diabetes in obese young adolescents. Type 2 diabetes in the young obese adolescents. We have called it malignant type 2 because they develop, as you rightly showed, all types of complications very early and they also die early.
It's serious to have type 2 diabetes in the young because the young adolescents or early in life, this patient will suffer complications, both microvascular and macrovascular complications.
Any questions, any comments?
I would like to ask you, Professor Inas, it was a wonderful talk. I'd like to ask you, do you screen children at the age of 8 years and at puberty in ethnically those who are ethnically at risk, plus if they have a family history of diabetes?
I beg your pardon, I couldn't hear your question.
Ma'am, can you repeat your question, please?
Yeah. For people, children at risk ethnically with a family history of diabetes, do you screen them at puberty universally?
We don't actually, but we have to. We have to, according to AGA recommendations or according to Canadian recommendations. We should even start screening according to Canadian recommendation, according to the guidelines 2018, starting from the age of 8, if there is 3 risk factors or more. And according to the American, if there is obesity or overweight and another risk factor. So we should make detection at schools, for example, for obese children. Every 3 years, for example, to start screening for diabetes or prediabetes. Yes, we must.
Okay, thank you. Any other questions to Professor Inas?
Thank you, Inas ma'am, for joining us live. Since this was a keynote lecture by you and Dr. Mohammed, we would like to felicitate you since we cannot felicitate in person. So kindly accept our virtual felicitation and I'll request, can I have the felicitation please? Dr. Mohammed sir, please join us. Dr. Chawla. in us, ma'am. We're missing you here, but we would like to felicitate you. So we would be honored to present this citation and a shawl to you, and we'll see how we can send it to you, Cairo. Maybe we'll hand it to you when we meet. So thank you so much for being with us, and we're honored to have you with us, ma'am.
Thank you very
Thank
much.
you,
It's
Professor
my pleasure
Inas.
and honor.
We surely are missing you. Maybe another 2 days and we could have had you here. The visa issues, I understand, but thanks a lot for delivering your keynote. And we have requested Mohammed to carry your scroll, shawl, and memento to you once we come to Egypt. Thank you. Thanks for being with
Thank you
us.
very much.
Thank you.
Thank you.
Thank
My
you.
pleasure and honor. Thank you.
So without wasting much time, we'll run a quiz session again. We'll try that. We'll cover up both the sessions of quiz. So I request everyone to scan as we have barcode here. Everyone is requested to scan the barcode. I hope everyone has scanned. We have only 6 players. I request everyone to join. I request everyone again to scan who has not scanned yet. Please. Ankit, can you help Meena ma'am to scan? So let's go ahead. It takes too much. दूर से नहीं So we have 13 players now. And the first question here. Which specific intervention targeting the gut microbiome has shown potential benefits in type 2 diabetes management? And you have 20 seconds. 8, 7, 6, 5, 4, 3, 2, 1. So 7 persons have given the right answer, and we'll see after 3 questions who is leading. So
what is a primary factor associated with the development of MASLD in patients with type 2 diabetes? Is it increased vitamin D level, low carbohydrate diet, excessive physical activity, or high serum insulin level? Very easy question. So 8 people have given right answer. So we can see here on leaderboard, Boti. You are Boti? Okay. So Dr. Meena ma'am has won this quiz. So I'd request Shalini ma'am to present prize to Meena ma'am. So again, we have three questions, and I request everyone to scan the QR code. Yes. So we have 16 players, 17 players ready now. So the first question, which medication has recently been shown to induce remission in type 2 diabetes patients through weight loss? Is it GLP-1, metformin, SGLT2 or sulfonylurea? Again, very easy question. Now we have 5 seconds left. Let's see who is leading. 16 players have given right answer. So almost everyone has given right answer. Next. So what is a significant difference in cardiovascular disease risk between women with diabetes compared to men? Women with diabetes have a lower risk of heart failure. Women with diabetes have a lower incidence of stroke. Women with diabetes have a higher relative risk of coronary artery disease, and there is no difference in cardiovascular risk between men and women. So 4 persons have given right answer only. Next question. So which gender has higher risk of developing heart failure with preserved ejection fraction in the context of diabetes? Men, women, both have equal risk or none of the above? Oh, 10 persons have given right answer. Next, let's see who is leading after 3 questions. Now Johnny. Who is Johnny? Come on, Johnny. Come on the stage. And I request again Shalini ma'am to present prize to Mr. Johnny. What's your real name? Dr. Dev. Right. Here we have, you can come here. So now we are moving to the next session, and that is CMRE oration. And for that, we have chairpersons Dr. Rajiv Chawla sir and Dr. Shalini Jaggi ma'am. I think they don't need any introduction. They are organizers for CMRE. I request them to take over.
Good morning. This is a very important oration, so I'll request Dr. Chawla to read out the citation for this oration.
It's our pleasure to have amongst us Professor A.K. Das, patron RSSDI, patron DIPSI, mentor to all of us, a teacher of teachers amongst us, and we are pleased to confer upon him CMRE Lifetime Achievement Award and this oration. Professor Das has been a Professor Emeritus Medicine and Immunology, Dean Academies, Mahatma Gandhi Medical College and Research Institute, Shri Balaji Vidyapith, Pondicherry. Currently is serving as Chairman of the Academic Committee of the National Academy of Medical Sciences, New Delhi. A former professor and head Department of Endocrinology, Cmre, Pondicherry, one of the most prestigious institutions in this country. Former Director, Indian Institute of Diabetes at Trivandrum. Honorary Physician Sir Aurobindo Ashram, Pondicherry has, to his credit, 206 publications in international and national journals, has been past National President API, has been past President Research Society for Study of Diabetes in India. He is past Dean Indian College of Physicians and currently serving as Department of Medicine in Molecular Medicine, and has also served at Sweden, Stockholm. He is also a visiting professor to Mayo and Endocrine Department, Mayo Clinic, Rochester. So with that brief, I will not say it's introduction upon him. He is himself an institution. It is very difficult to define or to talk anything about Professor Das. To us, he has been a father figure, Professor Das.
Shall I start? Shall I start? It's a great moment in my life. I'm extremely grateful to the CMRE organizers for giving me this honor, and I'll cherish this moment always in my life. Thank you very much. Dear friends, what I have brought for the presentation today is not exactly based upon the original work, but it is based upon something which is of vital importance for all of us to take home. I'm going to talk about diabetes complications, comorbidities, and multimorbidities. Dear friends, I will make it clear that I'll be speaking about comorbidities much more because on this forum, last year, I had spoken about comorbidities, multimorbidities, so I'll be confining myself to the complications and the comorbidities, except two slides which are on the multimorbidity. Dear friends, what is comorbidity? What is multimorbidity? I have not put this full slide here because that was last year's slide. Comorbidity means at least two conditions which is related to the index case. The comorbidities of type 2 diabetes are many, starting from the CVD, stroke, to neuropathy, to NASH, everything that is occurs because of the index diabetes case is comorbidity. The multimorbidity, the best example is when they develop mental aberrations. It can be Alzheimer's, it can be non-Alzheimer's. I've just given an example. There are many conditions which are include multimorbidity. We discussed it last year. Suffice it to mention that even the asthma and the back pain are also included part of the multimorbid type 2 diabetes mellitus. It only underscores the fact that to treat type 2 diabetes, one needs a general physician to be in the multidisciplinary team. Dear friends, the other thing I like to speak today is based upon a few of the work that we have done. In the 30 minutes allotted, I will not be able to do justice to the publication that we have and the work we have done organized in front of me, my colleague of long time from JIPMO. We had a lot of work on the diabetes, hypertension, heart and kidney, the deadly quartet. I'll touch upon it. I'll just take 2 minutes to go through it quickly. We had talked about the diabetes, heart, the interlink, diabetes and hypertension, diabetes and kidney, and what are the upcoming areas? We published a book through API, edited by me, called Unraveling the Deadly Quartet, Diabetes, Hypertension, Heart and Kidney, which I'll allude to in the middle of the talk. We also did some work regarding diabetic cardiomyopathy, which I will not be showing here today, except that we had in our own journal in RSSDI a special issue where I spoke about this specific heart muscle disease in diabetes mellitus, which occurs at what we call today not quote unquote today established diabetic cardiomyopathy. We also had the issues where we discussed about diabetic heart disease. So I'll take today as the corollary of the comorbidity, diabetes and CVD. We had some work, Professor Mohammed, on the diabetes and women. We published the untold story of diabetes and women. And we showed many things. But what suffices to mention is the fact that the prevalence of diabetes and GDM has increased. Protection from CBD is lost after menopause. CAD, heart failure, reinfarctions are more common in diabetic women in our country. Diabetic cardiomyopathy and heart failure, as you just now heard, is also more common. And rightly said that diabetic per se and diabetes heart disease in particular are difficult, different, often dismissed by their dear husbands, but they are deadly. So I'll just show some issues which have come to the forefront today. This is our work. This is a very important thing that I will not have time to go through. But we have pinpointed through the Swedish work that Mohammed again alluded to. I was in Karolinska for about over a year. So this is about the basic disease and what it affects. Kidney, podocytes, retina, pericyte, nerve, neurons, and the arteries, in general vasculopathy, endothelial cells. And we'll see what the current thing about taking care of them. And finally, it's about diabetic cardiomyopathy. We have shown the various pathological changes which will come in the course of discussion. The issue of the advanced egg products. We have shown the pathogenesis of hyperglycemia, fatty acids, protein kinase C, RAS, aldosterone-induced fibrosis, the microvasculature, the hypoxia, endothelial dysfunction, and autoimmune neuropathy. Dear friends, we have described the stages which has been accepted. We wrote about the specific heart muscle disease in the JAC, Journal of Cardiology, and also the structural functional correlationship. So dear friends, I'll stop about the work that we have done in this field, and we'll confine today to the this important remember that I started my work in diabetic neuropathy and the foot in 1986 in British Diabetic Foot Lab in the King's College Hospital with Peter Watkins and Mike Edmonds. And we that time popularized, already existing in our country, quantitative sensory testing like the biostistometer and the sensory testing and the ABI. We also did recently, every year we do, last 3 years we did not have the chance to do it because of the post-COVID. Diabetic food education program, we do it for 3,000 physicians every year. My partner in this crime is no more. So we have now dedicated the program to our dear friend Dr. Sarath Sensei, my classmate, my very dear friend. And this DEFET program is dedicated to Professor Dr. Sarath Sensei. This year it will be held in November. So this is the outline of my presentation today. we'll discuss mostly diabetic complications because they are mainly comorbidities, and the related comorbidities: diabetes-induced CKD, neuropathy, foot ulceration, retinopathy, and some summary. Dear friends, I sometimes wonder that the congestion of diabetes is addressable. It can be controlled. Early life under nutrition, tell me which one cannot be addressed. Early life under nutrition, these are the factors which influences the development of the type 2 diabetes mellitus. Anup, I have taken from the nature review, first three slides from nature review, and you will find that early life under nutrition addressable, malnutrition addressable, that gives rise to beta cell underfunction and IR addressable. We have excess postnatal nutrition, the garbage in and not garbage out, garbage in is garbage on. We have behavioral changes like discussed physical activity, increased calorie intake. We discussed, Mohammed beautifully spoke about the smoking increase and the post-sleep quality. And you know, except genetics, which we cannot address, cannot choose our parents. Many youngsters can choose their in-laws. There's also loss for us. Now, what are the distinctive features of type 2 diabetes in India, and can we address it? The things that we can address is possibly the West Circumference. I think Anup in his wonderful work will show about the new definition of the BMI and the fat and etc. And it can be addressed. The IR issue can be addressed, and the prevalence of BMI lowering, prevalence of coronary disease and kidney disease, the microbiome, the taking care of the kidneys can be very easily addressed. Now, if you compare the Indian versus Chinese, I don't know why Calvin is so fond of Chinese, but he has compared Indians with Chinese. You know, in Indian population, the fast-paced insulin secretion is affected. In Chinese, both first and second phase, we have increased IR at the liver. They have more IR at the skeletal muscle level. We have more of impaired fasting glucose, difficult to treat. In the pre-diabetes treatment, we were trying to use DPP-4 so that can increase the secretion and impaired glucose tolerance, and that is the difference between the two nations. Let us see whether the factors that lead to complications can be addressed. The theme of my talk today is that like Nachiketa went to Jama and asked why men are not immortal. And Jama answered in his unimitable style, he said men do not want it. So why diabetic complications occur? What are the factors that make it higher? Phenotype, central obesity, metabolic syndrome can be addressed. Metabolic, like increased C-reactive protein, IR, inadequate hyperinsulinemia, increased triglyceride, and small dense LDL. And we have genetic predisposition cannot be addressed, and dietary more of carbohydrates and saturated fat intake. How can we make it lower? By increasing ways and means to adiponectin, to increase HDL, intake of dietary. I will not drive home to the cold to Newcastle, vegetable, vitamins, minerals, poor quality nutrition, by physical activity. I think physical activity has emerged as a singular point for treatment of diabetes and its complications, and the health-seeking behavior. Tissue hypoxia. This is a very important concept in developed diabetes complications. This occurs because of scarcity of the vascularization. There is degenerative degradation of the vasculature, and there is skeletal oxygen consumption, and also because of the thrombosis and the RBCs, which can become defective. This cartoon shows that how diabetes-induced hypoxia produces multiple complications. The first one on my left is the healthy, where you find the body fat is central, optimal, blood glucose is optimal, and he has optimal oxygen level, no hypoxia, and the person is healthy. In contradistinction, you find the risk factors being unhealthy diet, we bring the smoking, being the lack of sleep, lack of physical activity, which makes one obese, makes one, of course, makes one the high in blood glucose, high in body fat, and produces not only type 2 diabetes mellitus, but also diabetic complication as given here. It's a very simple cartoon which has been used by UN to teach about how to prevent diabetes complication. Taken it from there. If you look at the protective factors that can stop the pathogens of diabetic complications are hyperglycemia, dyslipidemia, and hypertension. Eminently treatable, addressable. Systemic and tissue-specific risk factors that will also addressable to a great extent. And the protective factors like preventing the glycolytic flux and the various things which we'll discuss in the course of the lecture. Now, what are the diabetes-related multimorbidity? Dear friends, multimorbidity refers to either in the wider system context, either they are proximal or they are distal. The proximal factors are like behavioral factors like smoking, the exercise lack, the diet, the psychological factors, stress, anxiety, self-efficiency being lost, clinical factors like lack of screening, quality of care, the timely intervention not being available. So these are the things which increases comorbidity and which are really addressable. Now, when they develop multimorbidity, you find the multimorbidity develops in a cluster. I've given you 4 clusters which are very common in the multimorbidity. The first cluster speaks about the clusters dealing with the neuropathy, dealing with the retinopathy and the CVD. The traditional concordant complications like the liver disease, like the certain other issues are there. But there are 3 major emerging complications which I will like to draw your attention. And 3 emerging conditions which is going to be great to treat. One is possibly the mental aberrations, Alzheimer's, and the occurrence of depression and the psychological disease in the type 2 diabetes mellitus. So therefore, if you look at the emerging complications, what is most important are the functional disability, the cognitive capacity coming down. You even can find today, don't call it only brain fog. The cognitive capacity definitely comes down in a type 2 diabetes uncontrolled, and of course the various affective disorders. Now you also have the new complications like cancers, infections, liver disease, and of course the traditional complications. I'll save time not to describe them. Let us come to prototype CVD. Now today we know that the factors which make CVD very vitally present in the diabetic population. Number 1 cause of death is obesity, metabolic syndrome factors, and the IR. What they produce? They produce hyperinsulinemia, hypertension, inflammation, high TG, small dense LDL being high, low HDL, and renal dysfunction and hypercoagulability. It has been shown in one of our recent publications that the heart disease develops on a fertile soil. And the fertile soil is diabetic kidney disease, which is about 45% nowadays in our hospital admitted diabetic patients. So that also gives rise to heart disease. So therefore, endothelial dysfunction and atherosclerotic cardiovascular disease is very common. But dear friends, this has been shown today in cardiovascular diabetology paper in 2022 end that the prevalence of severe type 2 diabetes mellitus is changing. I think again Professor Mohammed alluded to the absolutely fabulous 1.40 records that the Swedish Academy has, and I also had a chance to go there during my 1 year stay there. It is changing. All CVDs before 2016 was between 15 and 45. 2007 to 2017, almost similar, about 32% to almost 40%. 2019 is 35%. So all that I mean to say, the CVDs in the most conservative estimation has not come down, sir. Mortality has increased and prevalence. Coronary disease is almost 26. 7 to 17, 21. 2019, it showed a little downward trend at 11. Heart attacks, see the heart attacks, it has come down. It was 18%. Next decade, it was about 10%. Now it's about 5%. The strokes also have come down. We also see that in clinical practice today. 1.7 to 17.7. Today has come down to 5%. Heart failure has remained at about 3%. People say it's increasing. And the peripheral artery disease in Indian population is about 3%. Dear friends, diabetes and hypertension predisposes to CVD. And the recently published metabolic map of India that we did in June 7th on the Lancet paper of ours, we have shown that the common metabolic aberrations in Indian diabetics happens to be hypertension, 35.5%. This lipidemia, 82%. This 82%, at least one of the either the LDL being high, HDL being low, TG being high. One of the dyslipidemia is almost 82%. And we have a very high prevalence of obesity. Taken the general obesity is about 30%. If you take general plus visceral obesity, it almost crosses 70%. And so therefore diabetes, hypertension together can produce the atherosclerosis, endothelial dysfunction, vascular inflammation, vascular fibrosis, arterial thrombosis, giving rise to microvascular disease, and the cardiovascular disease, which is again eminently preventable. Now, the mechanism whereby diabetes and hypertension cause vascular disease are given here during hyperglycemia, rash, immune activation, oxidative stress, inflammation, and giving rise to disease, advanced glycogen end products, and etc. And that's also responsible for the pathogens of the atherosclerosis. Dear friends, there is a link between the insulin resistance and the atherosclerosis, which gives rise, IR gives rise to, of course, type 2 diabetes, endothelial dysfunction, also responsible for coronary disease, and it has a gene polymorphism. I'll just escape one slide about that, but it has a different gene expression also. These are genetic factors, but beyond genetic factors which are given in this table below, there are a lot of factors which are easily targeted. Apart from the clamp studies which can give you the IR, the greatest and the simplest way of finding out the IR is TIG. I believe that triglyceride to fasting glucose ratio serves a great purpose in showing the degree of insulin resistance in the common clinical practice. It has been shown by doing the triglyceride, fasting glucose. Just do that. TY versus G, triglyceride versus G gives you the degree of IG, IR, and IR is eminently treatable with diet, physical activity. And of course, few drugs are available today. The gene SNP is associated with the IR and atherosclerosis. I will not go into details of it. I brought 3 slides. This will be left with Rajiv and Salini. So you can share this various SNPs associated. So if you want to reduce the severe risk reduction in diabetes mellitus, what we should do? First is, as we heard Dr. Inash, about the screening. Next about the lipid management, the glucose management, and also blood pressure management. Now we have taken leadership in the LAI, Lipid Trust of India, for the lipid management. I don't know whether you agree or not. The values that we have advocated, Rajiv, you were there in that meeting. We have advocated the values of cholesterol at the level of 40, sir, not even 55 or 57. So aggressive lipid management is possibly a great step for the cardiovascular risk reduction. Now, of course, we have the lifestyle management, the glycemic management, use of the new drugs like SGLT2, GLP-1, and the anti-thrombotic management. And beyond this, there are some social determinants which we must address, like the availability of health for all, we discussed some time back, and also the issues of the psychological problem. We call it biopsychosocial problems, and it must be also addressed in the type 2 diabetes mellitus. Now we have GLP-1 agonist, and you find that many of the indirect cardiovascular effects of GLP-1 agonist are very, very important and very beneficial for the heart. Now, if you look at the mismatch between the fatty acid and glucose metabolism, you find that is the most important dysfunction, mitochondrial dysfunction. And of course, this produces many things, including diabetic cardiomyopathy. So elevated effect glucose metabolism in the elevation of the reactive oxygen species, toxic intermediates, and these molecules damage the mitochondria, and then their morphology giving rise to mitochondrial fission, mitochondrial fusion, and damages the heart by cardiomyopathy. So therefore, in the pathogenesis of diabetic cardiomyopathy, these are the factors which play a role. And metabolic alterations of the elevated fatty acid metabolism and down-regulation of the glucose metabolism result in increased mitochondrial activity, generation of the lipid intermediates, and accumulation of the lipid droplets. Mitochondrial dysfunction happen owing to the detrimental ROS, synthesis, dysregulated mitochondrial fusion, mitophagy, and various other lipid intermediates. So if you look at the prevalence of diabetes and diabetic cardiomyopathy with risk of heart failure, and it can be easily addressed by the gadgets we have at our disposal. We can define cardiomyopathy. We can list restrictive. We have now divided into three types: least restrictive, called minimal ejection fraction reduction. First one is 50%. It is about less than 45, and the RF, which is more than less than 40. And all these varieties of cardiomyopathy can be addressed today. Now, what are the other risk factors that increased and they produce the events of the complication? One is atherogenic dyslipidemia. We have drugs to treat it. Today in India, we have the bempedoic acid. We also have the available to us inclisiran. And inclisiran is used more and more twice a year and giving rise to the lipid control. It's available, and if you want to get it cheaper, you can write to us, to LAI. We provide the inclisiran at a very affordable level. The blood pressure, of course, the main drugs, statins. If it does not work, statin resistant, statin intolerant, this can be addressed. High blood pressure, low-grade inflammation, cytokine. There is a study which we have just received from the investigators whether the hydroxychloroquine, which is an anti-inflammatory drug, whether it can be addressed in the prevention of diabetic vascular complications, because inflammation plays a role. It is undergoing the evaluation, so we'll see whether it will be approved or not. And we have got low-grade inflammation which can be addressed. We have renal disorders. Very important to remember that it is absolutely important to measure the ambulatory blood pressure. We have shown, I'm not time to show this here, that the nocturnal non-dippers, by a very tiny instrument available from Pune for 35,000 rupees, one can identify. We don't need ISA 9000 every time. We can diagnose with that machine. We have done that. We have shown that the nocturnal non-dippers are the ones who develop future diabetic kidney complications, albuminuria, and also did various other things. So finding out the nocturnal non-dippers and microalbuminuria and the ratio between the albuminuria creatinine ratio goes a wrong way in preventing the renal disorders. So we have the other things which also can be addressed. Dear friends, there are drugs today which are wonderful drugs to modulate several severe risk factors. Even though we do not know the direct action, how it helps the cardiovascular, renal, apart from glycemic efficacy. It decreases the blood pressure, arterial stiffness comes down, albuminuria comes down, uric acid comes down, glucose, insulin are all controlled. There is a rise in the LDL-C, of course, but the HDL-C also rises. Triglyceridemia comes down, the oxidative stress comes down, weight, visceral adiposity both come down, and the sympathetic nervous system activity comes down. I have not put it here. We wrote an article many of you might have seen called Vascular Euphoria SGLT2, published along with Mangesh Tiwaskar in Japi about a year back. We have shown that this group of drugs, gliflozins, provide the vascular euphoria. What is the vascular euphoria? Euphoria, you know. So all the vascular euphoria, vascular inflammation, the lipids, the endothelial function, all are very complementarily addressed by the SGLT2, which is a wonder drug to be used in such serious diabetic complications. And you know, if you look at the proposed cascade of care for the diabetic with cardiomyopathy, we find that from the screening, we have wonderful drugs today to address it. And if you look at the diabetes status and myocardial fibrosis, you will find that there are various studies where we had more fibrosis and where we had less fibrosis. If you look at the factors that had less fibrosis, were the ones where there were less of lipid droplet accumulation. So this is an animal experiment study that we had done, where by giving Sudan 310, we could find out the tissue triglyceridemia, cardiac tissue triglyceridemia. Today, we do not need animal experiments, where echocardiography machines which can identify lipids in the myocardium, and through that we have found the people who develop lot of accumulation of lipids in the cardiac muscles are the ones who develop more fibrosis, which can be definitely controlled. Now, the other thing is about the heart failure incidence has been correlated to the hemoglobin A1C and also the preclinical heart failure. So therefore, apart from the new paradigm shift in the diabetic heart failure management, including ARNI, MRA, beta blockers, and the gliflozins, these four have been taken as the new drugs for the heart failure in diabetics. It's also important to control diabetes very effectively, keep HbA1c as low as possible. Now this is important what Professor Mohammed was speaking about. I'll be very brief to say that in 2022 paper is from the Alliance. It is clearly said that there is a call to action, and sir, they also support the research proposals for the study the sex difference in diabetes, which was discussed very eminently by Professor Mohammed. Now there are three things on the hypertension, obesity, and diabetes: pathogenesis, epidemiology, treatment outcomes, and gender-based risk and infrastructure to impact risk has to be studied. There are yet current guidelines do not differentiate between the treatment of hypertension, obesity, and diabetes in male and female. They say male equal to female. We never will object to it, I'm sure. The research needed today is in the area of prospective RCTs, secondary raster analysis, real-world studies, and formal gender assessment for this diabetes management. There is control of glycemia. We know the guidelines. We know the targets for the blood pressure control, 130/80. We also have the lipid control targets, which have been given very eminently. Now we know the benefits of the SGLT2 and GLP-1 agonist, which has to be used very eminently, and the recommendation of the anti-diabetic drugs, which are cardiac friendly, also has been given. Now coming to the CKD, the kidney heart risk factor management has found a great role today. Diabetes has a great impact on the nephron, and we find that the newer drugs that are available today, they also impact the diabetic kidney disease, including SGLT2 and the finerenone, and then needed a holistic approach to control it, including SGLT2 and the newer drugs, which include the finerenone and similar group of drugs, various other MRAs. Neuropathy, I will not describe much, but suffice it to mention that what we had done earlier, today also they have the similar views. They're saying that the prevention non-diabetic neuropathy centers around clinical and by instrumentation, identifying the group who are prone. They have say bistoichiometric difference of vibration concentration between 15 and 25, which is early neuropathy. And they are the things which can be reversed. They talk about autonomic neuropathy, which diagnosed early, also can be reversed. So there is a neuropathy which is also very important to study today and find out. And also there is a study today which is called ADCSI, Adapted Diabetic Civility Index and Dementia, and that also can be addressed. So retinopathy I'll omit. I'll directly go to the my conclusions. And suffice it to mention that today we have in our armamentarium drugs where we can address the various types of VEGFs, the various types of drugs for the macular edema and for diabetic retinopathy, and anti-angiogenic drugs are flooding the market for retinopathy. We have for PDR and all the diabetic eye disease, we have new treatments available, including anti-VEGF therapy, which I spoke. So therefore, dear friends, the major risk factors for diabetes complications and comorbidities include obesity, endothelial dysfunction, vascular inflammation, and dyslipidemia. Please remember these four: obesity, endothelial dysfunction, vascular inflammation, dyslipidemia. There is a high risk of CVD complications, ESRD, where diabetes, hypertension combined. There are many barriers to self-care in our country. like lack of knowledge, financial constraint, and logistics for obtaining great care. There has to be also social and emotional support. And key insights must be there in the diabetic physicians, not only manage diabetes, its complications, the comorbidities, and the distal multimorbidities. More patient-centered approach is needed, and more appropriate and tailored therapeutic interventions are also needed. Thank you very much for your patience here.
Thank you very much, sir, for a wonderful oration on diabetes, complication and comorbidities, and your own learnings and teachings which you have imparted across your life journey. So we are happy to have you. This being a oration, there won't be any questions, and we'll be happy to honor you with a memento. Thanks a lot, sir. Thank you.
It is my proud privilege and honor to invite Professor Dr. Anup Mishra, sir, for the CMRE Gold Medal Oration for the year 2024. All of us know him, a very, very well-respected, reputed faculty. Dr. Anup Mishra is the chairman of Fortis CDOC Center for Excellence for Diabetes, Metabolic Disease and Endocrinology, New Delhi. He is director of the National Diabetes, Obesity and Cholesterol Foundation and Diabetes Foundation, India. After completing his undergraduate and postgraduate studies at the AIIMS, New Delhi, he worked at the Royal Free Hospital, London, UK, and also worked at the Department of Medicine and Endocrinology at Southwestern Medical Center in Dallas, Texas, USA, as a WHO fellow and later as a faculty member. In India, Dr. Mishra has participated in top advisory committees relating to diabetes, cardiovascular disease and nutrition, and has been an advisor to the Ministry of Health, ICMR and Department of Biotechnology on several issues related to diabetes and NCDs. He has more than 40 years of experience in teaching, services, research and community health intervention programs, has published more than 365 scientific papers or chapters in national and international journals. Citations as of September 24, he's got 48,000 plus citations with an H index of 110 and an I-10 index of 481 and books. In 2021, according to the analysis by Stanford University, he ranked in the top 2% scientists globally in diabetes research from India. Sir is editor-in-chief of Diabetes and Metabolic Syndrome Clinical Research and Reviews, a high impact factor journal from Elsevier, and associate editor of the Journal of Diabetes USA. He is member of the editorial advisory board of the British Medical Journal, a member of BMJ's regional advisory board for South Asia, and a member of the Lancet Obesity Commission 23-24. He's received numerous awards, delivered 38 orations, awarded India's highest award for medicine, Dr. B.C. Roy Award, and India's prestigious national honor, the Padma Shri. He's received the Outstanding Investigator Award for the World India Diabetes Foundation in 2013 with current interests including research on nutrition, metabolism, diabetes in relation to liver fat, pancreatic fat, lean skeletal muscle mass, and effects of vitamin D on metabolism. He's launched an innovative project, the Diabetes Care at Doorsteps, which has catered to more than 2 lakh underprivileged people. He believes that everyone with diabetes should have access to quality care. And to that, obesity should be treated as a chronic disease. He's committed to finding new ways to prevent and treat these conditions and to be improving the lives of people affected by them. And is an author of the best-selling books Diabetes with Delight and Diabetes Ke Saath Khushhal Jeevan. So it is our most profound honor to present you with the CMRE Gold Medal Oration for the year 2024, sir.
Thank you, Rajiv. Thank you, Shalini. Keep this. Thank you, Rajiv, Shalini, for bestowing me this honor.
I've never come to this conference previously, but I see so many people attending and wonderful organization. All congratulations to both of you. Today I'll be speaking on the new definition of obesity. Obesity has been something which I've been passionately following as far as research is concerned for the last 30 years. And first in India, then in the United States, and then back to India. And concentrating on the Indian population as far as various aspects of obesity is concerned. I start with a good quote from my favorite author, Stephen King, in It. And he tapped my forehead right where his damn whistle had bumped me. That's where everybody's fat. You put that what's between your ears from a diet and you're going to lose weight. Wisdom of Stephen King is something what we should learn. This is the obesity statistics from India. Now this is the data taken from National Nutrition Monitoring Bureau. I was a part of it in 2017. And if you look at that, there is a rising curve from the less developed states to highly developed states. And more obesity in women. Look at this, 50% almost in several states versus men, 30 to 25 to 30%. So this is the state as far as 2017 is concerned. But if you look at the overall picture of obesity versus the undernutrition, this is a recent paper, just 2 months back. And if you look at this paper, the data have been taken from 1999, 2006, 2016, and 2021. As far as severely thin is concerned, it has gone down. Mildly thin, gone down. Normal, slightly increased. Overweight, increased. Obese, increased. And this is for as far as women is concerned, this is for men. So underweight has decreased, overweight and obesity has increased. This is our recent paper, a couple of days back in Metabolism, published worldwide, global burden of disease. The data extracted the disability adjusted life years daily, means life years lost due to a disease. And these are the top 5 countries, China, India, Russia, USA, Brazil, Indonesia, Germany, etc. coming in between. Mexico is also there. But look at ranking of India in 1990 and 2021. And this is terribly important because not only type 2 diabetes, as far as daily is concerned, we are number one. Hypertension, we are number two, remain number two. Obesity from 4 position, we have moved to number 2. And high cholesterol, number 2. And metabolic associated fatty liver disease from 1990 to 2021. Though more research is required in any of these areas, but this is the daily, and this is, I'm part of this particular paper, but this particular paper has been written by Chinese authors taking data from global burden of disease. And we have been in forefront of obesity research. And if you look at the symptomatic analysis, not from my group, from somebody else, who did analysis of obesity research and publication from India in 2007 to 2000. This is exactly the point where I left All India Institute of Medical Sciences. To 2016, our name is on the top. Of course, there are fine researchers in India who are doing obesity research all the time. Coming to the Indian body phenotype. And this is very important for you to understand because this is what will lead to any changes as far as definition of obesity in India is concerned. This is the paper which we wrote in 2004. And we looked at the Asian Indian population, rural, urban, slums, urban, migrant, and then other population like the Chinese, Mexican Americans, Caucasians and African Americans. Their BMI, look at this, we have the lowest BMI still. But if you look at the body fat, we have the highest body fat, 33%. Look at the African Americans where the BMI is highest, the body fat is the lowest. It gives the idea as to how much body fat we have even if you're normal weight, if you're normal, even then you have high body fat as compared to other population. Now, at what BMI do we develop diabetes? This is very important because that's where the cutoff should be for prevention. That's where cutoff should be for BMI. Now, if you look at this, this is the comparative data, South Asian, Chinese, blacks and whites. And we developed diabetes in this paper in 2024 BMI. We have looked at the comparative data of UK versus India also in another paper and similar conclusion. By Chinese at 25 and blacks at 26 and whites at 30. So at 30, if they have a BMI of 30, they will develop diabetes more often. And we have BMI of 24. We will develop diabetes. So this is the status as far as BMI versus diabetes is concerned. And what about the other metrics of obesity, for example, abdominal obesity? And this is, we have number of studies, and I'll just show you representative data or representative single slice MRI image. We have been doing a lot of MRI studies of abdomen, because abdomen is something which we should look at when we are looking at other metrics like waist circumference, waist height ratio, waist hip ratio. Now here is the white portion is all fat, and this is the intra-abdominal fat, and this is the subcutaneous fat. Remember, subcutaneous fat is highest in the lower regions of abdomen, but truncal region also it is quite high. And then there is the fascia here which divides superficial from deep subcutaneous fat, and we have earlier shown that it is the deep layer of subcutaneous fat which is metabolically active and may be more important as far as the Indian population is concerned. It is also thicker than the Western population. We have all the data. Short of time I will not be able to show you, but the subcutaneous fat is thicker as far as Asian Indian population is concerned, and has almost 3 times the mass as far as intra-abdominal fat is concerned. Hence, it is a prime determinant for various factors like non-esterified fatty acid, and then determining the insulin resistance. This is the we have isolated the deep subcutaneous fat using a software, and we have used it in multiple studies from 2005 onwards to 2023. This is another seminal study which compared the non-obese people in USA, Caucasians versus the Asian Indians. They looked at the liver triglyceride using MRI spectroscopy, and if you look at here, this is the stark difference which we see here. Clearly, the liver triglyceride is 2.6 times more for similar amount of body fat, similar age, BMI, everything. We have much more liver fat. And this is particularly detrimental, since now liver is the actually center point of metabolic universe as far as Indian population concerned. And this study, you see that these people are more insulin resistant. Now the same study, non-obese, non-diabetic Asian Indians, age 29, BMI, seemingly non-obese, have higher inflammation. This is particularly important because inflammation is possibly the center point now of all the metabolic disorders and emanating from various adipose tissue. Now, if you look at interleukin-6 level, this is the comparative data between Indian population with Caucasian, and you can see twice the amount of interleukin-6, which is the inflammatory parameter. And my colleagues in Dallas, at that time when I was doing studies there, these people were also looking at the various other parameters in South Asian population, what is called as Dallas Heart Study, and compared Indian population with white Caucasian as far as the inflammatory genes are concerned. And if you look at this, these are comparable population here. And if you look at the various the genes and the inflammatory parameters which are higher as far as Asian Indian population is concerned, meaning thereby inflammation is higher and emanating from high body fat, high liver fat, high subcutaneous fat, high possibly deep subcutaneous fat. So adipocytes are also larger. Now there's a comparative data again that adipocytes are larger and more insulin resistant, more pro-inflammatory. Overall, these are sicker adipocytes than the other races. Now, if you look at this, there are plenty of inflammation in the adipocyte population. If you look at this, all full of inflammation. This typically a person, Indian person who's become slightly obese, has abdominal obesity, has liver obesity, and has a sick adipocyte. So, if you want me to summarize the data as compared to any other race, so mostly the data have been taken from the Caucasian population, as compared to non-Hispanic whites, we have a lower BMI, higher abdominal adiposity, subcutaneous, visceral, or both, and deep subcutaneous. Higher liver fat, higher magnitude of insulin resistance, and possibly lower beta cell secretory capacity, lower age and BMI of onset of diabetes with rapid conversion from pre-diabetes to diabetes, and higher inflammatory marker. So that leads to our main topic. In 2009, we made the definition of obesity in Indian population. What prompted us to do that? Asian Indians develop morbidity at lower BMI based circumference. I showed you the graph. And limits of BMI have to be lower than for whites. This was the basis for 2009. This is conventional wisdom at that particular time. And since then, many other studies have come in. And if you look at the current thinking, which is more rational, 2024, that Indians have excess body fat, abdominal fat, liver fat, which induces more inflammation and insulin resistance than white, and leads to more morbidities, and this phenotype is one of the bases for new guidelines. So revision of guidelines for obesity for Indian population, a couple of nuts and bolts which I will tell you. First, look at the previous definition, which was cited now. This is August, now more than 1,500 times. This is in a journal called Journal of Association of Physicians of India. Publication in 2009, which revised guidelines for obesity as well as abdominal obesity, led to rethinking of BMI cutoffs worldwide for Indian population. And this was in UK. That led to rethinking there. They lowered the guidelines. Also, to some extent, in American guidelines, where screening for diabetes for Asians is now at BMI 23. Now, this is the guideline. The overweight, 23 kg per meter square, as opposed to 25 WHO guideline. So we lower the BMI. And the reason I have already told you. Obese 25 as opposed to 30, waist circumference 90 for men and 80 for women, again lower than what has been shown in the various world guidelines. Now this is in 2008, 2009, 16 years have gone by. There are number of new concepts which have come. One of the major problem is BMI, a good measure of obesity or organ dysfunction. Now, excess BMI does not always mean excess adiposity. For example, look at this. Wayne Johnson here has a BMI of 33.5 kg per meter square. Would you say that he's obese? His body fat is not in the category of obesity. His muscles are too big. But BMI is 23. He will be categorized according to BMI as obese. He is not. So BMI doesn't capture the full complexity of obesity-related health risks, and BMI alone may not truly reflect cardiovascular disease and other metrics such as waist circumference and waist ratio, again showing importance of abdominal obesity, may be more useful. And we published this long back, almost 2 decades back. BMI does not accurately predict overweight in Asian Indians and North India. That has been cited multiple times. Now there are other people who think that certainly BMI is not the good idea. So we go ahead further. and look at multiple other things. For example, metabolic complications of obesity, mechanical complications, mental and milieu. For example, this staging is the Edmonton obesity staging from my friend Arya Sharma. Stage 0, 1, 2, and let me just tell you what stage 2 means. Moderate metabolic complication, type 2 diabetes, lipid abnormality, PCOS, mechanical OSA requiring PAP therapy, GERD, pain, moderate limitation in the activity, mental and milieu problems in relationship, etc. This is so complex. It is rational, but very complex. Now, if you're sitting in OPD and seeing, say, 25, 30 patients or somebody sitting outside Delhi in a remote area, will he be able to follow this guideline? It's unlikely. It's highly unlikely. And if you're going to follow, you'll take multiple tests and also lot of your time just to diagnose obesity. So I'm certainly not in favor. We had lots of arguments with Arya Sharma on this. He stuck to his point and we stuck to our point. So, what are needed to make any guideline for India or for matter globally? It should be simple, widely applicable in all settings, reproducible, based on generally reliable evidence, based on general consensus, and should be ethnic specific. The ethnic specific is particularly important, and we made the ethnic specific guideline in 2008. Now, keeping this in mind, last WHO guideline was made in 1999. 25 years have gone by. Other regions have made their own guidelines. WHO is not replaced. That continues. Lancet, last 1 year, we have been deliberating in search of rational and simplified definition. This is almost complete and will be online in maybe a 4 to 6 weeks time. And I'm a part of it, and we have ethnically directed limits of BMI waist circumference in this particular guideline also. India Obesity Commission was also started at the same time. To establish a consensus on diagnosis and management of obesity in Asian Indians, our approach involved soliciting opinions from experts in the field, and 5 steering committee members and the multiple experts, 83 experts, 5 Delphi rounds were conducted. I must say, for disclosure, that some of the thoughts for this guideline have been cross-fertilization of ideas with the Lancet guideline also, and I have disclosed that in front of Lancet 57 experts which deliberated the guideline, and we were very transparent about it. So unpack the ifs and buts and essential nuts and bolts. Rely solely on BMI? No. Relying solely on BMI may not effectively identify individuals, I've told you, and with high body fat or predisposition to obesity-related diseases. Consider adding another measure of obesity to BMI? Yes. And this will be waist circumference or waist circumference height ratio. They have advantages and drawbacks. Combining them with BMI could enhance accuracy of identified cardiovascular risk in these people. So BMI plus one more. Consider adding functional and mechanical symptoms. Somebody who has the BMI of 30 has a major knee problem, cannot walk. Yes, certainly. That is something we should consider. And consider adding comorbid disease, no doubt about it. We should consider. So all these need to be considered in the new definition of obesity. So revised definition of obesity. Again, I quote, I'm overweight, I can tell that, but there are all the kinds of overweight people in the world, aren't there? And the important thing is, I'm trying to do better. I'm sure the previous guidelines also made people try to do better. This guideline also will enhance on that. Slide, but most important. Stage 1 obesity, only 2 stages. Very simple. Anybody can understand, doctors, nutritionists, paramedical workers, general public. Inoffensive, excess body fat alone. There is no adverse consequence or consequences. Stage 2 obesity, problematic. abnormal anthropometry excess fat with adverse mechanical or metabolic consequences. Now, the stage is set. You already know all this. So, stage 1 obesity example. A 57-year-old man with a BMI of 28.5 can walk 5 kilometers per day at brisk pace. I'm sure many of you are like that. His blood glucose and other laboratory parameters are normal. No problem there, though his BMI is high. Is stage 1 obesity. We need to keep a watch. We need to encourage him to continue doing so that he doesn't develop anything. So this is something where we are going to advise them, but not extremely aggressively if they are following everything. But the second 60-year-old lady, BMI of 30.5, waist circumference of 90, body fat of 38%, asymptomatic, does 30 minutes of aerobic and strength training daily, blood parameters and cardiology tests are normal. Again, we have to encourage this lady, but not very aggressively if all these continue to be normal. Stage 2 obesity. A 65-year-old lady, BMI of 32 with osteoarthritis of knee, posing difficulty in walking. Something we must reduce weight. We must be aggressive. 50-year-old man having BMI of 39 with diabetes, hypertension, nephropathy, and edema of fluid. Clearly, something which we have to use some, maybe drugs also, to decrease weight. And a 45-year-old man with a BMI of 31 having dyspnea and palpitation on day-to-day activity. Again, we have to do something about it. So, this is the composite diagram. We take BMI of 23 as a cutoff and divide into two stages. Stage 1 obesity and stage 2 obesity. Remember this paper is in press and will be released at the same time that Lancet releases the guideline. So aligned with Lancet, it may be 4 weeks, maybe 6 weeks, something like that. Stage 1 BMI equal to more than 23. Optional, you can do waist circumference, waist height ratio, body fat, but it doesn't matter. This much is enough if there is no symptom suggestive of limitation of day-to-day activity and no obesity-related comorbid disease. So easy to do in any OPD setup. Takes 2 minutes. Here it takes longer time because BMI has to be calculated, waist circumference or waist height ratio needs to be calculated, and maybe some people who have can do body fat can be done. Plus one of the following: obesity-related limitations in day-to-day activity, one or more. Here are some of them, or obesity-related comorbidities. So 23 plus 1 plus 1. Very simple. This is something which is applicable, is rational. Here we be aggressive, not only by lifestyle factor. Even at 24 BMI with a lot of problems, you can use SGLT2 inhibitors, GLP-1 receptor unlock to lower the weight further. There is nothing like 27 you have to. This is the thing that needs aggressive management and reduction of comorbidity or the other symptoms which I have listed. So this is the proof of the paper, revised definition of obesity in Indians living in India. I have already spoken about India. I'm sure similar situation occurs in anywhere the Indian population is there. And this is my conclusion. We present a new definition of obesity for Indians under publication, aligned with worldwide new definition of obesity, soon to be announced by Lancet. Thank you, Rajiv. Thank you, Charlie.
There's a stand oration. Thanks a lot for having accepted our invite for this oration. We are blessed. To me, he is like an elder brother. The researcher from this part of the world, not from Delhi, not from India, he is amongst less than 1% across the globe who has been recognized with his research.
Thank you, sir. You don't have to stand.
Thanks a lot.
Thank you, sir.
Thank you, sir.
Nice. Thank you, sir.
For inauguration, you have to be with us.
I'm here.
We'll just have the inauguration starting in another 2 minutes, so I'll request everyone to stay seated.
For two questions only. So everyone, please scan this QR code. Everyone is requested to scan the QR code. We have 13, 14 players ready. 16, 17. Let's see. So the first question is, which complication is most commonly associated with diabetes and hypertension comorbidity? Is it retinopathy, neuropathy, nephropathy, or dermatopathy? 13 players have given right answer, and that is nephropathy. Next question. We have 22 players now. So what is the revised BMI cutoff for defining obesity in Asian Indians? Dr. Anup Mishra sir already has taken this part in his talk. So is it BMI more than or equal to 25, more than or equal to 28, 30 or 23? Let's see how many people have given right answers. Wow, 14. And still 5 have given wrong answer. This is quite surprising. So let's see on leaderboard who is leading. Again, Johnny is leading. Johnny, please come on stage. Dr. Dev, right? Congratulations, Dr. Dev.
We'll have the prizes during the valedictory.
Okay, so thank you very much.
Can I request everyone to be seated, please, for the inaugural ceremony? So it is my proud privilege to welcome all of you for the inaugural of the 11th International Symposium in Diabetes by CMRE. We've been collaborating with numerous partners. First day we were partnering with the Arabic Association for Study in Diabetes. Yesterday we collaborated with DIPSI. And today is the annual 11th CMRE International Symposium in Diabetes. May I invite the following faculties on the dais, please? Dr. A.K. Das, sir. Can I request you to join us on the dais for the inaugural, please? I'll also request Dr. Anup Mishra, sir, to join us on the dais for the inauguration ceremony, please. It's a privilege to have Dr. Mohammed Hasnain with us, who's been our partner and the biggest pillar of support ever since we started the first conference, and this is the 11th one. So I'll request Dr. Hasnain to join us on the dais, please. I would like to mark the presence of Professor Inas Shaltout, who could not join us today physically because of some visa issues from Cairo. She has been our partner as a leader of AASD, the Arabic Association for Studying Diabetes, are one of our partners in this conference and propagating academics and taking it globally across the boundaries of the country. So we welcome Dr. Inas and thank her for her partnership. I would also like to document the support of Professor Shashank Joshi and Dr. Banshi Sabu, who had to leave because of some prior commitment. So they cannot be here physically for the inaugural, but they send their words of thanks and support to CMRE. Before we go forward, I also would like to document the presence of ACE CEO, Mr. Johnny White, who has collaborated with CMRE for the first time this time. And yesterday evening we had an ACE symposium, a joint CMRE ACE symposium with faculties joining in from ACE, and we will be playing his address very soon. So all these dignitaries, I welcome all of you as director of CMRE on behalf of my co-director, Dr. Rajiv Chawla. And I would request everyone to join us for the lamp lighting. All the dignitaries on dais, please join us for the lamp lighting as we have the God's blessings, Saraswati Vandana. Can we have the Ganesh Vandana, please? Please join us for the lamp lighting, sir. Sir, please join us. Dr. Vinod Kumar, sir. You have been our mentor all throughout. So it's a very proud privilege to have this 11th year of the International Symposium in Diabetes, and all our faculties, all our delegates are our strength. Can I request Dr. A.K. Das, sir, to give us his blessings, please?
My dear Rajiv and Salini and the entire team of the CMRE and the very eminent personalities on the dais and off the dais and my dear friends. In today's world, diabetes and its comorbidities, multimorbidities, its complications has become most important contemporary challenge. No doubt about it. We had previously some diseases we used to say, know about syphilis, no whole medicine. Today, diabetes has probably assumed even a greater scientific advance where there has been great outburst, explosion of new knowledge. And also diabetes is the forum on which there is relentless advance. And you have seen the advance today. You saw our own Anup projecting before us the advances in the BMI. I know that was in 25 years back, and he gave the new definition today. So dear friends, there is relentless advance against a relentless disease called diabetes and comorbidities. To keep abreast with the advances and to apply it for the benefit of the patients is the objective of the CMRE. Long live CMRE. Blessed was the day when it started 11 years back. There has been a very good continuation. Let all wish and pray, no end, endless perfection. Thank you.
Thank you so much, sir. Dr. Rajiv Chawla, my co-director CMRE, a few words from your side, please.
Good afternoon. Dignitaries on dais, Professor Das, Professor Vinod Kumar, Professor Anupesha, Professor Mohammed, and my colleague and co-director CMRI, Dr. Shalini. Of course, we mark virtual presence of Professor Inash Sheltout, Professor Colin. They have been part of our organizing committee year after year, and this is the 11th edition of CMRE, a conference which we have been organizing early days with Cardiff University, but last 5 years we have partnered with ASD, which is Arabic Association for Study of Diabetes and Metabolism, and we live stream this conference across Middle East and Southeast Asia. And this is just to share with you that on Friday we had a 3 hours international symposium with ASD, which was live streamed, and we had close to 1,200 delegates logged in, and we finished the program at 9 p.m. with almost 900 delegates still logged in that virtual conference. DIPSI has been part of this CMRE conference year after year, and there also yesterday we had a 3-hour symposium with DIPSI, which was a virtual symposium because our mentor, Professor Shishai sir, is not in a position to travel anymore. So we had to organize the entire program virtually, where Professor Piki was there, Dr. Hema Divakar, Dr. Rakesh Sahai was there. Dr. Rakesh Sahai couldn't come in today because his father is not well, so he had to miss his morning presence here. He was part of the inaugural ceremony. This time, for the first time, as Dr. Shalini told you, we have collaborated with ACE. I think we look upon it as a great achievement for not only CMRE from this part of the world, because ACE now has an APEC chapter, which is Asia Pacific chapter, with Dr. Shashank as our chair, Dr. Rakesh Sahai, Dr. Bansi Sabu, me, Dr. Shalini, and Dr. Amit Gupta representing ACE APEC in this part of the world. We are going to carry forward their education modules, their learning, their certification program. We will try to encourage more and more members from this part of the world, not only India, but also from Asia, for getting the membership of ACE, encouraging them to attend ACE meetings physically, and then enable them to be the candidate for getting FACE, which is a very, very prestigious nomination in the international world. So last night we had a symposium almost lasting for 3 hours. We started at 8:15 and finished close to 11 p.m., which was again in collaboration with ACE. So this was the first ACE CMRE collaboration and the symposium. This time, because time was very less, we couldn't have them physically here. Hopefully next year onwards, this partnership further grows and we go to the better steps or bigger steps. So we have had since 9 a.m. today morning a very, very densely crafted scientific program. Dr. Mohammed and Inas madam have been always part of our chair in the scientific committee. With them we have drafted this program. We have tried to cover everything what is possible in diabetes, and because we had 2 parallel halls, so maybe we might look having little thinner attendance, but I think we have already had close to 275 registrations physically here, divided in the 2 halls. it is of course always a challenge, and we accept that there are two simultaneous meetings going on today in Delhi itself, so it is always a challenge getting more and more numbers. But that initiative on our part and effort on our part has been going on, and hopefully it will go in the future also. With those words, I'm sure day along we have another 3 sessions in both the halls. I'm sure delegates are going to benefit from this program, and they will, once they go back home, they will probably be able to carry these teachings from teachers like Dr. Das, Dr. Mishra, Professor Mohammad Hasnain, who is a very, very close friend. Not to tell you, we belong to different ethnicity. Many times I laugh. I say probably you are more than a brother to us. 11 years he has stood with us. The first program I remember we did in Radisson, Paschim Bihar, where we had only 100 delegates. And since then it has been growing. And his contribution, he has been a backbone to us and has been the Sutradhar for this entire program, linking us to ASD and to many more international organizations. So with those words, I once again welcome all the delegates, those who are logged in, and again convey our gratitude to all the faculties, those who have been with us for last 2.5 days virtually or physically today. Thank you very much.
Thank you, sir. It's an honor to have Dr. Anup Mishra with us, and I would request Anup Mishra, sir, to give us some good wishes.
I'm a man of few words. You've seen my conclusion, just 3 lines of the lecture. So just 2 points here. One is I thank Rajiv, Shalini, and all the organizers for this wonderful conference. It's been running for more than a decade now, isn't it? Oh, excellent. And I see wealth of researchers right on the table here. And that gladdens my heart because each one of them have 30 years of research experience behind that. But that's the second thing I want to add, because I see a lot of young people that research is not done enough as far as the Indian population is concerned. And I, being editor-in-chief of one of the high-impact journals from India, I see very little good research coming from India. And this conferences such as this and impetus from the speakers and researchers should spur you to do more research. If there's any help needed, I'm sure there are people around you, or if there's anything, that please email me and I can help you with this. So thank again for this wonderful opportunity.
Thank you so much, sir. Dr. Mohammad Hasnain has been our partner in this entire journey, and I would request Dr. Hasnain to talk about his vision, way forward, and a few memories that we have together.
It's difficult really to say anything further to what has been said. I've been delighted personally with the friendship and collaboration and with my good friends and brothers, Sister Rajiv and Shalini. It's great to be always in India and exchange thoughts and ideas. The difference between the doctor and the healthcare professional working here or working in Egypt or UK or Dubai are very little. At the end of the day, the person with diabetes is the same wherever we go. Same challenges, same problems. Yes, of course, some factors might vary, but the one common problem is education. Education for our people with diabetes is really lacking, and certainly education for all of us. I always admire healthcare professionals, doctors, giving up their time and traveling during their weekends and time off, or even taking annual leave to enhance their education. I'm not conscious that this happens in banking or in accounting or in engineering to the level that is happening in health. Perhaps because we're dealing with something very dear, which is the health of the individual.
So we're quite happy to give up our personal time and effort. So thank you, all of you, for coming and giving up your time. And look forward to future develops, inshallah.
Thank you, sir, for your kind words. Professor Vinod Kumar, sir, is a very, very well-respected senior, the man who was part of RSSDI as secretary when it started, who's always present with us, blessing us always in all our endeavors. Sir, we need your blessings. I welcome you for your blessings, please.
Thank you, Shalini. I must say that these days during such inaugural ceremonies, I am usually the last fill out on an unoccupied chair. So thank you for that again. And I would just like to say one sentence that during my heydays, I have been sharing dais with Indian presidents, chief ministers, and many ministers in my life. But today is a special day for me that I am sharing a dais with Dr. Anup Mishra, whom I regard as one of the highest academic standard researcher, and with whom we have both grown in All India Institute of Medical Sciences over 30 to 40 years, and I now see him a star in the sky, and I often talk about him to my contemporaries of my age. Thank you, Anup.
Thank you, sir. We have the recorded message from ACE CEO, Dr. Johnny White, and I would like him to be part of the inaugural through his message. Can we have the video, please?
Hello, everyone. I'm Johnny White, the CEO of ACE.
Can we have it on the
It's
screen,
great
please?
to be here with you internationally at the 11th International Symposium in Diabetes. First, I want to tell you a little bit about myself. Again, I'm the CEO of ACE. I've been involved in running healthcare organizations for many, many years now. I started my career at the Endocrine Society as a director, and then moved way on to the Cardiovascular Research Foundation, where I was the executive director, and then also was the senior director at the American Academy of Otolaryngology. In addition to running these organizations, I've also spent some time as an adjunct faculty member at Georgetown University and at a community college here. So I bring a lot of experience to this role, and I'm excited to be in this role and excited to be back in the endocrine profession. Now, I want to talk a little bit about some of the things that we're doing at ACE. First of all, our global inclusive community. We're an organization that's welcoming all types of healthcare professionals, not only endocrinologists, but also primary care physicians, nurse practitioners, pharmacists, and diabetologists. So if you are interested in finding a home that's providing education on how to treat patients with endocrine disorders, you definitely want to come to ACE. As you can see here, if you want any information about membership, you can go to our website. That's ace.com/join us. I definitely would love to see you a member of our organization. And then when you become a member, you also want to look at our designation. And that is our FACE designation. That's a Fellows of the American Association of Clinical Endocrinology. There are a few requirements. One is you need to be a member for 3 years, and that 3 years goes by pretty quickly. So I hope that you join today and you start your journey into becoming a FACE, having the FACE designation. You must attend one of our ACE major meetings within the next 4 years, or the last 4 years. This meeting could be the one that we have in the US or the conference that we have in the Middle East, which we've been doing that program for the last 3 years. And then there's an application fee. So again, if you're interested in that, please go to our website. That's ace.com/face distinction. An initiative that I'm really proud of is our certificate programs. We just launched certificate programs. We're doing a series of certificate programs. We just launched our Fundamentals of Diabetes Technology. And then by the end of this year, we'll have the Obesity and Weight Loss Certificate and the Inpatient Diabetes Certificate. And then next year, we'll have more certificates. These programs are very, very unique. It's not your traditional um, program where you're seeing a lecture and slides. It's very interactive. We have some animations and so forth in the certificates. So it's more of a hands-on virtual type of format. So I recommend that you look into these programs because a lot those that have taken it so far have given us some really good feedback and they're very satisfied with what they're learning in these programs. So again, on our website, ace.com/certificates. And then lastly, I want to invite you to our annual conference next year, May 15th through the 17th in Orlando, Florida. It will be at the Hilton. This is a program that you do not want to miss. This past year, we were in New Orleans. There was a huge buzz at the meeting. Everybody was excited about all the science that we presented and the opportunity to network. So I'm hoping that I will see you next year in Orlando. Again, May 15th through the 17th. Thank you. I appreciate you giving me this time to speak to you tonight.
Thank you, Dr. Johnny White. With that, it is my duty to convey the vote of thanks. Many thanks to our esteemed faculties, our seniors, Dr. A.K. Das sir, Dr. Anup Mishra sir, Dr. Vinod Kumar sir, all the senior faculties, Dr. Shashank Joshi, Dr. Banshi, Dr. Meena, Dr. Meenal, Dr. Mithun, Dr. Neeta, Sanjay, everybody who flew in from everywhere, Dr. Rohit Kapoor. I can see a lot of our faculties from uh, Delhi, Dr. Sen Gupta, Dr. Pratap, everybody, thank you so much for taking out time and being our backbone, our strength. Many thanks to our delegates who are always the backbone of any meeting. You've been here from the morning, and all your interactions make this meeting a great success. Word of thanks also to our sponsors, USV, Eli Lilly, Novo Nordisk, Lupin, Sun Pharma, Eris, Alembic, AstraZeneca, Ipca, Glenmark, Novartis, Alchem, Boehringer, Sanofi, Zydus, Cipla, Intas, Torrent, and Dr. Reddy's for all your support because you always help us propagate science. Word of thanks to RX Events, Hardik, Rahul, and their entire team, Ankit, everybody for all the support that you have extended in conducting this meeting. With that, many thanks to one and all. Any names that I have omitted, trust me, maybe it's a mistake, not a deliberate attempt. So with that, I would request everyone to stand for the national anthem, please.
विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मन दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you so much for joining us. Dr. Dhruvi, can I request you to present mementos as a token of our gratitude to our dignitaries on the dais, please? With this, we will break for lunch and we will be back by 2:15 for the post-lunch sessions. And we have great academics, clinical-based cases, everything lined up. So please join us at 2:15 for the post-lunch. Lunch is served on the upper floor, first floor in the Regal Banquet Hall. Thank you.
मैं सुबह ले चुका हूँ. हाँ.
Faculty lunch is served in the ground floor itself. Faculty lunch is here, right outside the hall on the right hand side.
He is past executive member of All India RSSDI and immediate past chairman of Gujarat chapter of RSSDI and advisory council member of West Zone of ACP India chapter. Dr. Anshul Singh is MD Internal Medicine and endocrinologist. He is a consultant endocrinologist at Maharaja Agrasen Hospital, Punjabi Bagh. Over to you, Chairperson.
So good afternoon, everyone. Welcome back to post-lunch session. And we are starting with a session dedicated to hyperglycemia in pregnancy, with focus on outcomes and other things. And as already highlighted, we will first start with the postpartum care and other things. So I will invite Dr. P.K. Saxena from New Delhi, who is Department of Obstetric and Gynecology at LHMC, New Delhi, India. And she is Director, Professor and Unit Head, Department of Obstetric and Gynecology, Lady Hardinge Medical College. And I will also invite two experts, Dr. Vipul Chawda, who is a dynamic diabetologist from the city of Ahmedabad, and Dr. Binal Mohit, who is diabetologist from the city of Jaipur and is also organizing type 1 diabetes conclave at Jaipur in the month of December 2024. So over to Madam for this session.
So thank you, Chairpersons. And without wasting any time, we would progress to this very important panel on delivery, postpartum care, lactation and follow-up. We have a very thin attendance, and I think after lunch, most of the people will go. So let us see what is the postpartum and interconception period. So it is the period, can I have a pointer please? It is the gold period which includes the time after the woman is having her delivery till the time she is discharged. The early postpartum period, that is between 4 to 12 weeks, and this period is also known as the fourth trimester of pregnancy, because at this time the physiological changes which have occurred during pregnancy are becoming normal. And then we have the long-term follow-up till next pregnancy, and then comes the preconception. These are the four periods that we are going to follow, and interconception is the period between postpartum till the time she wants to conceive again, that is preconception. So we know that GDM is also called a marker or a stress test or window of opportunity for future diabetes and for predicting future diabetes and CVDs. It is the predictive of increased risk of developing repeated diabetes in the subsequent pregnancy by 50 to 70%. 8 to 10-fold higher chances of developing type 2 diabetes, cardiovascular disease, the chances increase to 4%, and metabolic syndrome is also substantially high in these patients. So this period provides a unique opportunity for initiation of strategies for prevention of not only immediate pregnancy complications, but also future disease. And for the baby, we all know, besides the short-term perinatal outcomes, neonatal problems, we have long-term implications, and these children are prone to become obese, develop type 2 diabetes, hypertension, CVD, and metabolic syndrome. So coming to the first case scenario, as Dr. Rutul introduced, this is a 29-year-old Charu. She is an architect diagnosed as GDM and is achieved normal glucose values on insulin therapy. She comes for her regular antenatal checkup on ultrasound. We find that the baby weight is already 3.8 kgs and she is having a macrosomia. So Dr. Vipul, I would like to ask you, when will you plan termination of pregnancy for this patient, and what would be the route of delivery?
So at top set, I would first like to thank Dr. Rajiv Chawla sir and Salini ma'am for amazing conference.
And talking about this case, I would say this is a clear-cut case of GDM. We are not having any dilemma that whether is a pre-existing diabetes or type 1 diabetes. Clear-cut case of GDM. And now at the 35 week of gestation, the baby's weight is 3.8, and we can say that it's a macrosomia. But I will say that GDM per se is not any deciding factor about the termination of pregnancy. We need to see the how was the glycemic control in last couple of weeks. 3.8 kgs, yes, of course, a macrosomia, but still, if the gynecologists and diabetologists may plan in a better way and can extend the pregnancy up to 38 weeks, it would be better for the baby because the lung may not have matured, and we have not given betnazole or something that helps to mature the lung. So at this time, with good glycemic control, we should try to reach up to 38 weeks, and after that, it would be a consensus decision by a obstetrician as well as diabetologist to terminate the pregnancy. Again, about the route of delivery, the GDM per se is not indication for cesarean. We should see the previous obstetric history. Now, this lady is a primey, so there may be not any history, but we should see the pelvic, we should see the any other complication that per se may she have preeclampsia or anything else that may be the reason for cesarean section. But if the size of the baby at the 38 week would be 4 kg, yes, I would say the cesarean would be better for the mother as well as for the baby.
Absolutely.
So,
So, as you can see here, the ACOG, Indian guidelines, NIH, NICE guidelines, they all recommend that we can continue pregnancy till 39 weeks because we have to weigh the risk of prematurity because that is the biggest killer and the risk of immature lungs. Whereas at the patient going for cesarean section, if we try to deliver the patient early, many times in our hospital, when the girls, the PGs find that macrosomia is there, they will every day ask, ma'am, should we deliver? Bada bacha hai. So we need to tell them that it is not that the size of the baby is important. And before doing elective cesarean section in these patients, we need to give them antenatal steroids, as Dr. Vipul said. And in the Indian setup, we generally terminate pregnancy between 38 to 39 weeks because our baby's placenta matures earlier, and there is 5 times higher risk of late IUDs in these patients. And I've seen that many of the places, they think that if the woman is having type 2 diabetes, GDM, go for cesarean section. So it is not so. Always try for vaginal delivery unless, as Dr. Vipul said, there is a obstetrical or medical complication. In this case, in India, we are not taking 4 kgs, it is 3.5 kgs because we are smaller in size, and we have to rule out feto-pelvic disproportion, or if there is previous history of shoulder dystocia, difficult labor, or if there is a second stage arrest. There we have the option of instrumental delivery, that is putting a forceps or vacuum, but that is strictly no for these babies because the head may come out, but the shoulders will get stuck and there will be injury to the baby. So, as Dr. Vipul indicated, we did a cesarean section at 39 weeks, 2 days, and she was controlled, she was on twice insulin therapy. And Dr. Vipul, I would like to know that after delivery, what will be the future course of action regarding the Dr. Meenal, sorry, this is for you. How would you like to carry on the insulin therapy? You can take pre-mix insulin, several multiple basal bolus doses or anything. Let's not debate about that. The thing is how to carry on the insulin therapy once the woman has delivered.
So first of all, once again, many thanks to Dr. Shalini and Dr. Rajiv Chawla. This is a very interesting case. Probably it has been designed. It's a hypothetical case, as we all agree. So this case has actually been designed for learning. The previous question said there is macrosomia, but the blood glucose is normal. So normoglycemic, well-controlled pregnancy, 35 weeks, still macrosomic. A little eyebrow raising. If the sugars are well controlled, the baby should not be macrosomic. But it's a hypothetical case for learning because the message was that we have to extend pregnancy till 38 weeks Second, if the baby is above 3.5, as Dr. Biki said, we have to plan a cesarean. So that was a take-home pointers. Now, again there's a learning. She is normoglycemic with macrosomic baby, and she has been since 30th week of gestation on pre-mixed. Again, another controversy. For a flexibility, for a better control during pregnancy, we preferably keep the patient on a basal bolus regime. Now coming to postpartum, she has been delivered, madam has been successful in delivering cesarean section, healthy mother, healthy baby outcome. Future, of course, it was a GDM, so she should not be requiring insulin at all. The moment the placenta is delivered, the blood glucose comes down normal. Further, lifestyle management still stands. Next follow-up, 6 weeks. Ideally, at 6 weeks, we recommend another HbA1c and we recommend OGTT. So insulin further is not required as it was GDM. The second pointer says, what if she was type 1? Now the entire game changes if it is type 1. Why? Because in type 1, the baby, the fetus is exposed to hyperglycemia right from conception. Right from the first trimester, the phase of organogenesis, to the second phase, the second trimester, till the third trimester, the fetus is exposed to hyperglycemia or the challenges of glycemic variability right from day one. So the pregnancy of type 1 is very different from a pregnancy of type 2. Though we keep the targets same, but managing type 1 is very challenging because the fluctuations are very high. The targets still remain the same. We keep the same fasting targets for both type 1 or type 2. In type 2, the baby is exposed to hyperglycemia only in the final trimester. So when the baby has already gone the first phase of organogenesis, the second phase of metabolic development is only the last phase. The last trimester, when the child is the fetus is exposed to hyperglycemia. So the management differs. It's easier in type 2 because there are dietary controls we recommend the lifestyle modification, and of course we manage with insulin only, basal bolus. But in type 1, it's right from day one. So it's a longer period of management. Then comes your third question is metformin safe during breastfeeding? Ideally, yes. Metformin, I'm avoiding the next part, the WB word. I'm just using the word metformin. Metformin is safe during breastfeeding. Even we do give metformin in type 2 during pregnancy also at times. So metformin is safe during breastfeeding, but because it was a case of GDM, she might not be requiring anything for now. But had it been type 2 getting pregnant, then yes, she will be requiring metformin and it is safe. But coming to type 2, during lactation, if the sugars are not controlled with metformin, then we would recommend again the patient to be on insulin and not on OHAs. Other than metformin, we do not recommend any other OHA if it is a case of type 2.
So let us see what the evidence says. And as Dr. Meenal says, as soon as the placenta is out, the glucogenic hormones are out. So for most of the GDM women, they will not require any anti-diabetic agent. Maybe it may be metformin or it may be insulin. But we need to monitor the fasting and postprandial glucose for 1 to 3 days. What about type 2 diabetic? If she's breastfeeding, she can go back to the pre-pregnancy dose of metformin or glyburide, whatever she was taking. And we have to be very careful. These women are breastfeeding. They are losing a lot of energy. The sugar levels are coming down. They have erratic sleep cycles. So we also need to monitor her fasting and postprandial glucose and check that she doesn't go into hypoglycemia on the other hand. Type 1 diabetes, generally the requirement of insulin comes down by 20 to 40%. And of course, in all the 3 cases, we need to monitor the fasting and postprandial values. If she is again going to take glyburide, which she was taking earlier in type 2 diabetes before pregnancy, we need to understand that metformin and glyburide both are secreted in negligible amounts during breastfeeding. And what the evidence says is that there is no marked problem in the babies, so they can be safely continued. Of course, there is no doubt in the efficacy and safety of insulin. So when would you like to check her glycemic status in the postpartum period, Dr. Vipul? And which test do you recommend?
So in the early postpartum period, again, I would say, as you mentioned, that there may be type 1, type 2 and GDM. Yes, we are talking about GDM right now.
But here we are talking about only GDM. Because, yeah.
So immediately postpartum, the insulin requirement will be not there. So we have to measure the blood sugar for 3 days vigorously, pre-meal, post-meal, and after that, if there is no hyperglycemia, we should either put the patient on metformin, or if there is no requirement, we can put off the patient. After that, we have to monitor for 6 weeks and 6 months with HbA1c as well as with OGTT. And if there is hyperglycemia, again first we have to reinforce the lifestyle modification. Again, we have to reinforce the breastfeeding, because breastfeeding also have positive impact on metabolism of mother, and that may help to improve her glycemic control postpartum. And again, for taste, as I already said, that complete metabolic profile should be done. But in terms of when we are dealing with GDM, we have to do OGTT as well as HbA1c. These two are must.
So that's fine. Let us see. The Ministry of Health and Family Welfare in India says that the woman has to come back at 6 to 12 weeks. There is no controversy regarding a postpartum follow-up at 4 to 12 weeks, between 4 to 12 weeks, so that you check whether she has impaired fasting, impaired glucose, or she turns out to be diabetic. But the time of follow-up varies from 4 weeks to 12 weeks. The MOHFW says 6 to 12 weeks, and they recommend a 75 gram OGTT, the normal WHO OGTT, whereas the NICE guidelines and ACOG say that it can be also fasting plasma glucose, and the NICE says that after 13 weeks it may be a HbA1c. So here there is a controversy, but the problem is that most of the women who are breastfeeding, it is difficult for them to come practically in a fasting state. And HbA1c, as it is expensive, most of our women are anemic, so it is practically difficult. So best thing is to find a test which will be very suitable for a postpartum mother to spare some time and come. So the government has approved this test of 75 gram OGTT. The woman has to come. It has to be linked with immunization schedule, because the woman is going to come with the baby in the hospital at 6 weeks for all the injections. So at the same time, we can do a OGTT so that we don't miss her. And she has to be told that she is very high risk of developing diabetes. She has to come every year, lifelong. The second message is, if in this test OGTT, Dr. Vipul, you find an impaired fasting and an impaired glucose tolerance. Her fasting is 110 and 2 hour post glucose is 160. Then what will you do? This condition. Beach wala.
So if the fasting is more than now post delivery, the criteria for diagnosis will be the same as a normal non-pregnant individual. So again it will be a diabetic range. So we will consider them as a pre-diabetic. We are not leaving them without intervention. We will reinforce the lifestyle modification in terms of good diet, good exercise, breastfeeding, as well as we will try to add some molecule that will help them reverse from pre-diabetic to non-diabetic. And again weight reduction at this time.
Which is that molecule, Dr. Vipul?
Of course, metformin. Yes. And if the patient is affording, we can have many other in our armamentarium.
See, for prevention or progression to diabetes, the only one which has been proven till now is metformin. So as you correctly said, impaired fasting glucose more than 100 and less than 125, or impaired glucose that is more than 126 and less than 200. If it is more than 126 and more than 200, she is straight away diabetes, and all obstetricians need to transfer this patient to the physicians or the diabetologist. If it is impaired fasting or impaired glucose tolerance, as Dr. Vipul said, weight loss, exercise, metformin, and yearly checkup, all the metabolic checkup, weight, BP, BMI, lipid profile, all those things need to be checked up. And if it is normal, less than 101, postprandial less than, post-glucose less than 140, we just follow her up every year. So, although all guidelines are recommending, but hardly 3 to 33% women are following up in the postpartum period. So, ma'am, Dr. Meenal, what is this? Why is this problem there? Why is it a challenge? And can something be done to overcome this challenge?
Now, this woman has come for a follow-up, Dr. P.K., and you have come to the conclusion that she is already having impaired fasting and impaired glucose tolerance. So, she is in a state of IFG and IGT, as we call, which is a very high risk of progressing to type 2. Now, here comes other things which really become very important as you have taken the question out of my sight. The questions, can I have the questions back, please? So why the women are reluctant? First of all, we have to have, because it's a hypothetical case again, the family history and the history becomes very important. If she has a family history of type 2 diabetes and she's already having IFG and IGT, very likely that within next 3 months she might be a overtly diabetes case also. So we need a very strong reinforcement of lifestyle modification. And as Vipul said that he would like to introduce a molecule like metformin. He can of course introduce a metformin also. It's a molecule which can induce remission. Otherwise, the most important thing is LSM, that is lifestyle modification. Why are women reluctant to come for postpartum visits? I think it's not only women, it's a gender bias. Everybody is
we are talking about pregnancy, Dr. Meenal. So, we are talking about pregnant patients.
Don't get offended, madam. I am also a woman. Don't get offended. So, I'm just saying, education is the most important part. Not only for women, everybody. Anybody who's diagnosed with impaired fasting or IGT, very likely to progress to type 2 diabetes. So education is the most important part. And why are women reluctant? Again, because of lack of education, lack of awareness, lack of willingness to avoid complications. What can we do? Again, education at every level. Patient level, family level, GP level, even the co-partners in managing such cases, because pediatrician is a co-partner. They will be visiting a pediatrician for vaccination. Gynecologists are co-partners because they will be visiting more of the gynecs rather than coming to us. So it is a duty of the gynecs also to promote teamwork and ask them to visit their diabetor or endo. Similarly, the pediatricians have the responsibility of promoting the visits to physicians or diabetors or endos, because reinforcement is the only answer.
I think that is very correct. These women are very busy with their babies, and they do not have any time to come to the hospital. So what we can do is we start educating them in the antenatal period, tell them about the importance of follow-up visit, proactive reminders can be sent, effective communication channels, and we need to have postnatal clinics. We are all seeing antenatal patients, pregnant patients, but have you ever seen a postnatal clinic? And that should be in the afternoon. If it can be coupled with the immunization, that will be the best. The proactive systems like postal reminders, telephone, email, short messages, Skype, and recall messages should be done.
And this is
a very interesting new idea. The early in-hospital OGTT, if it can be done on day 2 or 3, while the patient is with us, the patient is discharged on day 3. If we can do this OGTT on day 2, this study compared this 2-day OGTT with 6 to 12 weeks OGTT in the postpartum period, and they found a very good coherence between these two tests. We have also done a similar study in Lady Harding, which we will be publishing very soon. So this is a very easy to do thing, and here we will be able to capture all the patients rather than having only 3%. So what advice you will give to the woman at discharge, Dr. Vipul? And what are the high-risk predictors? Dr. Meenal has already enlightened us with the family history, obesity. So what are those things you would like to tell the patient?
Sorry to interrupt, ma'am. I think we are running out of time.
Yeah. So this will be the last. Or can I just sum it up? The risk factors for recurrence are that if she is diagnosed in the first trimester, she has very high degree of glucose intolerance, insulin requirement is high during pregnancy, she has excessive weight gain and weight retention, and short period of breastfeeding. Breastfeeding, as Dr. Vipul said, is very, very important. It reduces plasma glucose, plasma insulin, increases glucose utilization, and decreases lipotoxicity. Thereby, it reduces beta cell load and preserves beta cell function. And it has been seen that if the woman is breastfeeding for more than 3 months, the chances of development or progression to diabetes are reduced by 40%. Similarly, weight loss by diet and exercise is very important. And last but not the least, contraception method. As we can see here, for GDM, all contraceptive methods are safe, but we just need to remember that they will be turning out to be type 2 diabetes very soon. So avoid estrogen containing COCs, oral contraceptive pills, and DMPA injections. These are category 3 and 4 having very high risk. So these two things should be avoided. Rest all are safe. So to conclude, postpartum screening offers a unique opportunity to initiate meaningful risk reduction strategies. Let's remember A, B, C, D, E, F, G. A is for assessment, regular follow-up to detect pre-diabetes and diabetes. B is breastfeeding. C is contraception. D is development of this multidisciplinary team. Development of exercise. E is for exercise and physical activity. F is for food and family. And G is for goals for optimizing weight, BP, blood sugar, hemoglobin, and lipid profile. Thank you all, and thank the panelists and the chairpersons.
Thank you, ma'am, for that enlightening session. And I'd like to thank the session experts as well.
Thank you.
And to carry on the session further, I'd like to call upon to continue with this session. Here to talk about preconception planning and care, I call upon Dr. Shalini Jaggi as the session lead. And as experts, I would like to call Dr. Rutul. He is a fellow in diabetes, Apollo Hospital in Liverpool, consultant diabetologist and managing director at AHC Diabetes Center, and visiting consultant focusing on type 1 diabetes at JDPF Ahmedabad. And our second expert is Dr. Vijay Arora. He's Senior Director and Head of Department at Internal Medicine, Max Super Specialty Hospital, Delhi.
So, good evening, everyone. This is where the journey was supposed to start, but actually we went back. So now what I'm going to do is take you through preconception care and pregnancy planning. And my experts, Dr. Vijay Arora and Dr. Rutul, will be joining me in this journey. We all know the prevalence of hyperglycemia in pregnancy is rising, and you can clearly see Southeast Asia leads. 1 in 4 live births in the IDF Southeast Asia are affected by hyperglycemia in pregnancy. And in India alone, GDM complicates more than 4 million pregnancies. If you look at the definition, I think all of us know hyperglycemia in pregnancy is the umbrella term which is divided into pre-gestational diabetes, which is women who already have type 1 or type 2 diabetes or rare forms of diabetes before pregnancy. Diabetes in pregnancy is when a pregnant woman is diagnosed with hyperglycemia for the first time in pregnancy. But she meets the WHO diagnostic criteria in the non-pregnant state. That means her fasting is already more than 126 or her post-meal is already more than 200, which means that maybe she did have diabetes before pregnancy, but it was picked at that time. So she is again somebody who's diagnosed for the first time in pregnancy, but maybe it is overt diabetes. This is DIP or diabetes in pregnancy. GDM is actually occurring any time in the antenatal period, not expected to persist postpartum, where pre-existing diabetes is ruled out. So this is actually diabetes that develops in pregnancy because of the diabetogenic hormones. Now, 29-year-old architect Renu planning pregnancy. Let me change the perspective a little here. She's been married for 3 years. She now is somebody who has a history of type 2 diabetes for the last 1 year. She has been prescribed dapagliflozin and metformin, but is quite irregular with her medications. She's been married for last 3 years. Family history, both parents are positive, type 2 diabetes. Of course, she does not really exercise much. 3 out of 7 days, walking about half an hour or so. Meal times are irregular because she's an architect. So on days that she has site visits, her food gets delayed. There's no other significant history. Now, parents are already type 2 diabetic. Her elder sister developed GDM when she was pregnant and needed insulin towards term. So now she is worried because she wants to start a family. About 6 months back, when she visited her GP, her HbA1c was 7 and she was assured everything is fine. Now, my first question. Has she done the right thing by coming to you at this stage when she is not yet pregnant? Should she not have bothered, and should she have come later after conception? You know, once she's pregnant, should she have come to you? Your take on that. Yeah, Dr. Rutul, you can take this.
Thank you very much, Shalini ma'am and Rajiv Chawla sir for inviting me first of all. And this is a very important question and an interesting case. So this is so much common. As a patient is consulting GP, and most of the time when they are not aware, they think that yes, HbA1c of 7 is quite okay. You don't need to worry. Now you can go for, you are ready for pregnancy. But as we can see here, patient's BMI is 29. Patient is definitely overweight, or in Indian context, we can say patient is obese. So definitely we should take a little time more, or we should try to get HbA1c less than 6.5. We should try to reduce weight by at least 5% if it is possible in next few months. And the patient is irregular on her medicines as well. So we need to explain her. And if possible, try to get HbA1c less than 6 if possible, and without hypoglycemia. And then we can even ask for pregnancy even without insulin if HbA1c is less than 6%. But if patient is less around 6.5 and she wants to get conceived, then we need to switch her on insulin, and that we need to clearly explain her.
Absolutely. So I think she's done just the right thing by coming to you at this juncture, even when she is planning to get pregnant, because this is where preconception counseling and care becomes very important. In simple terms, it should start right from the beginning when diabetes is diagnosed for any young adult with diabetes, especially females, and should be ongoing at every visit. So I think you need to just tell them, any young diabetic in the reproductive age group, any woman you see, you should definitely tell her that, you know, in case there's an accidental pregnancy, that should not happen, because she needs to plan, optimize her glycemic control, explain that the risks, and discuss how they can be reduced but not completely eliminated. And the reason why we need to get A1C on target is simple, because first 8 weeks are very, very critical, because organogenesis happens at this time. So there are a lot of complications that can happen if glucose levels are not controlled. Most important being congenital anomalies that can happen right in the beginning of pregnancy, most common neural tube defects that we see in uncontrolled diabetes. And of course, for the mother also, increased incidence of miscarriages, higher incidence of infections, acute metabolic complications, worsening of complications also happen. And then if the glucose levels are not controlled, towards the later half of pregnancy, a risk for polyhydramnios, fetal macrosomia, shoulder dystocia, difficult labor, neonatal hypoglycemia, and hyperbilirubinemia. So it's important, like Dr. Rutul said, there's study which show that for every 1% increase in HbA1c beyond 7%, the odds that this pregnancy is going to be affected by a congenital anomaly increase by 30%. And therefore, like Dr. Rutul said, it's important to aim for an A1C of less than 6.5%, and very important to prevent neural tube defects is folic acid supplementation. So, in simple terms, what is preconception care? Dr. Vijay sir, if you could guide us.
The preconception care is we should avoid unplanned pregnancies, and we should lay more stress that if an accidental pregnancy happens, the incidence of congenital complications will be high. So we should avoid unplanned pregnancies. Then the health of the mother. So health of the mother is of prime importance. During preconception, we should maintain that if she is having ideal body weight or not, and if she is having other comorbidities that must be addressed, like hypertension or asthma or other diseases, which needs to be optimized before she should have pregnancy. And then we should tell her in detail that the birth defects which are common, and with every degree rise in HbA1c, the incidence may vary from 20 to 44%. That needs to be stressed. And as we all know, the maternal health and fetal health both are important for us. So we need to address this problem, that if the baby weight is high, then the complication at the time of delivery or during the pregnancy or even postpartum period will be higher, and she might land into cesarean section. So we need to stress that accidental pregnancy should be avoided, weight gain should be minimized, the weight of the child should be in control, so that the complications which you have already told that must happen in the first 8 weeks of life, and especially the CNS complication, the neural tube defects, or congenital heart disease, or disposition, the complications which are seen in the ears, then macrosomia, and then the eyes. These are the complications which usually happen in different weeks, and the maximum complications happen in the CNS. So if she is taking folic acid at least 3 months prior to the onset of conception, then we can avoid these type of complications, and we need more stress on this.
Absolutely. So I think it's very clear that preconception care means providing her biomedical, behavioral, and social health interventions before conception occurs. And the reason is because once she's pregnant, and then if you try to control the glucose levels, you will not achieve optimum results, and there are very high chances of congenital anomalies and all the different complications, because we know that the developmental origin of adult disease clearly tells you that everything starts in pregnancy. So it is very important that the future chronic diseases need to be prevented. You need to start right in the beginning, even before she conceives, because pre-pregnancy overweight or diabetes or hypertension during pregnancy can lead to so many complications: development of preeclampsia, gestational hypertension, SGA babies, preterm deliveries. And then as this progresses, there is an increased risk of cardiovascular disease, hypertension, stroke, mortality, etc. So what all are the components of discussion when you offer preconception care, Dr. Rutul?
This is very important point, and what we really need to explain is, first of all, we need to explain better glycemic control. The other thing is how regularly they should check their blood sugar even before pregnancy.
then definitely few of the complications. If the case is already like we have this case of type 2 diabetes, we should ask for regular other blood reports, and even she should go for a retinopathy and nephropathy checkup. As we know that during pregnancy, chances of retinopathy increases if patient has already some sort of retinopathy. So definitely we should plan for comprehensive checkup as well as weight reduction. We should plan before pregnancy for even her nutrition, and we should explain her thoroughly that we should put some more effort during the pregnancy, that she will have frequent contact with healthcare professional, how frequently she should come to our clinic.
Absolutely. So this brings me to the next question, Dr. Vijay sir. How will you work her up? What basic tests do you want her to do, now that she's come to you for preconception and you've explained why glycemic control is important?
Before going for any basic test, we should find out whether she is having any comorbidities or not. Accordingly, we can test her. And if a patient is hypertensive or having diabetes before the onset of pregnancy, then a complete workup including hemogram, liver function, kidney function test, including albuminuria, and then dilated eye examination to rule out retinopathy. So these are the things which usually get exaggerated during the pregnancy. So we should avoid these type of complications. And if we keep the HuNC less than 6, then we can prevent further.
Absolutely. So I think it's very clear that we need to understand that if there is already pre-existing diabetes, as she gets pregnant, the diabetogenic hormones will progressively cause an increase in the insulin resistance. And there's worsening of glycemia, there's worsening of complications, besides all these other complications that we talked of, retinopathy, nephropathy, neuropathy, they can worsen in pregnancy. She's at an increased risk of infections, diabetic ketoacidosis, as well as the child who's born to a diabetic mother is at an increased risk of childhood obesity and diabetes in the offspring. And that is why we say GDM is a window of opportunity for future NCD prevention, because if you are able to prevent hyperglycemia from being transferred from the baby to the mother, the stimulation of the baby does not happen. So the intrauterine programming, the adverse programming can be prevented, because it is clearly seen that in mothers with type 1 or type 2 diabetes, risk of malformations, preterm deliveries, large for gestational age, perinatal mortality are almost high. So basic biochemistry workup includes a complete workup including the vitamin B12, D3, folate levels like Dr. Vijay said. Urine ACR is again very, very important, because preeclampsia, hypertension are something that she can always develop. So I think it's very important that right in the beginning you start talking about getting an A1C to less than 6.5%. Glycemic variability is a very important component. Dr. Rutul, would you like to stress some information on CGM in pregnancy and why glycemic variability is directly related to macrosomia?
So definitely glycemic variability is now a very important part, as we have learned since last few years, that even only hyperglycemia does not affect that much, but if glycemic variability is high, if patient is having hypoglycemia and hyperglycemia in a day, and it is going to have adverse effects during pregnancy. But as this case is of type 2, as we know that this patient is already on dapagliflozin metformin, but we want to switch it on basal bolus therapy, then this case may get more glycemic variability as we start with insulin. So we have to be very careful while using insulin. And CGM plays a vital role in reducing glycemic variability, as it is kind of a video. When you take a picture, you just know that point of time what is the blood sugar. But if you use continuous glucose monitoring, it is kind of a video, and you can see what exactly you need to change and at what time you need to change insulin dose or whatever the medication. So CGM can reduce glycemic variability
accessibility by higher extent. So we should promote it more and more
So
in
basically,
the
for
conception.
during preconception, don't only aim for an A1C of less than 6.5. If this is pre-existing diabetes, you need to look at the glycemic variability, because many a times A1C is just an average. So simply relying on an A1C may not be sufficient if this is type 1 or type 2 diabetes. That is where you really need to put a chip and see if there are no glycemic excursions, ups and downs happening. Furthermore, ask her to lose weight if she is obese, because gestational weight gain eventually is again something that is going to be a concern. And of course, lipids also need to be stabilized. So glycemic targets we've already discussed. What about glycemic targets pre-pregnancy? I think we're all very clear. A1C of less than 6.5 and fasting as close to 90 to 120 as possible. Pre-meal 72 to 126. And once she gets pregnant, the targets change, and this will be covered in the next session. So strongly, any woman who is beyond an A1C of 7, especially somebody who is beyond 9, 10, should be discouraged from getting pregnant, because risk of congenital anomalies is very high. As far as weight is concerned, again, anybody who is overweight or obese should be asked to lose weight. And contraception is something very important, because unplanned pregnancy can cause a lot of complications. So choice of contraception can be left to the patient, depending on whatever is her choice. Advise her to use contraception till the A1C is on target. And once it is achieved, that is when you can tell her to withdraw contraception and try it. What about complications? What all complication screening are important? Dr. Vijay, if you could stress on this.
Again, I have said previously also, then the detailed eye examination, the related eye examination must be done before preconception, so that we can rule it out proliferative diabetic retinopathy, because there is acute worsening of proliferative diabetic retinopathy during the pregnancy. And this is one thing which we can prevent if patient is having before the onset. And the complete renal assessment, if patient is having macroalbuminuria or having worsening in the kidney functions, then we can stress that patient should avoid pregnancy. And if until unless the things are in the line, HbA1c less than 6.5, only then she should go for pregnancy. And SMBG, and we should have a ready kit with the patient that she should, if the type 1 diabetic, she should check the ketone levels on a routine basis. If this, especially when patient is having on insulin pump, and the site of the pump and the tubing might get blocked, and then patient may land into decay. So we should be careful, and we should address all these complications to the patient. And other complications which are not related to diabetes are the STDs and thyroid-related disorders. Especially, we should maintain the TSH level less than 2.5 before and after during the pregnancy, so that the child should have a normal brain development.
Absolutely. So somebody who is at a high risk of neural tube defects should be given folic acid supplementation. You can start with 400 micrograms per day. Somebody who's already had a history of neural tube defects or glucose levels have been bad should be given about 5 milligrams per day until about 12 weeks of gestation to reduce these congenital anomalies. Again, dilated eye examination ideally should be done pre-conception or at the first pregnancy visit, and then should be repeated every trimester. Because like sir very clearly said, there is worsening of retinopathy that happens in pregnancy. So if there is background retinopathy, you should immediately manage that before you allow her to get pregnant. Now, very important question is medications. Now that she's planning pregnancy, you're bringing her to control. Do you want to continue medications, or do you need to actually switch her to insulin? Safety of medications. Dr. Rutul.
So, as I already told in my first time when I started, as this patient is already type 2 diabetic patient, we should ideally switch her on basal bolus insulin. And in most of the cases, only basal or only bolus even doesn't work. Or even metformin we should not use in first 20 weeks. Ideally, we should switch her on basal bolus insulin. I would strongly recommend that we should stop even glyburide or glibenclamide in such cases. Though internationally glyburide is it is approved, but we should not use it
definitely we should stop ACE, ARBs, such kind of antihypertensives, and we should try to switch them on labetalol, and we use even nifedipine we can use. So definitely other medication already Dr. Vijay explained that for thyroid you should target TSH between 1.5 to 2.5. So according to that you should titrate thyroxine as well. So
Absolutely. So
folic acid is very
I think
important.
the message is very clear. Somebody with pre-existing type 2 diabetes should ideally be switched to a basal bolus regime. Premix does not really have a huge role to play here. Only if it is GDM, that is where maybe if she's, if it is only very mild dysglycemia, you can continue. So basically, insulins are found to be very safe and effective. Do not cross placenta. Most of the insulins are now approved and found safe, right from your conventional insulins, which means Ectrapid, Ectrapids, and your analogs, all the Lispro, Aspart, all are found to be safe. Fast-acting Aspart is commonly used these days because of its quick action. The basal insulins, Glargine also, if she's on Glargine, you can continue Glargine, but now we also have Degludec, which is approved in pregnancy beyond the conventional NPH that we were using. Analogs, of course, are found faster, predictable with less hypos. So I think when it comes to preconception counseling, let me sum up and tell you that optimal glycemic control preconception is very important to prevent all the adverse maternal-fetal outcomes that we can see if glucose levels are not controlled. So it is an integral part of pregnancy planning. You need to inform the patient, tell her, advise her on not getting pregnant till the glucose levels are on target, which means an A1C of less than 6.5. Advise contraception till then. You tell her when to stop once the glucose levels are under control. Importance of glycemic management is very important. Of course, complication screening for somebody with pre-existing diabetes, especially retinopathy, is again something very important, because if there is proliferative retinopathy, maybe a laser prior to conception is indicated. Even in the first trimester, laser can be done. Beyond that, it becomes little difficult. The only contraindications when you tell her not to conceive is if she's got ischemic heart disease with a very poor heart, or untreated proliferative retinopathy, because it can worsen and lead to blindness, or in case of somebody who's got severe renal impairment. So explain that all this is going to reduce the risk. It cannot really negate the risk. You cannot really guarantee that things will be well, but all you can do is control the environment and ensure that the risk of complications is less. Of course, medicines need to be reviewed. Any potentially teratogenic or harmful medicine needs to be stopped right in preconception, including steroids, statins, ACE inhibitors, ARBs. All medication should be stopped. Metformin alone is something that may be continued in pregnancy if need be. Otherwise, it has to be insulin all along, and of course, it has to be a comprehensive diabetes management team. And you can go through this algorithm, which is easily available on preconception. Thank you so much.
Thank you.
Thank you, ma'am. I'd like to thank the chairs and ma'am as well for the session lead. Can we have the facilitation, please? To continue the session, I'd like to call upon stage as a session lead Dr. Sunil Gupta. He's a diabetologist, CEO and MD at Sunil's Diabetes Care and Research Center.
Sunil is not there, I have to.
So Dr. Chawla will be continuing this. He is, of course, and Dr. Rajiv Chawla. I'll be calling Dr. Rajiv Chawla, and for as the section expert, I'll be calling Dr. Vipul Gupta. He's MD Medicine, FSCP, FRCP. He's consultant physician and diabetologist, founder and medical director of Gupta Ultrasound and Heart Care Center since 1997. And as a second session expert, Dr. Girish Khurana. He's founder and medical director of Vidya Medicare Center, Delhi and NCR, Secretary RSSDI Delhi chapter. Thank you, sir.
Thank you, Dr. Anshul. So, having a patient, I think she was Renu. She has already conceived, and I suppose so that she has conceived in the best expert hands. And now we are left with the management of her during the pregnancy, so as to make sure that we have a tight glycemic control and we have normal neonatal as well as maternal outcomes. Slide is not moving. Okay. So, first of all, let's see once she conceives whether she is at a high risk for developing GDM. So let me take you through this first question. How much you think is going to be the risk for developing GDM, or what is the prevalence of GDM, Dr. Girish?
Prevalence of GDM, we talk of hyperglycemia in pregnancy, and that depends upon the age in which the patient conceives. And in IDF data, we take this age from 20 to 49 years. And the prevalence increases as the age increases. At 20 to 25 years of age, this prevalence is around 10%, whereas above 45 it is 40%. And if we take the estimated average, in Southeast Asian context, it is 28%, meaning thereby every 1 in 4 women suffer from hyperglycemia in pregnancy. And if we count the number of births affected by the hyperglycemia, according to IDF data, it is approximately 6.8 million. So the prevalence is age dependent and according to the country where it occurs. In our scenario, Southeast Asia, it is much higher.
So it depends on what is the maternal age. Second, whether there is a history of GDM in the mother or in the family history of type 2 diabetes, whether she has had PCOS before conceiving, and how much is her BMI. These will probably decide whether this lady is going to be at a high risk. And unfortunately, in Southeast Asia or in Indians, this risk is very, very high. 1 in 4 live births, they tend to have some degree of hyperglycemia in pregnancy. So what are going to be the complication of hyperglycemia, especially if it comes out to be a early pregnancy? Dr. Vipul, please.
First of all, thank you, Dr. Charlie and Dr. Chavla, for giving me this opportunity to be a part of this prestigious conference. We have all understood that preconception counseling is the most important part, and we try to bring down the HbA1c before the patient conceives. But in GDM, as you know, patient sometimes doesn't come to know that she has conceived, and the damage is already done by that time, because the most of the organogenesis we have learned occurs in first 8 weeks. And by that time, if the patient or the baby is exposed to the hyperglycemia, the complications have already occurred. To name the complications, most important are the neural and the cardiac complications, the congenital anomalies, the anencephaly, microcephaly. They are very important. Then the large for date, hydroamnios, those are the other complications. And during delivery, because of baby being large, the shoulder dystocia, the Erb's paralysis, neonatal asphyxia, they are very important. And if you talk of the complications on the maternal side, they would be if the patient is exposed to a higher sugar levels, there are higher chances of infections, candidiasis, then probably the microvascular complications also going worse, the retinopathy and the albuminuria also going worse during that period. And during delivery also there are chances of more injury and patient being exposed to more cesarean section, and then more prone to infections because of hyperglycemia. So we have to be very careful during preconception period. Try to control sugar levels in first 8 weeks once the development of CNS, cardiovascular development, IE, and all those parameters occurs. And once you expose the baby to a higher HbA1c or hyperglycemia during that period, the chances of complications, like in the non-diabetic patient, with every 1% increase in HbA1c, the chances of complication increase. So we have to be very careful.
I think very true. By the time you diagnose GDM conventionally at 12 to 13 weeks, Forget about Indian guidelines, even Caucasian guidelines still are saying that you may first time screen at 22 to 24 weeks. Now it is for the first time that we have adopted as based on DIPSI guidelines a universal policy to screen every female at the first ANC, which happens to be 12 to 13 weeks. And these days we are talking on AGI, which is a early glucose intolerance in gestational, and we tend to screen them as early as 8 to 10 weeks, because by the time you pick them up at 12 weeks, organogenesis is already completed. And Dr. Vipul very rightly said, by then a lot of damage has already been done. In our ethnicity, we have seen that females developing GDM as early as 8 to 10 weeks also. So I think it is very important to screen them for these any degree of hyperglycemia, because I'll not go into go the details of that, because major morphological abnormalities will happen even if you pick them up at 13 weeks, because by then organogenesis is by and large complete, and it has a very linear relationship. It's something like a continuum. There's nothing like that at 12 weeks you are normal glucose tolerant, 13 weeks for the first time you have GDM. Anyone who has GDM or AGI or early GDM, it might start as early as 8 to 9 weeks, and it goes on based on your hyperglycemia, and so is going to be the greater risk for developing all these complications. And we always knew that trimester-wise consequences of dysglycemia are going to be there. If it is diagnosed in first week, obviously malformations are the one concern. Subsequently, in second weeks, polyhydramnios, PIH, fetal loss, prematurity, or hypertrophic cardiomyopathy. Third trimester, you will tend to have macrosomia, hypoglycemia, hypocalcemia, and IOD. So, do we screen every pregnant female, or it should be a selective screening, Dr. Girish?
Ideally, every pregnant female should be screened, and it has been advocated also that wherever there is a high risk of diabetes, these patients they should be screened. But if we look at our Indian context, we have already seen that among the South Asian countries, Indian women they have the highest frequency of GDM, and Indian women are 11-fold more at risk for glucose intolerance as compared to Caucasian women. And sometimes patients they don't give family history of diabetes. They try to conceal, and if patients are overweight and other siblings or in other relations they have diabetes, they are at risk of developing
That is why in our
so looking into all these aspects,
every pregnant female needs to be screened
at first ANC or even before ANC.
even earlier also if it is possible. And there is a concept of preconceptional counseling. That is why in all female, those who are at a greater risk for developing GDM subsequently, those are the one getting conceived for the first time, maybe close to 30 years. Those who have a mother who has history of either GDM or a family history of type 2 diabetes, or there has been a PCOS in the pubertal age. So they are the one who are likely to have high risk for developing GDM. That is why there has to be a universal screening in India. Every pregnant female should be screened as early as possible as per DIPSI guidelines, and these have been adopted by Government of India Ministry of Health also. How do we screen pregnant female, Dr. Vipul?
Earlier, there used to be a lot of confusion what kind of OGTT we used to do, whether it's 75 gram, 100 gram, 1 hour, 2 hour. But now, the guidelines, the TIPSI guidelines, which have been accepted by the Ministry of Health and Family Welfare also, they suggest that 75 gram OGTT in a non-fasting state, even without the time of the previous meal, patient should be subjected. The 75 gram dissolved in 300 ml, taken over 10-15 minutes. And then check the glucose level with the calibrated glucometer 2 hours later. If it is more than 140, then you label the patient as GDM. And this is you do it at the first antenatal visit, 24 to 28 weeks, then every 4 weeks. And then if those patients are more than 140, then you treat them with lifestyle and medication.
Now we follow single test procedure, which is advocated by Government of India Ministry of Health, and it is simple 75 gram glucose dissolved in 300 ml of water to be drunk in 5 minutes time, and do a sugar at 2 hours. We are not asking a fasting status. It has to be irrespective of the last meal. Anytime patient walks in, unfortunately I have Professor Mohammed, whom we always
debating on this issue because he follows IDPSG criteria. In India, we follow DIPSI guidelines, and we have shown, just before you, I know you are going to fire me. We have proven with lot of studies here. One of our studies, me and Dr. Shalini published this month only in IJJDC, where we said that IDPSG two-step criteria versus DIPSI criteria, absolutely identical outcome, fetal and maternal in 100 patients of ours. And there's a lot of evidence now. For our ethnicity, we are not asking them to come for fasting because it is not possible. They have to travel at times 2 hours. Mothers may not allow them to go fasting for a test and then come back, take glucose and then go for a second visit. Many of those patients might be in rural areas. So this is now being advocated and has been adopted by Government of India, and it has been validated at least in good 10 to 15 studies. Yes, your comments. I agree, but one-third is not probably a very tall claim. I agree, you are going to miss certain pregnant females having mild degree of fasting hypoglycemia. But if you believe me, if normal fasting in a normal glucose tolerant female who is not diabetic, not developing GDM is 74 milligram. First trimester, when you screen them for fasting sugar, mean sugar is 75 plus minus 8. It never exceeds 90 or 100. That means because of improvement in beta cell proliferation, mass because of placental hormones, estrogen and progesterone, fasting levels actually come down. It is a proven fact. And even if you are anticipating a fasting hypoglycemia at 12 weeks, that we have seen in our ethnicity, it hardly exists. It is primarily a postprandial hypoglycemia, but well, theoretically, I agree. Few fasting hypoglycemia you might miss if you're not doing a fasting sugar. Taken your point. How do we interpret glucose tolerance test? Yeah, Girish.
So as told by Dr. Vipul, we subject the patient to 75 gram of glucose once she enters into your clinic, and we check blood glucose after 2 hours, and if it is more than 140, we diagnose her as GDM. And if it turns out to be negative, then we screen her at her second visit at 24 to 28 weeks. And if it comes positive, we treat her as GDM. And if it turns out to be negative, then we again screen her at 32 to 34 weeks. And we label her as GDM if blood sugar is more than 140. Ideally, the patient should be screened at the first trimester or at 12 to 16 weeks. The earlier, the better. And if patient does not tolerate the 75 gram of glucose, or if she vomits, we can repeat the test the next day.
So a cut off 140, absolutely. Anything more than 140, it is GDM. So this is not only a screening, but a diagnostic test. And it has been adopted by IDF, by FIGO, and also endorsed by WHO based on our ethnicity and our own results. That one test, if it is more than 140, it is GDM. Anything 120 is normal, but 120 to 140, we say it is again eggy. It is mild degree of hyperglycemia, and those patients need to be followed subsequently at 22 to 24 weeks if negative, and then for the third trimester screening. So pathophysiology, we will not going to go into the detail. Anything you want to say, Dr. Vipul, about pathophysiology of GDM, how it all happens, and
it is only the interplay of the placental hormones and the balance between the insulin secretion and the insulin resistance. Once the insulin resistance outweighs the insulin secretion, the person develops, GDM. The pathophysiology is quite similar to what we have in a non-pregnant female, the adipose tissue, liver, gut, but the placenta plays a very important role. The cortisol growth hormone, human placental lactogen, they are the very important hormones which increase the insulin resistance and outweighs the insulin secretion, and the person develops who are predisposed to it, maybe because of genetic predisposition, obesity, and because of the lifestyle, and they end up having
One simple dictum: all those who are pre-diabetic or those who have mild dysglycemia outside pregnancy, moment they conceive, they are the one who are likely to develop GDM. That is what is the hypothesis, that with all these counter-regulatory hormones, there has to be an increase in insulin secretion, a proliferation of beta cell by 200 to 250% to match that insulin resistance, and that will only happen if you have a normal beta cells. So this probably will earliest manifest as postprandial hyperglycemia. That is what is the hypothesis. They may not have a fasting hyperglycemia. So moment there is an increase in insulin resistance, the beta cells are not competent enough to proliferate by 200 times, they will develop dysglycemia, and this will be picked up as any degree of dysglycemia 140. This is what I was referring to. 71 is the fasting sugar in normal pregnancy. It is 109 plus minus 10. It never exceeds 120 milligram. That is why this eggy new term has been coined, that someone who has sugar more than 120 is also not normal. Other organizations are still not agreeing to that. They say, okay, anything more than 140 is GDM, but we are saying that because normal physiological will never cross 100, 9 plus minus 10, that means 120. So any degree of dysglycemia more than 120, don't take it as normal. They are also IGT in pregnancy, or some degree of dysglycemia in pregnancy, because if you don't pick them up, what they are going to deal or going to lead to is stimulation of the beta cells of the pancreas of the fetus, which will lead on to a fetal steal glucose phenomena. So mother sugar may come down because of hyperinsulinemia into the fetus, and these fetus, once they are born out of little hyperglycemia in pregnancy, they are the one who are likely to develop non-communicable disease like hypertension, dysglycemia, or obesity or CVD once they grow as close to 20 years or 25 years. So what are the targets of glycemic?
In that previous slide, you have shown that fasting, just a little back. Fasting is 71 plus minus 8. That's why we take PIR from 63 to 140.
Yeah, that is very good. That is why when we are putting them on AGPs or CGMS, it is 63. Which is not hypoglycemia in pregnancy, because physiologically it can be 63. Based on that only, very true. So we go towards the last, that is what are the targets. Here it is a very important quote, that achieve a pregnancy outcome in diabetic women that approximates that of a non-diabetic woman. That means mother should never have hyperglycemia more than 120 if you want to have a normal outcome, and fasting should never exceed more than 90 milligram. And based on that, you have the targets of fasting 90, postprandial 2 hours, not more than 120. But if it is done at 1 hour now, of late lot of evidence is coming that 1 hour may have more correlation. That should not be more than 140. So 90, 120, 1 hour, not exceeding 140. If you can achieve this in a patient who has even earliest degree of dysglycemia, probably only then you can make sure that you will have normal fetal and normal maternal outcomes. Target during pregnancy for women with type 1, you already said that we are talking of 63 to 140, which is extremely difficult until unless these patients are on 4 to 5 doses of insulin or on regular pumps, because type 1 it becomes all the more difficult to make sure that you don't exceed 63 to 140, and it has to be 70% that time in that range, and below target not more than 4%, and target above also should not be more than in 25%. Because of the paucity of the time, this we have already touched upon. There is an important role of CGMS today, and maybe closed loop type of pumps where you can have not only the targets which are marked there coming out of a continuous glucose monitoring. Here you could see that type 1 and type 2, those who are non-pregnant, we talk of 70 to 180. In pregnant female, we talk of 63 to 140. In type 1, which is extremely difficult to make sure 63 to 140. But in type 2 and gestational diabetes, most of the times ideally you should be in this range of 63 to 140, and it has been adopted by AD also. It is published in Diabetes Care. Role of CGM, I think, people, you have a lot of patients on pumps and you do a lot of AGPs. Anything you like to say here?
Yeah, this is a very important tool, as everybody has already said, that just measuring a HbA1c, which is just like taking a still photograph, videography or a CGMS is a very important tool because we come to know the glycemic variability and the hypos and hypers, because these patients are most often on a basal bolus dose. Then adjusting those levels into the targets is very important. Unless until you do this kind of measurement or this kind of monitoring, it is sometimes impossible for the patient to do a 7-point SMPG or multiple times testing and then take four injections a day. So this is a very important tool, and we have used it in so many patients, and it comes very handy. Cost may be a little constrained, but this gives you absolute good results and titrating the dose
Very true. Last 2 points of discussion. When do we start pharmacotherapy in GDM? How long we can wait for lifestyle modification and MNT in GDM? I think it is clearly not more than 2 weeks. If it is early pregnancy, 1 week. If it is anything after 13 or 14 weeks, not more than 2 weeks, and we must ensure that sugars are less than 120 milligram. Anytime if it exceeds more than 120 milligram, that is the time we must start therapy. This therapy, anything you want to say? Therapy could be in the form of
we have metformin and insulin. Preferably, all the patients they should be on insulin except those who have conceived on metformin like PCOD, and they can be continued on metformin. And after 12 weeks, they should be counseled for metformin effects and should be switched to insulin if possible. And if not controlled with metformin, again insulin can be
very true.
right. And in fact, all type of insulin except insulin glulicin, they are advisable. All basal insulin, NPH, glargine, degludec,
They're all category B now.
they are all category.
So insulin is the gold standard. Metformin well can be used in all those patients after counseling, a verbal or a written consent that they are not keen to go on insulin, they cannot take insulin because of social reasons, or they cannot afford, they cannot monitor, or they are from a rural background. So those patients, they can be on metformin because metformin has been found to be safe and it is approved as per our own DIPSI guidelines, and Ministry of Health says that after 12 weeks you can use metformin. But those who have conceived on metformin, what ADA says, we agree with that, IDPSC also, that we must stop metformin because many gynecologists, they want to continue metformin even after 12 weeks, but that practice has to be abandoned and we must stop metformin. Of course, metformin crosses placenta, but a lot of reviews and meta-analysis said, so what, even if it crosses placenta, because it hardly does any harm. So of course, insulin remains a gold standard, and choice of insulin, I think they have already discussed about that. He also mentioned that they are all category B. This is one of the review which we got published. We reviewed entire literature and we found even glargine is also safe like degludec. But these patients, if they are on insulin, well, they will have to be ideally on multiple doses or basal bolus 3 to 4 doses, or ideally on pump. So with that, we will stop short here. Thanks a lot for a lot of insight coming from Dr. Vipul and Dr. Girish, and thanks, Dr.
Thank you, sir. And thank you.
So I'd request Dr. Anshul to felicitate our experts. So for next sessions, we have debates, and now we have chairpersons Dr. Rohit Kapoor and Dr. Sanjeev Kapoor on case-based management in type 2 diabetes scenarios. No, this one is not there.
The case-based management. There is a debate which will be chaired by Rohit,
Okay.
Dr. Deepak Gupta, and Rohit. And what about Sanjeev? This lecture is not there. Okay.
So we have chairpersons Dr. Rohit Kapoor, Dr. Sanjeev Kapoor, and Dr. Deepak Gupta for the debate. The first debate is sulfonylureas still relevant in 2024-25. Over to you, chairpersons.
Good afternoon, everybody. Thank you, Rajiv. Thank you, Dr. Shalini, for inviting us. Today's era, we have a lot of oral antidiabetics beside insulin. We have sulfonylureas, our old friends in the management of diabetes, along with metformin. But lately, in the last about 20 years or so, we have many more molecules which have come up. So the question arises, are the older sulfonylureas still relevant in the practice, or they have to be discarded? So for this debate, we have two speakers. One is Dr. Anshul Singh from New Delhi and Dr. Meenal Mohit from Jaipur. Dr. Anshul Singh would be for the motion and Dr. Meenal Mohit for against the motion. So I invite Dr. Anshul Singh.
Thank you, sir. So I'll be talking about sulfonylureas and I'll be speaking for the motion. It feels like I'll be playing the devil's advocate here because sulfonylureas for the last, at least since the advent of SGLT2 inhibitors, have moved into obscurity. So what has driven the change in the adoption of sulfonylureas and the position in prescribing? First is, of course, there is weight gain which is associated. We talk about the risk of hypoglycemia, the concerns about CV safety, and there is advent of newer molecules like SGLT2 inhibitors, GLP-1RAs, which have cardiovascular benefit, weight loss benefit, as well as renal benefits. So sulfonylureas, we forget the past, they have been the first and potent oral glucose lowering agent that was available to us. It was the first sulfonylurea was found in the 1940s and 50s. And then we moved on from the first generation to the second generation drugs like glimepiride, modified release gliclazide, and gliclazide. So the first argument that has been made against sulfonylureas is that the durability and the efficacy. So when we talk about India and we talk about diabetes irrespective of, we can talk about the complications, the cardiovascular risk, but eventually it does remain a disease of increased blood glucose levels. The diagnostic criteria is still HbA1c, fasting blood glucose, and post-meal blood glucose, and we do need to bring the blood glucose levels down. When it comes to India, we know that Indians are grossly uncontrolled diabetes. Their HbA1c, this was a study which was published, and approximately 75% had an HbA1c of more than 7%, with approximately 40% having an HbA1c of more than 9. As hyperglycemia and the HbA1c progresses, we know that the risk of complications and the development of complications increases. So therefore, the first priority does remain controlling blood glucose levels. Amongst all the drugs, when we talk about their efficacy, the most potent drug that we have, right along with metformin, is sulfonylureas, causing consistently a decrease in HbA1c of around 1 to 1.5%. This was another meta-analysis which was published, and it showed, although it's not clear here, but it showed that along with metformin, in a head-to-head comparison with pioglitazone, with DPP-4 inhibitors, alpha-glucosidase inhibitors, sulfonylureas was the only drug, apart from metformin, which caused a consistent decrease in HbA1c level of around 1%. The same drug, this is the RSSDI wheel, and we know that diabetes prevalence in India is more. We need drugs, we need cheaper drugs, we need drugs which are more effective to bring blood glucose levels down. There was a Carolina, the paradigm shift occurred with the Carolina trial. Carolina trial was perhaps the first trial with an active comparator, linagliptin, with a proven CV neutrality, and we compared glimepiride with linagliptin, and it was found that when it came to the 3-point MACE, glimepiride did no worse than linagliptin. There was no significant groups even in the subgroups of the analysis of the control group. With the active comparator, no difference was observed. HbA1c reduction, so second point that is talked about is the durability of control. At least it is as good or as bad as linagliptin. So over a period of 6.3 years, as long as this trial lasted, Carolina, the durability of control with the glimepiride was as good as with the linagliptin. The same thing, as durable as linagliptin at 256 weeks. Initial reduction, in fact, was better with glimepiride, and lesser number of the participants required additional glucose-lowering drugs in the glimepiride group. Carolina trial has been just one of the many trials that have been published which have proven the safety of sulfonylureas, especially the second generation. The one trial that happened, that was the university group diabetes program, which showed an increased CV risk, was done with the first generation. Tolbutamide, chlorpropamide, these have been shown that they did increase cardiovascular morbidity and mortality. Ever since then, multiple trials, whether it's ADOPT, ADVANCE, UKPDS, TOSCA-80, recently, in fact, Lancet published the UKPDS 91, the 24-year post-trial data, and it also showed that as compared to the durability, it's as good, glimepiride is as good as any other drug. And Carolina was the first with active comparator head-to-head analysis. It showed that second generation sulfonylureas are CV safe. Advanced trial also, again, another shot in the arm for the glycemic variability at 5 years, and it showed that in the intensive arm, who was started on gliclazide in the advanced trial, had an HbA1c of less than 7 in 81.1% patients. The grade effectiveness, which compared 4 anti-diabetic drugs, which was insulin glargine, liraglutide, glimepiride, and sitagliptin, showed that glimepiride was in fact better when it came to glycemic durability as compared to sitagliptin. The comparison of various CV outcome trials which had the sulfonylureas in the control group. So it all shows that because the standard of care procedure was followed, the control group, this was a sub-analysis within the trials which was done, TICOS, SAVOR-TV, and EXAMINE trial. It showed that in the groups, in the control group itself, there was no worse, because there was non-inferiority trials. Placebo group with sulfonylureas did not perform worse than the active group. Now, this is a trial which was published in 2022 in the European Journal of Preventive Cardiology. They followed patients, 21,000 patients, and then separated into those who took glimepiride and compared them with the patients who did not, and with the matching was done, of course. And what they found was surprising, that long-term continuous glimepiride use was associated with decreased admission for heart failure, for acute cardiovascular events, as compared to the people who did not. And they also found that the patients who took glimepiride at a higher dose, the subgroup analysis showed that the patients who were on a higher dose of glimepiride, like 2 to 4 mg, had a better outcome as compared to those who were on 1 mg of glimepiride. The cardiovascular protective effect, they attributed it to increased epoxy icosahexaenoic acid, but it's something to be studied on. So another argument, this is also which has been made against glimepiride, is beta cell absorption. To end, it has been beaten that sulfonylureas with the time, the durability decreases, the effectiveness. Somebody who has an increased duration of diabetes will not respond to sulfonylureas, because sulfonylureas lead to beta cell exhaustion, lead to increased beta cell apoptosis. So gliclazide, this was a study, said gliclazide versus other sulfonylureas, only 7% patients had secondary treatment failure after 5 years with the gliclazide. So gliclazide is a second generation. We can presume, no head-to-head analysis has been done between gliclazide and glimepiride in the guide study as well. So both are comparable when it comes to long-term diabetes control. And hypoglycemia is also lower with gliclazide. So the newer generation sulfonylureas appear to be more effective in controlling blood glucose levels, have a better durability of control, are CV safe, and lower hypoglycemic events as compared to the previous agents. UKPDS, the beta cell exhaustion myth was done away with, that there was no solid evidence for beta cell exhaustion in the clinical setting over 6 years in UKPDS. When UKPDS was going on, primarily the patients were on sulfonylureas and insulin in the intensive arm, and none of those patients, in fact, after years, the 24-year trial has just been published, and it has also showed that it's still, the beta cell mass and the beta cell responsiveness is still persists to this day. Adding glimepiride, so another trial which was published, adding glimepiride to insulin and metformin in long-standing diabetic patients who had diabetes duration of more than 10 years responded well, and there was a decreased insulin requirement in such patients. So again, goes to show that despite we talking about beta cell exhaustions and how sulfonylureas are bad, long-term usage can lead to decreased insulin responsiveness or insulin secretion from the beta cells. It does not seem to be the case. Even after long duration of diabetes, the addition of glimepiride to insulin and metformin, it can be effective in lowering HbA1c as well as reducing the need for exogenous insulin. Another article published recently, this was 2023, and it was a Scottish population trial. Patients were evaluated, and it was a comparative retrospective analysis which was done in patients who are added on a second drug. The head-to-head analysis was between sulfonylureas, especially glimepiride, with DPP-4 inhibitors and pioglitazone. And it was seen that glimepiride was not worse off than DPP-4 inhibitors when it came to cardiac safety. It consisted of the population, the study population consisted of the entire Scottish population. This was done through health records and going retrospectively. And it was, the Cox regression analysis was adjusted for confounding factors, and as we can see, the hazard risk ratio is 1. When it comes to cardiovascular, the 3-point MACE, all-cause mortality as well as cardiovascular death. So therefore, we are not comparing. So the basic premise of this talk is not to talk against SGLT2 inhibitors or GLP-1 RAs, because they certainly have a cardiovascular benefit. What we are talking about is the place of sulfonylureas, whether sulfonylureas need to be replaced completely. But as the case is, it's not cardiovascular deterioration, it does not cause deterioration of cardiovascular markers. There is no increased hospitalization. And when we talk about cardiovascular, the tangible outcomes, the 4-point MACE was not worsened in patients who were taking sulfonylureas. The conclusion of this study was that irrespective of what the previous data suggested, because these were unadjusted data, sulfonylurea should remain a part of global diabetes treatment portfolio. And even the 2023 ESC guidelines, they've suggested and they've mentioned that sulfonylureas, although they do not have cardiovascular benefit, but they are at par with DPP-4 inhibitors and GLP-1 RAs and even SGLT2 inhibitors with no proven cardiac benefit. So as an add-on to drugs with a cardiovascular benefit, sulfonylurea should be used primarily because of their immediate efficacy as well as the fact that they're cheap. Hypoglycemia, another argument made. UKPDS trial, the sulfonylureas, patients who were on sulfonylureas had a lower hypoglycemic rate as compared to patients who were on insulin. Glimepiride was associated with fewer episodes of severe hypoglycemias. All the data of about hypoglycemia, severe risk that comes, and in fact did come, was from the older trials. The older trials were on the first generation sulfonylureas like tolbutamide, glibenclamide, or chloropropamide, and those, irrespective of what the group was, did have a increased cardiovascular morbidity and mortality, but glimepiride, the second generation drugs, do not. There was a lower incidence of severe hypoglycemia in patients. So a head-to-head analysis, there was at least a 5-time reduction in the incidence of hypoglycemia when glibenclamide was compared with glimepiride. In the guide study, in fact, the analysis was done between gliclazide and glimepiride. Again, gliclazide showed an even lower hypoglycemic incidence as compared to glimepiride. Now the question is where the current status of sulfonylurea is. So an article published by the International Task Force in the IGAM, it shows that it said that modern sulfonylureas may be continued with appropriate precautions, even with insulin. When used with premixed insulin, they can be given with the antipodal meal. Short-acting sulfonylureas can be added to a third meal just to decrease the post-meal glucose excursion. RSSDI also, although with caveats, has prescribed that sulfonylureas may be used in patients with BMI who do not have a high BMI. In fact, the glimepirides and gliclazides of the world are now proven that when used with metformin, if not, they do not cause weight gain and are metabolically neutral. In people who are not, so in elderly, it needs to be used with caution, of course, due to increased risk of hypoglycemic events. And in patients who are at a high risk of hypoglycemia, of course, sulfonylureas need to be avoided. But in a customized regimen, sulfonylureas certainly do have a role still. And of course, is the final argument in favor of sulfonylureas is the cost. 80% of the people with diabetes live in lower middle class, middle income countries. In fact, when we talk about India, sulfonylureas is still one of the most commonly prescribed drugs. Even in the US, in fact, most of the prescriptions, around 41 prescriptions, contain a sulfonylurea. Sulfonylureas have effective glucose lowering agents and are very cost effective. Sulfonylureas, it remains central to the management of diabetes across the world. Glucochronology of modern sulfonylureas, just because of the price being cardiac neutral, because they also do not cause weight gain, sulfonylureas sure make a case for their usage today as well. So the practical considerations when it comes to prescribing, practical consideration is of course the cost. Another article from 2013. So the major constraint, the major question that the patient had when taking medications was the financial constraints, was the affordability, because living in metropolitan cities, sulfonylurea sure seem like a risk that we are taking, but more than anything, what we need to focus on is that diabetes still, at the end of the day, we have targets to achieve for HbA1c levels, for fasting blood glucose levels, and sulfonylureas, because they're easily available, the price constraints are not there, sulfonylureas sure remain still a part of prescription. Diabetes, bigger challenge in the developing nations. Again, another Lancet article which just goes to prove and shows and prescribes, in fact, that sulfonylurea should be a part of the prescription and the anti-diabetic regimen that is being used. We do need to customize treatment though. Everything being said, we cannot prescribe sulfonylureas to every patient. Patients who have overwhelming need to control hyperglycemia at any stage, in those patients, sulfonylureas must be prescribed. It can be the first, second, or the third add-on after metformin. Patients who are at a lower risk of hypoglycemia and a normal or lower BMI. It should be given with caution in patients who are at a high risk of hypoglycemic events, especially the elderly. So the take-home message would be sulfonylureas are widely recommended and prescribed and are still prescribed, and not just in countries with who are in the lower middle income group, as well even in countries like Saudi Arabia. It is one of the most common prescribed drug. The absolute rates of severe hypoglycemic events with model sulfonylureas were low, and the Carolina trial showed that although there was a 3-fold increased risk of hypoglycemic events with glimepiride, none of these events were severe, as in not requiring a third-party help. And most of the international and regional guidelines still prescribe sulfonylureas, still recommend sulfonylureas to be used as a second or a third line drug. Thank you.
Thank you very much, Dr. Anshul. We have tried to convince a lot about sulfonylurea place. Now, Dr. Mainal, ball is in your court now.
So, very good evening to all of you, and thank you, Dr. Chawla sir and Dr. Shalini ma'am, for a wonderful conference. A very modest, indeed a very modest presentation by Dr. Anshul, so I really not feel like debating also. It's like somebody pleading to give me a place, some one corner in the house, please let me be in, don't kick me out. That was the message what I got actually in sitting in the audience. Nowhere he said that the molecule is better. Nowhere he said that the molecule is the best. Everywhere he simply accepted that yes, it will cause hypoglycemia, it will cause weight gain, it is cheap. Allow me one place, somewhere in the prescription, at least to the poor segment of your patients. So I really don't think I should fight it. But anyways, let me complete the protocol. So, please don't get slipped by his talk. I'm your saving fairy. Probably I can save you. Sulfonylureas still relevant? Probably not. एक शेर सुनाऊं? उम्र कब की बरस के सफेद हो गई, कारी बदरी जवानी की छटती नहीं. So this is about sulfonylureas. They are aged, old, outdated, but we are still fighting over it. Why? I don't know. Still, ma'am, you can fight it out in that case. Maybe you can stay with this statement by the last slide. So what are we talking? We are talking about beta cell dysfunctioning, beta cell exhaustion, beta cells overworked, in a scenario where we have more than 15 to 16 players on our card. We are still sitting and crying over one pathogenetic defect, when we are fully convinced that there are many more and many more significant. We are talking about incretins, we are talking about GLP-1 RAs, we are talking about imagglinin, we are talking about mitochondrial dysfunction, but we still want to play with a molecule which is just targeting one simple defect of incomplete insulin secretion from the beta cells. And those beta cells which are already dying, apoptotic beta cells, we are just fighting over them. So with so many pathogenetic defects, one molecule which is working only one simple way. We all now are multitaskers. We are talking of multiverse. So we have multiple ways of disrupting the defect. So let's not talk of only one defect. And coming to diabetes, is it hyperglycemia? How many of us define diabetes by hyperglycemia? It is a metabolic defect. We are talking of something like CKD, CVD, heart failure. It's a metabolic dysfunction in altogether. We are not targeting sugars. It is not hyperglycemia, and we all agree to it. Even Anshul agrees to it. So what are the targets? When you see a patient of type 2 diabetes, do you just try to maintain his sugars, or do you target his lifestyle, weight, then of course the ease, compliance, safety, his CKD, CLD, you ask for his lipid profile, and what you focus. You focus on whatever you achieve. Don't let any episode of hypoglycemia happen. Then patient should never come back to you with gained weight, because we know weight is another entity which is a mother of all metabolic illnesses. It will worsen your diabetes also. So sulfonylureas are probably an oversung hero. We are just talking about a hero, overdue, like the Rajnikant styles. We're talking of one molecule, oversung hero, the Robin Hood. Everything is done by sulfonylureas. Chadam Santosh is a pseudo satisfaction of achieving the target of HbA1c 6.5. And what are you talking? What are you costing to your patient? So don't do that. Let's be wise. We all know that diabetes begins here. By the time we are here, by the time we talk of sulfonylureas, the disease began way back, probably in utero. This is what we talked in the last session, pregnancy and diabetes. So probably the disease began here. And what we have, insulin resistance as the first marker, acanthosis, the first marker. So you have to start the journey somewhere much earlier. We can't wait for sulfonylureas to come into play. Of course, allow them. If they want, let them be there. But then when has to introduce that molecule in your prescription? Look here, Indian scenario. The disease begins quite early. Indian population has a whole lifespan to live with this. We are diagnosed at what age? 25 years, 30 years, young generation, early diagnosis. We have a huge lifespan to live with diabetes. If we start sulfonylurea, we will exhaust beta cells very soon. And then another concept, the YY paradox given to us by our own Dr. C.S. Yajnik. Indians are the population who have visceral adiposity. We are dealing with pancreatic fat. We are dealing with hepatic fat. We are dealing with early onset of complications. We have a much earlier episodes of retinopathy, nephropathy, neuropathy, vasculopathies. Why? Because we are the thin fat Indians. We have higher insulin resistance. We don't want beta cell dysfunctioning. We want to target insulin resistance first. So what about the CVD risk in Indians? So young Indian diagnosed with atherosclerosis, young MI. Most of the Indians have a high CV risk which is diagnosed much earlier. Again, thanks to our thin fat paradox. So we have high risk. We are not only at high risk, we are at high risk of everything. Sitting in that scenario, cardiovascular risk factors among the diabetes, Indian population, do one lipid profile in any of the young patient coming to your clinic. Nothing may be there, but LDL will be high. So we are dealing with a very high prevalence of dyslipidemia in the young population, even when they are non-diabetic. So in such scenario, would you target beta cells to make more insulin, secrete more insulin? Mind it, beta cells have no storage of insulin which they are hiding. They have to be made to produce more insulin, so they will be more exhausted. Don't forget that pathophysiological defect does not exist. Not so far at least. Now look at this. The beta cell dysfunctioning also occurs at a rapid progress in the Indian population, especially in the young Indian generation. Again, why so? Look at this, the normal glycemic control and the impaired fasting, impaired glucose tolerance, and then diabetes. The journey of beta cell failure is very, very high in the young Indian population. So the rate of conversion from pre-diabetes to diabetes, the journey is traveled very fast, rapidly. Why? Because we have people like, we have people like my fellows who are very keen on writing sulfonylureas. Please give them a place. Let me write a sulfonylurea. He is poor. Did you ask that you are poor enough to lose your beta cells? Are you poor enough to control your sugars with a molecule which will worsen your diabetes? Probably no. And then comes your beta, the mechanism of action. He said we are working on some potassium channels. We are closing the potassium channels. Yes, we are closing the potassium channels. This is how the sulfonylureas work. They work on the potassium channels, they allow the calcium inside, and they cause the insulin release. But does every sulfonylurea work in the same manner? No. It is only glyclazide, which he talked. So this is how it happens. You make the beta cells produce more insulin, and there is a tipping point. How long can the person work? How long can the beta cells work? There will be a tipping point. So from adaptive compensation, you make the patient enter a decompensated metabolic state. And this journey, you make it very, very fast. No, there is no pathophysiological defect that we are known of so far that beta cells have got a hidden treasure somewhere and the sulfonylureas are going to go and find it out. It is not like that. Your sulfonylureas are going to make your beta cells worse and rapidly. So this is the fact that there is insulin resistance, there is genetic abnormalities, and there are insulin secretory defects, which leads to hyperinsulinemia with endoplasmic reticulum stress, oxidative stress, there is beta cell failure, and finally diabetes. So this is the true paradox. This is the true paradox that for your patient you are having improving disease, improving glycemic control, better HbA1c. And what is the fact? You know in your heart before prescribing that what am I doing to my patient? I have already started a reverse journey for my patient. I cannot ask my patient for remission now. I cannot ask my patient for a reversal of diabetes now. I have myself set my patient on a non-U-turn journey. So this is the true sulfonylurea paradox. And that is why there is no durability. And Anshul accepted it, that yes, durability of sulfonylurea has been challenged. And this is the true durability study. And you find the sulfonylurea curve as the least curve. You can find here, the least curve is with sulfonylureas. We have the best curves with SGLT2Is, DPP4s, metformins. So we have the worst curve of durability with sulfonylureas. So when do we tell the truth? Do we really tell the truth anytime to our patients that this is what we are doing to you? Or we just prescribe, we assume he's poor. Do we ask that can he afford his health against not eating a sulfonylurea? Maybe few pennies more for a DPP4. Only GLP-1 is pricey. Rest all of the molecules are quite acceptable. And with all the government schemes, they are quite affordable also. So when do we tell the truth? We hardly tell the truth. Most of the patients don't even know that diabetes is actually a disease of cardiovascular renal complications. Most of the patients don't even come back for a follow-up because they don't know the seriousness of the condition. Most of the patients don't even know that there is a multimorbidity involved. It's a disease not of numbers but of metabolic derangement. So I don't force anybody. You talk, I will talk. You don't, I won't. This is what we follow in our clinics, overflooded, overburdened clinics. We have no time. And coming to your ischemic preconditioning, this is the only molecule which is specific for sulfonylurea receptor 1 channel. Most of your sulfonylureas are non-specifically binding to IPAC channels, sulfonylurea receptor 2 channels, and they are causing all damage to your ischemic preconditioning. And you know what? The greatest advantage of telling the truth? Nobody will believe you. So they don't know, patients don't even want to hear all this. Patients also want to hear, ye goli khana, kal subah tak sugars theek ho jayenge. Most of the patients come to you only when they have a surgery for cataract or a dental extraction. They want the results within a week. And my fellow colleagues like Anshul, they prescribe sulfonylurea and they give them quick results, forgetting the cost that they are paying. Financially, maybe a penny, but metabolically, a huge price. And these are the studies, they are the various RCTs which are showing right from UKPDS, Advanced, Tosca, Carolina. Carolina was quoted many number of times by Anshul. The real data of Carolina says that the molecule has a severe damaging effects on most of the cardiovascular mortality in terms of MI, stroke, the MACE points. So there are all data which are showing that sulfonylureas, most of the RCTs say that the molecule is not having any benefit over the other established newer molecules. This is just like saying a half glass full or half glass empty. He said the molecule is non-inferior. I say the molecule has no further benefit. So why use it? You can place it somewhere because it's bleeding, but should we? The meta-analysis of the various CV studies, again the same results. They are showing that this molecule has nothing better to offer, except that, as madam said, old is gold. But it has not proven it to be gold. It is old, I agree. Meta-analysis of the further studies of sulfonylureas versus DPP-4 inhibitors, again showing the same data, but my way of saying no proven benefit over the other DPP-4. Coming to your hypoglycemias, can you see the vast difference of the curve, the rate of hypoglycemias with sulfonylureas? 82% lower risk of hypos with the DPP-4s. The huge gap. And we all know it clinically. I don't need this data. We all know. The only hypoglycemic OHA, sulfonylurea. None other is a hypoglycemic. Other than insulin and sulfonylurea, no molecule causes severe hypoglycemia. You compare the molecule in terms of hypo, weight gain, or a rescue medication in all group of patients, below 65 or the elderly patients. Again, you will find that without any rescue medication, hypoglycemia and weight gain are the two biggest challenges of sulfonylurea that we are facing in every prescription wherever there is a sulfonylurea. So SGLT2I and the weight loss. Now you can compare the benefits of SGLT2I. Of course, we know that the molecule gives us a significant weight loss. If you combine up SGLT2I with a DPP-4 inhibitor, it's a bihormonal disease, we have accepted it. So there is in fact an improvement of the insulin-glucagon ratio. So the combination, if you think metformin is the first molecule and second is say DPP-4 inhibitor, Anshul said at least give it a third place. I say why? Give SGLT2I the third place, at least your glucose-insulin ratio will improve. So the newer agents, they are much better in 24-hour glycemic control. So even your glycemic variability is targeted. With sulfonylureas, there are significant GV variations, glycemic variations, hypo, hyper, hypo, hyper, the ping pong effect. Why do you want a ping pong effect? Let me have a smooth curve. We are targeting what? CGMS, TIR, point in range, time in range. So let me have a smooth control with a very newer molecules which are much better and giving me no fluctuations. Now we know that this is a CRM disease. It is a CKD, heart failure, cardiovascular, other metabolic complications. So we all know, I'm just running because my time is ticking. So we know that it's a cardiometabolic disease. It is not hyperglycemia alone. Now look at this table quickly. The only molecule with the maximum yellow, orange, reds, the sulfonylurea. Rest of the molecules you will find quite safe. So again, the European guidelines are saying, go with SGLT2I, go with GLP-1RA as a monotherapy if above target, add another molecule. With metformin, add another molecule. In patients who are drug naive, in patients on metformin already, again add another SGLT2I or GLP-1RA. Continue monotherapy again or add another molecule. No guideline has recommended a place for sulfonylureas here. If you look at this, again this is a glucocentric or patient-centric approach. You will find for the weight management, we need molecules. For the glycemic management, you might find a place for sulfonylurea here, but otherwise for cardioprotection, for your renal protection, liver protection, for all pleiotropic benefits, you choose other molecules. The ADA guidelines, where do you find sulfonylurea in the whole curve? Can you see sulfonylurea written anywhere? I can tell you, it's written once here, somewhere. So again, coming to the complication-based targets, you will find no guideline mentioning sulfonylurea here somewhere, maybe, probably not. Okay. So none of the guidelines are now coming to your RSSDI wheel. Yes, RSSDI wheel has sulfonylurea at two places on the top position, first position. When money is involved and when very high glycemia is involved. But again, with a word of caution, otherwise sulfonylureas always have a position much below. We are still respecting it. It is in the curve. We are not throwing it out. but the position has to be justified. Again, another way of showing the same curve, you will find the role of sulfonylurea somewhere very, very back when you are dealing with only very poor strata or with a patient with very high glycemia, not accepting insulin, you talk of sulfonylureas. So guys, clean your specs, high time. It's time to clean your specs. And let's begin. We are not talking of sulfonylureas. We are more bothered of weight, hypoglycemia, durability, and poor compliance. So boss, there is a difference. Healing versus curing. You are wrong if you say the two are same. You need to heal the patient. This is not the treatment. So guys, thank you so much. But if you are focusing on HbA1c, Anshul is correct. But if you are focusing on weight, cardiometabolic complications, you are missing the mark.
Thank you, Dr. Minal, for emphatically stating that sulfonylureas are...
Come.
Ma'am, first of all, the topic was not the superiority of
Dr.
SGLT2 inhibitors and GLP-1 RA.
Dr. Anshul, you can come to the stage.
Talk, boss.
And now it's time for you to give
Come
rebuttal.
here and talk, Anshul, it's all yours.
So, the talk was not about proving the superiority of SGLT2 inhibitors and GLP-1 RAs. I conceded that. I specifically brought out points which ma'am extensively talked about. Weight gain, I spoke about that the newer agents do not, especially when combined with metformin. Ma'am spoke about the CV safety, which I showed Carolina trial. So if sulfonylureas need to be thrown out because the fact that they're not CV safe, they're as safe as linagliptin. When we talk about, just the third point ma'am made was hypoglycemic events. So in the Carolina trial, which ma'am also spoke about, there was a threefold increase, but none of the hypoglycemic events were associated with increased CV risk. They were not severe enough. And lastly, of course, they're cheaper. My point still remains, it's cheaper. And if sulfonylureas need to be thrown out, probably DPP-4 inhibitors as well.
All accepted, all said and done. You began your talk very nicely, very beautifully, and we accept your position. Sulfonylureas are not being thrown out. The judges are here, the house is open. We are not throwing out any molecule. We are just judging the relevance, the prioritization.
Yes, absolutely. So I am just talking about sulfonylureas in the wheel, that's all.
Correct.
And that's what I was here. Exactly. So
true, but time to change.
Even
true, but time to change. Yes.
Yeah, and we all have to know that our patients cannot achieve glycemic control without the help of sulfonylureas, because HbA1c reduction achieved by these newer molecules like SGLT2 and DPP4 are to the tune of 1% only, and we have huge gap to cover. And Dr. Anshul has one more point that he has highlighted, that if you compare sulfonylurea with SU, then the mortality and morbidity, hypoglycemia, CV safety of SU is much better than the insulin that you have highlighted in UKPDS or equivalent to insulin. So we have a medicine which allows us to cover the glycemic goals, targets, without having to use a drug like insulin, which is more cumbersome to use. So I think we should, as Dr. Minal has highlighted, that we should first focus on drugs which address multiple pathophysiological pathways of the diabetes, and if our glycemic controls are not achieved, then we should proceed for sulfonylurea therapy.
So I think so. Some patient suppose is coming with the blood sugar value fasting 225, and however is not having any comorbid on any ASVD. And then Dr. Minal, I'm just asking you then about this case, and he's just a medium class person. So in this case, you don't have ASVD, any risk factor, and what should be your first choice in this case?
I'm so sorry. Sir, the class does not count anywhere. It is only about sugars.
Because GLP-1
Yeah.
are the only
Here
molecule
I
which
am
are very,
focusing
very
on blood
high.
sugar value.
So yeah, and if it is a new patient, drug-naive patient, again first-line therapy is always metformin and not a single,
Obviously.
not a monotherapy. You can't send a patient of
Yeah.
fasting blood glucose 225 or HbA1c of 12 with a monotherapy of metformin and say come back. We are not treating in anticipation anymore. You have to hit hard. So yes, it can be a triple drug therapy to start with, and it may have a sulfonylurea or may not have a sulfonylurea, again depending upon the individualized personal patient personality and profile. If the patient is a very lean thin patient and you think of insulinopenic condition, I will still not prescribe a sulfonylurea maybe. I will ask for a C-peptide first and maybe straight away start with insulin. If it is a well-built, mediumly built or obese patient, then yes, we can consider metformin with a SGLT2I, with a sulfonylurea, or with a DPP-4 inhibitor, with LSM, and maybe follow back with a week or so, 10 days or so. Because a drug-naive new patient with a fasting of 225 is nothing new. But these are the patients who don't even know that they are having diabetes.
You want to make out sulfonylurea absolutely out of your practice?
Not out of practice, sir, but a cautious word that when it is needed, please write it. If it is not needed, don't make it your priority.
Okay. So that's a position statement you want to say. That it's not a priority, but depends upon what are the patient and what are the associates and ASPD or whatever the factors you have to see. Dr. Anshul, what do you say?
Sir, so
Do you agree with her?
Sir, so I to an extent do agree. So I'm not.
Yes or no?
Yes, I do.
You want to agree with her? All right.
I do.
So that's the main point basically because
so again, with a caveat.
barring the 2 points like you are more stressing on this weight and second is hypoglycemia and third is the cost. 3 factors if we say it's with the sulfonylurea. If we say the best is glycoside, sustained releases, I know one of the best, even KidGo guidelines, they say even CKD, that is one of the safest sulfonylurea you can use. We know this glycoside SR is really fantastic drug and molecule we all are using. And Danish registry has shown much of the cardiovascular safety for glycoside even in that. So I'm not bothered about using this sulfonylurea. Glycoside XR is one of the best sulfonylurea to be used. Dr. Meenal, you agree with glycoside XR? Okay, you say yes or no?
Yes.
Yes, oh, all right. So with glycoside you are happy. So other sulfonylurea you are not happy, but you are ready to use glycoside in many of the situations in CKD and even some CV, not a risk with glycoside XR. So barring 3 facts only, cost, hypo and weight. That's only 3 things you want to say. I'm not going to use for this, otherwise SGLT2, DPP4, they are far better. Dr. Anshul, you are ready with the use?
Sir, so that was what I was trying to say. So even in the Carolina trial, one thing that was overlooked was
you are just focusing on one trial, Carolina.
No, no,
try to understand. Try to understand. You are focusing only one trial, which is a non-inferiority trial, and in that we have seen that glimepiride is non-inferior.
I'm not talking about CV safety. I'm talking about early reduction of HbA1c and early glycemic control, which was better with sulfonylureas, especially.
Well, that's another point. When you use empagliflozin, you see the TIR. When you do the AGP, within 24 hours, you find a reduction in TIR, better TIR, with even on the within 24 to 48 hours. It has shown with the SGLT2 inhibitors. They are very quick in controlling TIR within 70. And DPP4, they take more than 72 to 96 hours to control this TIR. So that's another point when you talk about how effective, quick SGLT2 should be now. Okay.
Sir, if you are talking of a quick control, please do not forget the prolonged hypo. A hypo
that's another point. That's why.
And your patient is in the ICU for at least 72 hours.
That's why.
So
this DPP4 and SGLT2, we know. DPP4, they are safety for hypoglycemic drugs, and SGLT2, they are non-insulinopenic drug. I am not bothered about hypoglycemia. Correct. So I mean, we have to make some position statement, ultimately, finally. You both are very correct, and you really troubled everyone to think what to use, what not to use. So, Dr. Sanjeev, make the position statement. No.
I think both the speakers did very well in proving their points. And in any patient, depending on the situation, I think both the molecules, most of the time we have to use.
Absolutely true, sir. So most of the molecules, all the molecules are still with us, but use them judiciously. Thank you.
That's the position statement.
So our next session is 16-year-old adolescent with obesity. And for the session lead, we have Dr. Lily Rodriguez from Hyderabad. She is director at Stride Hospital located at KPHB Colony and professor at Maheshwara Medical College, and she is principal investigator, global and national clinical trials. I invite you, Dr. Lily Rodriguez, ma'am, and we have experts, Dr. Sunil Kohli and Dr. Saurabh Srivastava.
So the topic given to us is 16-year-old adolescent girls with obesity. Thank you at the outset, Dr. Chawla and Shalini Jaggi, both are not here, I think. This is going to be a very interesting discussion. We have the two experts here, sitting out here, and I would like to just introduce the topic. And talking about the prevalence of adolescent girls with obesity, between the 1980s and 2014, the prevalence of obesity among adolescent females in the United States increased from approximately 10% to 21%. And coming to the Indian scenario, one study found that 23% of adolescent girls were obese and 14% were overweight. And another study, 23.9% was the prevalence. A study in the urban areas of India, which used WHO criterion, showed that overweight obesity among early adolescent school girls was 12.9% and 9.9% respectively, and reported that the extent of overweight and obesity was 17.63% and 5.1% among affluent Bengali schoolgirls. So female adolescent faces medical, psychological and reproductive health challenges. Early intervention is imperative and preventing short-term and long-term morbidity as well. The study showed that escalating incidence of overweight in early adolescent schoolgirls in small town of our country is a critical health issue. The study suggests also that greater risk of overweight among the schoolgirls identifies a group for targeted intervention that promotes increased physical activity and decreased consumption of energy-dense foods to control the escalating prevalence which ameliorate our future generations. So, obesity in adolescent girls can have number of health consequences: gynecologic and obstetric complications, pregnancy complications, metabolic syndrome, cardiovascular disease, eating disorders, cardiovascular issues, orthopedic conditions, and psychological risks as well. Now, we have the case study. Name AB, 16 years old female, presenting with weight-related concerns and fatigue. History of presenting illness, struggling with weight gain since childhood. Despite efforts to diet and exercise, she has fatigue, joint pain, SOB on walking, low self-esteem, and social withdrawal. And as for her past medical history, she was obese, her BMI was 38, she had PCOS, asthma and depression, which was already diagnosed. And as for her family history, mother was obese and has type 2 diabetes and father has hypertension. Social history, she was sedentary. As per her lifestyle, spends 4 hours per day on screens, consumes high calorie, high fat diet, lives in an urban area and reports bullying and social stigma related to her weight. On physical examination, her height was 168 centimeter, weight 100 kg, BP 130 by 90, waist circumference was 102 centimeters. She had acne on her face and back, hirsutism, normal respiratory system and cardiovascular on exam, and as far as her lab results were concerned, fasting was 110 milligrams, LDL was 135, which was high, LFT mildly elevated ALT, and hormones were also estimated, and she had elevated testosterone and she had irregular menstrual cycles. So now we have questions to our experts. We have Dr. Sunil and Dr. Saurav Srivastav here. The first question, may I ask Dr. Sunil Kohli, on screening and diagnosis recommendations, what would you suggest us?
Thank you so much for bringing up this topic, because I think obesity in childhood and adolescence is an important subject. And primarily, I think the prevention should be our target. But as Dr. Lilly pointed out, how do you screen them? As a matter of fact, the AAP recommendations are to start screening of children from age 2 or 3 onwards till 18 years of age, at least once a year, and then look at their BMI based on age and sex. You look at the nomograms for their percentile weight and divide them by, overweight is defined as between 85th percentile to less than 95th percentile. Above the 95th percentile is considered as obesity, and severe obesity is defined as going 120% above the 95th percentile weight. There is also questions of what we call as central adiposity, and if you notice that this particular girl has a waist to height ratio over 0.6. It's a shade over 0.6, suggesting high central adiposity, as waist to height ratio is more than 0.6 or more, therefore indicating a very high health risk or greatly increased health risk, as we've seen in this particular individual. So you can also screen for comorbidities. You can screen for diabetes by doing a glucose tolerance test, where you see the response to 75 grams of anhydrous. We've always talked about glucose tolerance test as using 75 grams of glucose, and I must point out here, it's 75 grams of anhydrous glucose. Most of the laboratories use glucose monohydrate, in which particular case it should be 82.5 grams. And I think that's something that should be clarified. She's already an asthmatic, so when you screen for asthma, we're doing a spirometry. That's very easy to do. You now have oscillometric methods of doing spirometry, which are easier to do. And of course, you screen for liver disease by doing a ALT test and an ultrasound abdomen, which can be repeated on a yearly basis if need be. So these are the general screening procedures for children and adolescents.
Yeah, you have rightly highlighted the point that children for 2 to 18 years of age should be screened for obesity, especially those who have high risk from the point of view of family history and their own weight. And they should be monitored regularly to prevent the complication of obesity and other metabolic disease. Thank you, Dr. Sunil. And we move on to the next question to Dr. Saurabh. What are the health concerns in this case? Would you recommend you tell us?
As you have very well seen in the case, that the first and foremost thing which is there is obesity, and all the health concerns are related to obesity itself. So first and foremost is obesity. As the patient had high testosterone, you have said that the fasting level blood glucose is 110, and patient has raised ALT also. So there's a possibility of metabolic fatty liver disease, and then patient had insulin resistance also, LDL is high, so patient has dyslipidemia. PCOS, you have already mentioned that patient had PCOS, patient had asthma, and patient had depression, and patient carries a cardiometabolic risk. Father is hypertensive, mother is diabetic, so she carries a risk of having diabetes and hypertension in the future life, and also as the weight is high, so patient had skeletal issues or chances of osteoporosis and all in the near future.
Thank you, Dr. Srivastav. Yes, obesity is the mother of all other metabolic disorders. We need to definitely, these are the concerns that you have rightly said. Now, the next question to Dr. Sunil. How will you manage the PCOS and obesity, and how will you monitor them?
So actually, obesity among children and adolescents is a multifactorial problem, and you have to address all particular aspects of it. It actually starts in childhood, and there are studies that have shown that a patient's emotional regulation ability at age 3 impacts their likelihood of developing obesity by age 11 or 12. So it's actually, we need to tackle or prevent obesity at the earlier ages. In this particular patient, she's already 16 years old and obese, so we are now going in for secondary. But I think insofar as the primary prevention of obesity among children and adolescents is concerned, we should start targeting them early and take on preventive measures early. They've said that children at age 4 who can delay their emotional gratification are have less likelihood to become obese later. So treating children to high calorie stuff as in childhood leads to greater chances of the developing obesity later. Cold drinks, junk food, and there are studies that have shown that you could say either taxing high calorie drinks and junk food at a government level reduces risk of obesity. In this particular patient who already has PCOS, has asthma and obesity, will require a multidisciplinary approach. We not only require a general physician who will take on the overall responsibility, along with the help of a psychological counselor or a psychiatrist to manage the problems of depression. We need a nutritional expert, possibly an exercise physiologist to help her develop the right exercise modules for her, promote activity. Lifestyle changes not only are emotional support and psychological support, lifestyle changes also involve nutritional support and also an exercise regime. Reducing screen time. She, as Dr. Lilly pointed out, that spends 4 hours a day on screen. That itself affects not only her exercise capabilities, but also affects sleep. So good sleep regulation is also important for managing obesity. So counseling with a trained counselor, improving their self-image, because she has poor body image problems, so she will need counseling to improve her self-image. Oral contraceptives for PCOS. We may use metformin for her insulin resistance. Of course, treatment of asthma with appropriate steroid inhalers. And spironolactone because she has hirsutism. And that also affects, especially in young girls, it affects their self-image. And that may need spironolactone for maybe 6 months to a year, or depending on how she responds to treatment, it may require. And of course, last but not the least are anti-obesity drugs. And there are only 4 classes of drugs that are approved in adolescent at her age that you can use. One is orlistat, second is liraglutide, third is semaglutide, and fourth is the naltrexone combination with bupropion. So these are the 4 classes of drugs that can be used if she doesn't respond to other lifestyle measures, diet and exercise, and of course the treatment for her comorbidities. And last but not the least, which is very, very rarely used in adolescents, is bariatric surgery. That should remain the last resort for those who don't respond to any other treatment.
Yeah, thank you, Dr. Sunil. As you rightly said, it is a multidisciplinary approach. And I would just like to conclude that it is morning, Dr. Neeta spoke about obesity, and she said it is a spiritual journey for the, especially for the girl, because what is first and foremost in her mind is that, low self-image, and she finds it very difficult to fight her obesity. So the treatment goes along with the spiritual counseling. The counseling part has to go side by side with all the rest of the treatments, and only then she will sustain her loss of weight probably, and other diseases that are associated with this index case. So, Dr. Saurabh, what mental health support would you recommend for this case?
Actually, you must see that family is the core for any disease, and family support is the first and foremost thing which is required. If family eats burger, the child will also eat burger. So junk food is to be avoided in the family also. The support of the family is to be there. And what sir has already told that the reward thing, that if you do this, you will get this much. So this should be avoided. Open communication should be encouraged, because bullying and these things affect the self-esteem. So open communication with the psychological counselor and psychiatrist is required for building up the self-esteem. Peer support again is a very important thing, because after a certain age, when the person is in the adolescent age group, he mixes up more with the peers, and the bullying incidents also occurs in the peers. So peer support is very much required, and he or she should have some person who is his peer, is or her peer, who supports him in his developing the self-esteem. Then sleep, which is very important. Right now we are overcoming the sleep. We work late in the night and just forget to sleep. So sleep is very much important, because sleep, proper sleep and sleep hygiene develops, the chances of obesity are less. Then again, eating should be sacrosanct. You should learn how to eat. You should not eat much. You should try to consume whatever is being eaten. Then the self-esteem, body positivity is required, and a multidisciplinary approach is required, in which you will require the family support, the peer support, the psychological counselor, and the friends, and the psychiatrist. All of them will support her in his developing a proper, getting a proper mental health.
Thank you, Dr. Saurabh. That brings to the end of our questions, and we still have 2 minutes. The questions are open. If there's any question.
I think we clarified things very well, or
yes,
it was too boring for you to understand. But in any case, I think what is important is, as Dr. Srinivasan, Dr. Lilly pointed out, I think we need to take obesity among children and adolescents seriously. And it's, obesity among children is a matter of, as they say, their genetics, their cultural background, the country where they come from. Because when a lot of places in Punjab, unless the child is plump, you say, nahi ji, lissa pa gaya. It's the cultural background, the family, the community where they come, and if there are any places for them to play around. Because in a lot of places, there are no open areas for the child to go out and play. When we were children, there was no screen time. We were out the whole day, and we exercised a lot more. But the children of today spend more time on computer screens and others, and therefore they're more prone to develop obesity. And I think that's something that we need to prevent. as he pointed out, that reward system needs to be, diminished or discouraged. The more emotional regulation should be sort of encouraged at an early age. And as yesterday, I think some of the speakers pointed out that hedonistic eating should be discouraged. So there are multiple factors. And thank you, Dr. Lilly. You brought out a very important topic.
Thank you so much. And also eat slowly. This has to be told to them. Don't gulp it immediately, without biting it. Mindful eating, yes. So thank you everyone. We come to an end of this session.
So here we have last session on breaking the complexities of type 2 diabetes management with solid evidence of IGLAR Lixi. And for that, we have a speaker, Dr. Vipul Gupta sir, from Delhi. And chairpersons, Dr. Lily Rodriguez, yes. So,
Pointer, can I have the pointer?
Good evening, everybody. Thank you once again, Dr. Chawla, for giving me this opportunity.
Dr. Vipul, we would like to introduce you first.
Oh, sorry.
So, Dr. Vipul is MD Medicine and FACP USA, and is consultant physician and diabetologist, founder and medical director of Gupta Ultrasound and Heart Care Center since 1997. Awarded the Legend in Internal Medicine 2017 trophy from Times of India. Awarded Fellowship of Research Society of Study of Diabetes in India 2019. And he is chapter treasurer Delhi RSSDI from 2022 to 2025. Executive Committee member, API Delhi State Chapter, and many publications in national and international journals and chapters. So I invite Dr. Gupta to deliver the talk.
Thank you, Chairpersons, for the introduction. Thank you, Dr. Chawla, for giving me this opportunity. This is the second last session. I'll try to keep it very brisk, and we'll have ample time for discussion, because we all know that type 2 diabetes is a progressive disease, and once we have exhausted our options of oral anti-diabetic agents, we have to jump on to basal insulin, which is now a known entity. And with the presence of so many basal insulin, we are able to control at least the fasting. But what next? Once we are not able to do justice to the patient and we are not able to reach the targets, the fastings are controlled, but maybe PP are higher, HbA1c is still higher, then we need to up-titrate the dose either to premixes or to a co-formulation. But now we have another molecule in our armamentarium where we have a combination of basal insulin, the time-tested golden glargine,
and a GLP-1 analog which has come into the market. We'll discuss the management of type 2 diabetes in that context. We'll see what is the evidence regarding this molecule and how we can use and bring it into our practice, and why this is a molecule which addresses most of the pathophysiology of type 2 diabetes. We all know that the unmet need with the complex regime in type 2 diabetes is a rule with so many OADs available, and the insulins which are available now may be having a complex insulin regime. There are multiple injections which are not easy to take, which have a reduced flexibility with meals. They disturb the daily routine of the patient, and there is also a risk of hypoglycemia. These all factors impact the lifestyle of the patient. He has to take the diet at a particular time. The insulin dosage has to be, addressed along with the meals. The physical activity is curtailed because he cannot do the routine activity. To counter all these problems, a new molecule which has come to the stage is a combination of insulin glargine 100 and lixisenatide, which is a GLP-1 receptor agonist, and which has become recently available in India. We'll be talking about this molecule. The brand name is Soliqua, 100 milligram, 100 IU of glargine and lixisenatide. Why this molecule is important and how this is, technically or scientifically a good molecule for the treatment of type 2 diabetes. If we see the Omnius octet, it covers 7 out of 8 pathophysiological defects. If we see the GLP-1 RA, we all know they secrete glucose-dependent insulin from the beta cells. They decrease glucose-dependent glucagon release, increase satiety by acting on GLP-1 receptors at brain. They reduce gastric emptying, so they cover these 4 pathophysiological defects. And we all know the mechanism of action of insulin. It decreases hepatic glucose production by decreasing gluconeogenesis, increase glucose uptake in the muscles, decrease lipolysis. So except for the kidney, which is covered by the SGLT2 inhibitors, all other 7 defects are covered by the combination of basal insulin and GLP-1 RA. And with this, if we see, the effective HbA1c reduction is achieved, fasting and postprandial both are controlled. It addresses multiple pathophysiological defects, as we have seen. More people achieve glycemic targets with once a daily dosing. The weight neutrality or weight benefits are there. Lower rates of hypoglycemia even when you are trying to intensify the insulin, and with a improved GI tolerability, even with mono components, this component gives a better tolerability. And with the global guidelines also recommending the combination injection, the ADA 2024 approves the combination of basal insulin and GLP-1 receptor agonist as a potent glucose-lowering action and a less weight gain and lesser hypoglycemia with intensified insulin plans. ACE 2023 also says that failure of OAD or GLP-1 RA individually, if the glycemic targets are not met, then a basal insulin should be added alone or with a combination of GLP-1 receptor agonist. Also, ESD 2022 also advocates the combination of basal insulin and GLP-1 RA for greater glycemic lowering if for a lesser weight gain and lower rates of hypoglycemia. So all the bodies also advocating the use of this molecule. It becomes more scientifically relevant to use this in our clinical practice. So now let us see what is the evidence we have got for I-glargine lixi. There are multiple evidences in the terms of meta-analysis, real-world studies, phase 3 studies. We'll focus on certain key studies which are important to our clinical practice. That would be along with combination of IDEC as part, which is the co-formulation of basal insulin and as part, compared with I-glargine lixi. The name of the study is SOLID-D. This was a 24-week open label phase 3 study, and the adult population of type 2 diabetes with BMI less than 40 were the included population from HbA1c 7.5 to 11. They were all randomized in 1:1 into glargine lixi and IDEG as part. This was a 24-week study, and the endpoint was to see the non-inferiority in HbA1c and the change from the baseline. And there were certain secondary endpoints as well: superiority in the change of HbA1c from baseline, superiority in change in body weight from baseline in 24 weeks, along with more people who were able to achieve HbA1c less than 7 without body weight gain, without hypoglycemia. There are certain exploratory secondary endpoints were also there to see the change in fasting plasma glucose, change in 7-point SMBG, proportion of participants reaching HbA1c target less than 7 at week 24, and the dose of insulin, which is also very important to see. And the safety endpoints were also seen: the hypoglycemia, the level 1, 2, 3, and any other serious side effects as well. If we see the basal characteristics, they were all matched. The more important is to see that the duration of type 2 diabetes in this was close to 9 years in both the groups. If we see what was the results at the end of 24 weeks, the HbA1c reduction was superior in the group who had IGLAR lixi. From 8.53 baseline, they reduced to 6.58, a reduction of 1.88, whereas in the group IDEC as part, it came down from 1.68 to 6.83. So it was non-inferior also, and statistically superiority was also established because of the presence of lower HbA1c. If we see the body weight reduction from baseline in 24 weeks, it was seen that there was a reduction of 0.3 kilogram in the group of IGLAR lixi, whereas there was a weight gain in the groups who were on IDEC as part. If we see the other exploratory key secondary endpoints, the number of patients achieving HbA1c less than 7% in 24 weeks, that was 72% in IGLAR lixi as compared to IDEC as part. Without body weight gain, again more in IDEC, IGLAR lixi, and patient without body weight gain at 24 weeks with no hypoglycemia, again 26.5 versus 13.4. So if we see all the exploratory endpoints, they fared better in the IGLAR lixi group as compared to the IDEC as part. If we see the 7-point SMBG from baseline, this is the baseline 7-point SMBG, and if we see after 24 weeks, the IGLAR lixi fared much better in terms of reduction of 7-point SMBG than the IGLAR IDEC as part. If we see the postprandial glucose reduction, all the meals, breakfast, lunch, dinner, they were all faring much better in this group. Similarly, if we see in the mean insulin dose, the requirement was much less in the IGLAR lixi group, 0.4 units per kg in the IGLAR lixi group as compared to 0.48. So there was a reduction of dose also, around 20% of dose reduction in the patients who were on IGLAR lixi. If we see the adverse side effects or the hypoglycemia, any hypoglycemia, level 1 or level 2, all were consistently lower in the IGLAR lixi group. There are no patients in any group who had level 3 hypoglycemia, and any hypoglycemia was also lower in the IGLAR lixi group. Yeah. So if we summarize the SOLID-E, which was a head-to-head study of IGLAR lixi, it demonstrated non-inferiority and statistically superiority in HbA1c reduction, superior weight benefit, more patient achieving a composite endpoint of HbA1c without hypoglycemia, without weight gain, lower risk of hypoglycemia, and no unexpected safety concerns. So this should be considered as a valuable option as an advancing therapy in patients who fail or uncontrolled on OADs. Now we look at another trial, which was the comparison of individual molecules
Iglar-Lixi combined with individual molecules, the glargine 100 and lixacinatide in patients who were suboptimally controlled on OADs, the Lixil O study. Again, this was a phase 3 study which has allowed 1170 patients, 30-week study, patients with type 2 diabetes, again 1:1, randomized into either Iglar, Lixi. All these patients were on a background of metformin. Iglar alone, glargine, Iglar, Lixi, and lixacinatide alone titrated to 10 microgram and then 20 microgram. Again, the primary endpoints were same, non-inferiority in HbA1c at 30 weeks and change from baseline at 30 weeks. If we see the main points, the HbA1c reduction was higher in the Iglar-Lixi group, fasting and 2-hour postprandial reduction was much better, 7 SMBG. If we see the Iglar-Lixi was much better, and individual targets, more number of patients were able to achieve a HbA1c less than 7 in the Iglar-Lixi 74% patient as compared to the individual molecules. And similarly, the weight change was also better from glargine in Iglar-Lixi, though slightly better in patients who were taking alone lixacinatide. So, if we see that Iglar-Lixi complements both Iglargine alone and lixacinatide effects to achieve a meaningful HbA1c reduction close to near normoglycemia without increase in either hypoglycemia or weight gain, as compared with glargine alone and with a lower gastrointestinal side effects as compared to lixacinatide. We talk of another study which is very important study. This is a study, Solimix study, which is a phase 3 randomized controlled trial comparing Iglargine Lixi with twice daily bi-aspart. This is the premix, if we see the premix with Iglargine Lixi. These are the population of type 2 diabetes who more than 1 year, more than 18 years of age. Again, this is a 26-week study, 1:1 randomization into Iglargine Lixi and bi-aspart 30, and total of 887 patients, and more importantly, 182 patients were from India. And if we see what were the results, it was superior to bi-aspart 30 in change in HbA1c from baseline to week 26, 1.3% HbA1c reduction as compared to 1.1. If we see the body weight from baseline at week 26, there was a reduction of 0.7 kilogram in Iglargine Lixi as compared to weight gain in the bi-aspart group. Similarly, the number of patients achieving less than 7% higher in Iglargine Lixi group, and the patients who were achieving HbA1c without weight gain and without hypoglycemia were again higher in this group as compared to bi-aspart. Total insulin dose was also less. Baseline insulin dose in Iglargine Lixi was 26, and at week 26 it's gone up to 39.7, whereas in bi-aspart it went up from 33 to 58. So there was also a lesser dose of insulin which was required in Iglargine Lixi group. If you see the incidence of hypoglycemia, again, any hypoglycemia level 1 or level 2, all were less in the Iglargine Lixini group, and incidence of nocturnal hypoglycemia was also much less as compared to the patient who were on the bi-aspart 30. So there was 68% lesser nocturnal hypoglycemia, because this is another very important component when we are titrating basal insulin. We are afraid of patient having nocturnal hypoglycemia, but if we are able to titrate a dose and the lesser chances of hypoglycemia, nocturnal hypoglycemia particularly, we can do justice in reaching the fastings easily. So if we see the efficacy as compared to bi-aspart 30, better glycemic control with weight benefit, lesser hypoglycemia, fewer daily injections, similar proportions of adverse side effects, and it is an efficacious, simple and well-tolerated alternative to premix bi-aspart 30. So we have seen that this, as compared to the individual molecules, glargine or lixacinatide, premixes or a co-formulation, this is a better alternative and gives you a better HbA1c reduction with lesser hypoglycemia, with weight reduction and no adverse side effects. So this, as compared to those molecules, stands better in terms of all the parameters. Now let us see how this molecule is available and how we can use and titrate and shift the patient from the other available or the molecules which the patient is already on. This is the pen which is available, which has a combination of iglargine and lixisenatide. A single pen has 100 units of glargine and 50 microgram of lixisenatide. They are present in a fixed ratio. 2 units of glargine, if you deliver, will give patient a 1 microgram of lixisenatide. This is a 3 ml pre-filled pen which has 300 units of glargine and 150 microgram of lixisenatide. And there are 40 doses step. We can dial from 1 unit each time to reach the 40 units. And how we can adjust the dose, it is all again depending upon the fasting blood glucose levels, the median of last 3 days, and the dose is titrated every week in the insulin naive patients on OAD or GLP-RA. Or patients who were on insulin glargine less than 20 units, you straight away start from 10 units of glargine. The dosage are calculated in terms of glargine. If you give patient 10 units of glargine, he'll get automatically 5 microgram of lixisenatide, and then you can titrate the dose every week depending on the mean SMBG fasting for last 3 days every week, and you can reach the target maximum of 40 units titrating every 1 unit or 2 units. If the patient is already on glargine more than 20 units, you straight away starts from 20 dose step. That will give patient 20 units of glargine and 10 microgram of lixisenatide. The maximum dose per day of lixisenatide is 20 microgram, so which also makes a 40 units of glargine and 20 units of lixisenatide. Titration algorithm is based on what we titrate normally with the basal insulin. If the fasting blood glucose is more than 140, you can increase by 4 units. If it is between 100 to 140, then 2 units. 80 to 100, no change. Less than 80, you decrease the dose. And it is preferable to give the molecule or the injection subcutaneously once a day, 1 hour prior to the meal. Same meal every day is the most convenient time of one convenient meal you can choose, which is convenient to the patient. And in case of missed dose, the injection can be given within 1 hour to the next meal. And weekly dose adjustment to be based on the last 3 days of the fasting blood glucose level. So to summarize, if we see the usage in specialized population, this can be used in elderly patients. No dose adjustment is required depending on the age of the patient. It can be used in mild to moderate renal failure. The studies have been done. It should not be used in EGFR less than 30 ml per minute, because the studies have taken the patients above 30 ml per minute of EGFR. Any can be used in patients with hepatic impairment. No dose adjustment is required in patients who are hepatically impaired. Pregnancy, this is not recommended and should not be used, and if the patient becomes pregnant, this has to be discontinued. So this molecule has good efficacy in the patients who are high-risk patients or patients who are fragile patients, and you can easily use this molecule in all those patients. So this gives you a flexibility of one injection in patients who are already on OAD failure and where the basal insulin has not worked. This combination would give you a flexibility also, and the control of both fasting and postprandial. Once a daily injection, and has to be taken 1 hour prior to the meal. So this combination injection is a synergistic once daily injection of basal insulin glargine, as I told you, and a prandial GLP-1 receptor agonist lixisenatide that provides a efficacious fasting and postprandial glycemic control. SOLID-E trial also showed us that this is a simple, well-tolerated treatment for better glycemic control with added body weight benefits and lower risk of hypoglycemia as compared to IDEG part. Solimix was the trial with the premix insulin, showing us that it is an efficacious, simpler, well-tolerated molecule which provided us a better glycemic control with weight benefit and lesser chances of hypoglycemia as compared to bi-aspartate 30. Thank you. Thanks for the
Thank you.
patient.
Thank you, Dr. Whipple. In short time, you have covered all studies and trials
connected to IGLAR Lixi. We are already late. I think one session is remaining. So one or two quick questions we will take from audience. Any comment or question? I will ask one question. In your experience, what is the best placement of this injection, where we should place it? Instead of basal insulin, we should give this, or on failure of basal insulin?
So what I have used in my clinical practice is upgradation from a basal insulin. Once we have used basal insulin and we are able to titrate a fasting, but the postprandials are not controlled and the HbA1c still stays out of range, then from shifting to basal to a premix, you can give a up titration from basal insulin to a basal plus GLP-1 RN, taking off the DPP-4 inhibitor if the patient is on. I have placed it in whatever in my clinical practice in those patients.
But I think it's such a good molecule. If cost is no inhibition, then instead of basal glargine, we can start this molecule also.
We can do that, but I think best would be to give, if the fasting is the only component which has to be titrated, then probably giving basal insulin would be a better option rather than safely, because maybe some side effects of GLP-1 RA would deter you to titrate the basal insulin to a up titrate to a level where you need to give HbA1c or a fasting target. Those molecules will all continue. If the patient is on DPP-4, that has to be taken off because that will not have any added advantage if the patient is on GLP-1 RA. But all other molecules, if required, they have to be all continued.
Thank you, Dr. Gupta. Thank you very much for the excellent talk.
Thanks.
We have one more session. Yeah.
So last session of today, it's about optimizing muscle nutrition, the dynamic duo of high protein nutrition with prebiotics and probiotics. So the speaker is Dr. Sunil Gupta. He is a senior diabetologist, CEO and MD of Sunil Diabetes Care and Research Center at Nagpur. He was National President of DIPSI 21-22 and National Treasurer of RSSDI 21-22. He has many rewards, 21 orations, and he has to his credit 6 consecutive Best National Research Paper Awards. And there is a list of awards. He has 211 articles and book chapters and abstract presentation in international and national journals. He has conducted total around 3,000 programs in last 29 years. Executive editor of Indian Diabetes Education Journal of RSSDI 2022 onwards, and he is a National EC RSSDI 2016 to 19, Associate Editor of International Journal of Diabetes in Developing Countries and the Journal of Clinical Diabetology, and also he is principal investigator in 2 phase 2 clinical trials and more than phase 3 clinical, 25 phase 3 clinical trials. So over to Dr. Sunil Gupta.
Respected Chairperson, thank you very much for this wonderful introduction. Somehow I am realizing in the last few days, whenever I go to any meetings, Chairperson started introducing me in little more detail. Otherwise, most of the time, you know Dr. Sunil Gupta well. He doesn't need any introduction. Dr. Gupta, you can start your topic. So that is 3-line introduction most of the times, but today morning also as Jabalpur. And we had a wonderful introduction. Thank you very much for that. But for the paucity of time, I'll be little brief in this presentation. I have a declaration that this
particular set of slide belongs to
Zydus Nutrition, some wellness division. And there is no conflict of interest as when it comes to honorarium and I think here in this for this session. I have been requested by my elder brother, Dr. Rajiv Chawla, to speak on this, and we are going ahead with this. So, optimizing muscle nutrition, but I should be thankful to Dr. Rajiv Chawla, Shalini, and the whole team for allowing me, for stimulating me to read this particular topic little in more detail. So, we have around 20 slides, and I'll be very quick in this. Optimizing muscle nutrition, the dynamic duo of high protein nutrition and prebiotics plus probiotics. So now they are trying to say that we have some data available where it is not just the high protein diet, but to use the protein properly, as well as to avoid the possible adverse events of very, very high protein diet. If you use prebiotic and probiotic in combination, possibly we will be able to have better tolerance as well as better outcome as far as role of protein is concerned. So I feel everyone knows that 73% of the Indians, they are protein deficient. Over 90% are unaware of the daily protein requirement. 85% believe that the protein consumption may lead to weight gain. There are health issues associated. You have weakness, increased hunger. Anyone coming to you with any vague symptom where you can't correlate, I feel we should be thinking of having some nutritional deficiency. So much muscle atrophy, increased susceptibility to infection, reduced immunity, mood and cognitive impairment, brittle hair and nails, very common in diabetics, and increased risk of stress fractures if you have hypoproteinemia or if you have low protein intake, even if you don't have hypoproteinemia. Adequate protein intake recommendations from various platforms. So we have India has the lowest average protein intake in compared to both the other Asian nations as well as the developed countries. The recommended dietary allowance for protein is described as a minimum quantity which is necessary to prevent the loss of lean body mass. Very specific. It is the minimal protein intake required to fulfill essential amino acid needs to maintain nitrogen balance and prevent the muscle mass depletion. And that's why RDA recommends that for an average, instead of remembering 0.83 per kg, I always remember 1 gram per kg body weight for any healthy adult. And if you are elderly person and if you have some deficiency, maybe 1 to 1.5 gram per kg body weight. So around 25 to 30 gram with each meal in more than 65, and around 55 gram per day for those who are around average 65 adult and less than 60 or 65. Now this is a wonderful data here, and this picture has shown how does the muscle mass changes as you age. And even I realized then that possibly I must have lost almost, I was trying to calculate while reading this, that how much muscle loss I must have had when I'm just 60 this year. So peak muscular mass and strength are achieved between the age of 20 to 30. So muscle mass actually strengthen and the peak is achieved by around 20 to 35. Maybe you can take a higher range of 35 because most of us here are 35 plus. Muscle loss can begin as early as at the age of 30 and may progress at a rate of 3 to 8% per decade. So every 10 years, you are likely to lose a muscle mass around 5% in all of us above 30 years of age. This rate of decline accelerates significantly after the age of 50. So once you are 50 plus, most of us now, so the loss is around 1 to 2% per year rather than 3 to 8% per decade. So it's almost doubled. So 1 to 2% of muscle mass loss in every one of us who is more than 50 years of age. More than 10% of the young adults across most of the ethnicity may suffer from sarcopenia. And what are the things which affects this muscle mass? The lifestyle habits. So maybe reduce physical inactivity, physical activity, alcohol consumption, and smoking and lifestyle modification plays a major role. There could be some genetic factor. I'm not going to go in detail of a prevalence of chronic health conditions in Indian adults. So if you see irritable bowel syndrome, says they are almost almost 5 to 7%. Prevalence of obesity, overweight, everyone knows, varies from 14% to almost 57%. 5 to 6 out of 10 women, so almost 50% of the women are having abdominal obesity, and osteoporosis, osteopenia, almost 20 and 48%, and hypertension, almost every fourth person. Diabetes, everyone knows. I feel this figure is little less. We have around 10%. So what are the factors which affect the muscle health? And do we have a data to say that there is a role of nutrition in building up these muscles apart from exercise? So let us understand the function of the muscle protein. Muscle protein serves as a primary repository of the amino acids and provides the free amino acids for the following functions. It causes reincorporation of the amino acid into the muscle protein, energy production through the oxidation. It needs to be converted into glucose whenever you have hypoglycemia. So gluconeogenesis of the glucose regulations, you need protein. Synthesis of the immune components, most of the enzymes, most of the plasma proteins, hormones are being produced through protein, and amino acids is required. And what are the factors which are influencing the muscle development is the muscle contraction during the exercise. That's why exercise makes a major role. You have it stimulates the muscle growth by triggering the repair. So when you go for regular structured exercise, monitored exercise, you actually stimulate repair. And it also strengthens the muscle fibers. It also, when you give amino acid through diet, there is essential for muscle repair, growth, and highlights the importance of dietary protein. So dietary protein will help in muscle repair and growth. So it is both. You need to have a high protein diet, monitored diet, as well as the monitored exercise. What are lifestyle factors which can stimulate the muscle loss? So if you have a lot of excess of alcohol consumption, which may decrease the muscle protein synthesis. Cigarette smoking again will have the same impact. Insufficient protein intake by any mean, either dietary or maybe through some disease, because of some disease. There is increased muscle destruction, protein degradation, excess calorie intake, overweight, obesity, decreased muscle function and quality, and vitamin D deficiency. So excess alcohol, insufficient in poor intake, obesity, vitamin D deficiency, cigarette smoking, and of course the sedentary lifestyle. All of them will cause decrease in the muscle protein synthesis, increased degradation, decreased muscle function and its quality, and loss of skeletal muscle mass, strength, and the function. So now protein, calcium, and vitamin D on the musculoskeletal health. After the age of 35, joint undergoes degenerative changes due to diminished tissue repair capacity. Optimal musculoskeletal health is critically dependent on the synergistic role of this protein, calcium, and vitamin D to maintain the structural integrity and functional capacity of the bone, muscle, as well as the joint. So now we are talking about bone, muscle, and joint. All of them, they require good amount of protein, enough calcium, and vitamin D. What does protein does? Protein and amino acid play a crucial role in muscle growth, physiology, and metabolism. Protein constitutes approximately 50% of the muscle bone volume and around 1/3 of its mass. It provides the structural matrix of the bone. So it's a part of the structural matrix of the bone. Calcium is a dominant mineral within the bone matrix, contributes to the strength of the bone. It works with protein matrix to form a robust skeletal structure. And vitamin D is involved in differentiating, proliferating, and the growth of the muscle cell. It modulates the muscle contraction and strength by controlling the calcium homeostasis within the muscle tissue. And that's why for a good muscle health, you have to have, and bone health, you have to have more protein, calcium, vitamin D3 well in place. So gut wellness and its role in nutrient absorption. What does gut wellness means? What is the importance of gut health? Gut health, if it is good at maintaining a good gut health, may significantly reduce the occurrence of functional gastrointestinal disorder. Most of the patient coming to a gastroenterologist with want of any complaint, most of the diagnosis will say functional GI symptoms or disorders. Persistent digestive systems such as gas, bloating, constipation, very common in our people with type 2 diabetes, can alter gut motility and microbiota balance. Over time, these changes may contribute to development of IBS or irritable bowel syndrome. If you maintain a good health of the gut, it can have effective digestion and absorption, improve the gut motility, stable intestinal microbiota, effective immune status, and absence of GI illness. So good health of the gut microbiota will help in good metabolism, host protection, and the immune system development, as well as the gut muscle access, which improves protein digestibility, gut permeability, short chain fatty acid production, reduction of the inflammation, and all possible benefits to the gut and the overall health. Now this is the most important part of the presentation about the role of prebiotics and probiotics and its impact on the gut health. We understood that we are deficient in protein. We understood we have vitamin D deficiency common. We understood that the muscle actually causes the gradual degradation of muscle occurs. And now we understand how do we maintain all this with the help of prebiotic, probiotics, and the protein intake. So what is prebiotic? Prebiotic defined as a non-digestible oligosaccharide undergoes transformation by beneficial colonic microorganisms, which is called a probiotic, to potentially offer the health benefit to the host. So prebiotics nourishes other beneficial bacteria by supporting their growth and production. So prebiotics actually gives a better health to the probiotics. So it inhibits pathogens, reduces allergy risk, enhances immune system, alters the gut permeability, modulates probiotics, production of the metabolites, enhances calcium absorption, and decreases protein fermentation, and reduces the harmful protein digestion, thereby decreases the effect on the toxic metabolites. Now, what is the effect of probiotics? They are the live organisms. Everyone must have gone through this lecture, so I'm not going to go too much in detail. But here they are talking about lactobacillus and bifidobacterium that are beneficial bacteria that are present in the digestive system. They have its impact on positive impact on immunomodulation, normal gut microbiota, and metabolic effects through various mechanisms which we have understood through prebiotics also. Now, pre and probiotics have their role in the protein absorption and the muscle integrity. Now this is a new thing which possibly we'll be understanding in a better way. The probiotics, they regulate intestinal microflora, induces host digestive protease and peptidase activities, improve the small peptides and amino acid absorption, and reduces harmful protein fermentation, and ultimately influences the dietary protein digestion and utilization. So to have a better protein absorption, digestion, and utilization, if you have a healthy pre and probiotic constitution, possibly it will help the patient in long term. So prebiotics, they modulate the gut probiotics, which leads to formation of a key beneficial metabolites such as short chain fatty acids and inflammation and immune markers. So what are the highlights we have about the Bacillus coagulans unique IS2, which is a probiotic? So I'll talk on this Bacillus coagulant unique IS2. This is a probiotic, and it has its action on the adult gut health. It elevates the abdominal pain, abnormalizes the bowel movement, mitigates overall symptoms in adult related to GI, maybe IBS or functional constipation, manages acute diarrhea sometimes, and also a small intestinal bacterial overgrowth. It also causes muscle strength by augmenting the muscle strength and optimize the protein absorption in the athlete population. And Bacillus coagulum unique IS2 plus the whey protein concentrate improves the muscle power and plasma in the amino acid and the amino acid levels. That means if you give probiotic along with the whey protein, it might help in better protein absorption, and amino acid levels might be helpful. Now, whenever you come out with such molecule as a supplement or a drug, you have to prove that that this molecule is safe for the body. That's called as NOAEL. That's a no observed adverse effect level. And they have tried this particular molecule of the probiotic by very high dose in animal models, and they have found its safety, robust survival rate, rigorous toxicity studies have been done, no treatment related changes, no adverse event, and there is the absence of bacterial infection in this population. What are properties? So it thrives in both aerobics and anaerobic environment, ensures survival and survival through through the GI tract, It produces various digestive enzymes, aids in aiding in the efficient nutrient breakdown and absorption, and it also has antimicrobial properties in the system. It also helps in vitamin synthesis, capable of producing vitamin, contributes to overall nutrition balance, and probiotic potential, has promising probiotic potential, offering benefits to the GI health. So this is about the Bacillus coagulum unique SIS2. Now, do we have any clinical evidence that this molecule is safe and efficacious? So this is a data of around 138 patients, and these are the patients who are resistant trained males, so they are already on a rest and exercises, and they have given 20 gram whey protein along with 2 billion CFU of Bacillus coagulum unique IS2, and the other group is placebo group, and they have found there is increased plasma free amino acid by around 16%, which was statistically significant. Branch chain amino acid increased by maybe isoleucine, leucine, and valine. They also have increased statistically significant compared to placebo. There is improved exercise performance of various muscles, whether it's exercises which you go and do in gym, so maybe leg press or bench press or vertical jump, all the efficacy of the muscles have gone up. So supplementation of this Bacillus coagulum unique IS2 with whey protein significantly increased the BCAA absorption, branch chain amino acid absorption, and improved the muscle power in lower body, suggestive of a positive impact of the probiotic on the protein utilization and exercise performance in patients who are on resistance training exercises, and they are all male. Now, Bacillus coagulum unique IS2 in functional constipation, so around 100 patients, the functional constipation, they have found the result in the, as compared to placebo group, increased number of bowel movements, statistically significant normal stool consistency, relief from the symptoms of incomplete evacuation, painful defecation and abdominal pain, and they have shown that they have spontaneous stool per week and consistency, everything was improved. So it has demonstrated effectiveness in decreasing the symptoms of constipation, indicating its benefit in patients of functional constipation in adults, which is common in diabetics. Dietary fiber and health, I feel everyone knows that we have insoluble and soluble fibers, and here you have non-fermentable or fermentable. In fermentable you have viscous and non-viscous dietary fibers. They are the remnant of the edible portion of the plant cells, polysaccharides, lignin and associated plant substance, and these fibers are not digested by the human digestive system but are fermented in the colon. So they have a highlight on this fructo-oligosaccharide FOS, fructo-oligosaccharide, which is a prebiotic and which is a water soluble. Sweetness is around 0.3 to 0.6 times of sucrose, highly hygroscopic, so it forms a higher viscosity than the sucrose, thermally stable, highly stable in normal pH, and resistant to hydrolysis in the GI tract. Once you take this FOS, it undergoes fermentation by various enzymes, promotes the growth of certain microbes like bifidobacteria, and this reduces the colonic pH. It inhibits the growth of proliferation of harmful bacteria like E. coli, Clostridia, Streptococcus, and Proteus, and reduces the production of the toxic metabolites such as ammonia and other things. So it has a prebiotic effect, it has relief of the constipation, facilitates mineral absorption, modulation of the immune system. And the clinical evidence you have, this is a small trial of 10 patients, and these patients were constipated nursing home residents, and they have shown that there's increased fecal dry weight per week by around 42%, increased fecal count of this bacteria, bifidobacteria, significantly, decreased Clostridia, decreased use of enema, daily fecal outcome is found to be increased with the, and the total bacteria, and bifidobacteria output was also found to be more. So FOS positively influences the gut bacteria by promoting the growth of bifidobacteria and reducing the plasma TBARS concentration. This TBARS is basically a fecal bifidobacteria lipid peroxidation index. It's a kind of index which is supposed to be reduced after taking this, which has found to be significantly reducing. And there's a small study again in 9 patients who are on the peritoneal dialysis, and they again have found that there is a improved type 1, that is nut-like. See, now fecus, your feces are also being defined. nut-like feces to the sausage-like feces. This I have seen for the first time. So improved type 1, that is nut-like, to type 4, that is sausage-like feces. So feces quality have improved, and colonic transit time is also improved. So it is effective in increasing defecation frequency and improving the fecal feces appearance. FOS can be viable alternative to other laxative. So finally, this is my final slide, Chairman Sir, that the muscle loss begin as early as in 30s and can accelerate significantly due to lifestyle factor like physical inactivity, malnutrition, and bad dietary habits. Musculoskeletal integrity is maintained by interplay between the protein, calcium, and vitamin D3. While the primary role of protein is to maintain muscle mass, calcium is vital for bone structure and muscle function, and vitamin D enhances the calcium absorption, bone health. Maintaining a healthy gut microbiota and effectively managing gut health issue like IBS, constipation, bloating, these microbiota may play a major role, and high protein supplementation, including the prebiotic and probiotic, as well as physical activity, may mitigate muscle deterioration and enhance the muscle function by improving muscle protein synthesis. Pre and probiotic, including Bacillus coagulum unique IS2 and FOS, have been shown to improve nutrient absorption and support the muscle protein synthesis and overall gut wellness. I feel with this I stop here. Thank you very much for the patience listening.
Thank you, Dr. Sunil, for a very interesting talk. And we all know that gut microbiota is the in thing, is the research. A lot of research is going on this. They have attributed it to every disease in the body.
And they're trying to, make it a very, very important part of the treatment. So I think he has mentioned very effectively the use of high protein diet along with pre and probiotics so that the absorption becomes better and the protein which is required is properly there for the muscle strength. So if any questions from the house or any comments, most welcome. Sir, how do you suggest to give 1 gram of protein, especially in the vegetarian people? Say if a person is 60 kgs, so 60 gram of protein, how do you divide 20 grams with each meal? And simple things, how do you, give 20 grams? 20 grams is...
I feel that's the job of most of dietitians we do, and I'm now missing out Kavita here. I'll be referring to such patients to my wife, but of course you can divide it either into 15 gram 4 times a day, or you have total 5 meals, 3 major meals, 2 small meals, and you can accordingly take a decision. That part is again very tough. I have never counted protein. Even you must not have ever counted protein in your our own diet. Forget about patient's diet. So I feel, but this is all being done by most of the dietitians, and then they calculate. But this is very true that almost 70 to 80% of our population is not taking enough protein. That is true. That has been proved in our own studies, as well as there's one more thing, that vegetarians still, especially, are still having very low amount of protein intake. So that's important. So we have to have extra supplements, and this seems to be a little promising. And a lot of patients, they are coming with either partial gastroparesis or chronic constipation. I feel we can simply think of trying such things in such patients.
I think it's time that we should start teaching our patients simple things, like 1 ball of dal has almost 8 grams of protein.
Sir, I do something else. I ask them.
We can tell them to take 3 balls of dal in a day, so that makes it 24 grams.
With the major meal.
1 roti is 3 grams.
Yes.
So,
sir.
Yeah.
Sir.
Fine.
Sir,
you can't give 3 bowls of dal. There'll be a lot of lentil carbs, so you'll be increasing the carbs. And dals are poor biological value proteins, so we need to give proteins from dairy, from nuts, from lentils.
I'm just giving an example. I'm just giving an example that we should start telling them about all this.
For chronic constipation, what we recommend is, there are 2-3 things which can be done. One is very high, good amount of fiber diet. So you should start your diet with the fiber. So first you take full bowl of salad and something, then you start your meal. Once you start your meal with fiber, most of the patients will have can be relieved with chronic constipations. So fiber diet is very, very important, high fiber diet.
Thank you. Thank you, Dr. Sunil. If no more questions, we can conclude this session. And over to organizers. Let's give a big hand to Dr. Sunil, last session.
So nice of you. Thank you. Thank you, sir.
Before we close, I think every good thing comes to an end. So has 11th CMRI International Symposium in Diabetes. We are extremely thankful to the entire faculty, starting from our international faculty, Professor Mohammed, Professor Inash Sheltout, Professor Colin, Professor Edi Mata, Professor Dandona, Dr. Antonio, and our national faculty, Professor Das, Dr. Anup Mishra, Bansi, Dr. Shashank, Dr. Sunil Gupta, I must tell you, came all the way. Since last evening he has been traveling. He just came for this 20-minute lecture from Jabalpur to Delhi, and now he'll go back to Nagpur. So this is the amount of regard for we have each other. Yeah, so it has been a great feeling. I'm sure all the faculties have done their best. It couldn't have been better. And the last session we could count, it could be around 7,500 people. I think that at least speaks the quality of deliberations done by our domestic and international faculty. Both the days, virtual went superb. We had close to 1,300 logins for our ASD program. For yesterday ACE program, we had close to 800 live streaming, and we had 120 people, 100 people around for the physical. For the first time, we did ACE CMRE symposium under the banner of ACE EPEC. ACE EPEC is now a reality. Shashank is chair, and we 5 people are Bansi, me, Sahai, Shalini, Amit. We are all executive members, and we plan to take ACE further to the greater heights, to disseminate their knowledge in this part of the world, their educational modules, their certification programs, and try to have more people getting into the FACE program. That is what is the idea. Although that chapter India existed for close to 10 years, but it was dormant, it never came up. So with Bansi and energy of all these people, it went very well. So I think at the end, I must express my gratitude to all the delegates, those who have been there with us, almost 2 days virtual. Yesterday we did the DIPSI symposium, was excellent, Sunil. We missed you there because you were traveling in this. Hema said, and Bhavtharni sir was extremely happy and called us, all of us, that it was a wonderful program. So it all went very well, and all the delegates, both in virtual as well as in the physical mode, those who have been with us for close to 2 days, we express our gratitude to all of you, because you make any conference a success. Without you, it is not possible. Then the industry, mainly people like USV, Novo, Lilly, Snowfy people, Aris people, Torrent, Lupin, they have all been part of this sport to us. And our RX team, Hardik, Rahul particularly throughout, Ankit, and their entire team has been a wonderful sport. And toward the end, I must express our gratitude to the hotel management also. They have been very, very cooperative right from the beginning. And Dr. Meena deserves a special applause. She is there with us since Friday, 3 o'clock, all session till 9 p.m. on Friday. On Saturday, 3 to 10, she was with us, and since 9 a.m. she is here. So we have wonderful faculties. They are all our colleagues, actually. They are also been a great sport. And thanks a lot to everyone. Dr. Shalini, I express my gratitude. Again, as a colleague. We have been working together for close to 10 years. This is the 11th program. Not that I'm expressing thanks to her. She has been part of the program, but we have been working very, very close to each other with a very good understanding. So if I miss certain names, I'm sure I'll be excused. Those are non-intentional. So at the end, we declare this conference closed. And because, as I said in the beginning, every good thing comes to an end. So has come 11th Symposium, International Symposium in Diabetes by CMRE, ACE, ASD, and DIPSI. Now we have 4 partners in this conference. That was, I think, an achievement over last year. Thanks a lot once again. And again, if we have missed anyone, I am sure we stand excused. Thank you very much. Our own fellows, DNBs, they have been with us again yesterday also in the physical program. All of them have been a great sport. Thank you very much. They want to come here because there was only 4 weeks time. They wouldn't have managed visas and all that. Otherwise, they actually wanted to come. Thank you, thank you, thank you, thank you.